रजत सर, आप दो डिवाइस से लॉगिन है, हो सकता है इको होगा सर।
Yeah, I'm logging out from one.
सर अभी आपका ना एक एक से लॉग आउट हो जाओ सर।
कर रहा हूँ, कर रहा हूँ. Now it's okay. Now it's okay.
यस सर।
Okay. So we start exactly at 1. Do we start
यस सर।
exactly at 1?
यस सर। यस सर। यस सर।
Yeah, okay. We have Dr. Sumana Chatterjee with us. She's joined. How's it?
सर हर रिकॉर्डिंग इज हियर।
Okay. So Swapna is joined. Purvasha, I think, will be joining. Dr. Chintan, I believe, is not there. That's what I might got the message yesterday. Dr. Pallavi Joshi is here. Hi, Swapna. Hi, Pallavi.
Hi, Dr. Rajat.
Hi Rajat, hi Swapna.
Hi, Dr. Purvasha.
Purvasha, welcome.
Hi. We have how many speakers? 8.
Dr. Chintan, I was told, is not available. Others के बारे में मुझे information नहीं. There are total 7 talks supposed to be there. Dr. Chintan's, who's I think not there. So probably we'll be having 6 talks. So Purvashi, you have a lot of time. You can take your
No,
time.
I don't want that.
Hello and very good afternoon to one and all present here. I am your host Shweta, and we have our first session in Hall C for the day, which would be on spectrum of ocular surface diseases. And our chairperson would be Dr. Namrata Sharma, and moderator would be Dr. Rajat Jain. Over to you, Dr. Rajat Jain.
Thank you, ma'am. So at the outset, let me welcome all the audience who are listening to this amazing course in which we'll be discussing about the spectrum of the ocular surface disease. I welcome my co-speakers, Dr. Sumana, Dr. Swapna, Purvasha, Dr. Chintan, and Pallavi, and Dr. Shilpa. So without wasting much time, let us have the talk of Dr. Sumana Chatterjee. I believe she is not here, but she has sent us our recorded talk. So can we have her talk, please? Okay, Dr. Sumana is here. Welcome, Dr. Sumana.
A very good afternoon to everyone. I want to thank South Asian Academy of Ophthalmology and Dr. Sharon D'Souza for giving me this opportunity to talk on ocular allergy, what's new in our armamentarium. So to start with, let us introduce the term acute ocular inflammatory disease. It is a wide spectrum of T lymphocyte-based disorders that range from dry eye syndrome to ocular allergy. So ocular allergy is a type 1 hypersensitivity response that affects 15 to 20% of the population. What happens in sensitized individuals, T2 cells release pro-inflammatory cytokines that stimulate the immunoglobulin E production by the B cells. Immunoglobulin E become membrane-bound to mast cell, leads to mast cell degranulation and release of preformed and newly formed mediators. Early phase of the allergic cascade begins within seconds to minutes after exposure and clinically lasts 20 to 30 minutes. Late phase begins a few hours later with epithelial infiltration of inflammatory cells like neutrophils, lymphocytes, basophils, and eosinophils, and that leads to continued inflammation, persistent symptoms, and tissue damage. So this is in nutshell is the picture what happens when the allergen gets attached to the antigen presenting cells. So allergic disorders are the inflammatory response of the conjunctival mucosa, also affecting the cornea and eyelids. The known varieties are seasonal, perennial, atopic, vernal, and giant papillary conjunctivitis, and they may be immunoglobulin E mediated and non-immunoglobulin E mediated also. So the supportive diagnostic testing, apart from the clinical evaluation and thorough history taking, can be aeroallergen skin prick testing on the forearm. It is recognized as positive when resulting wheel is at least 3 mm larger than the negative control. When we order for the serum specific immunoglobulin E measurements for the aeroallergens, if the patient is taking antihistaminic medicines that cannot be discontinued, if the results of the skin tests are ambiguous, and to complement the results of the previous skin prick test. In this new article on ocular allergic test and biomarkers on the ocular surface, published in 2020, it includes the tear test for evaluating the concentration of biomarkers in tear and ocular surface test for assessing the expression levels of mRNA biomarkers on the ocular surface. The biomarkers can be eosinophilic inflammation biomarkers, Th2 inflammation biomarkers, giant papillary biomarkers, etc. This is how that both the tests are being done, and the ELISA and PCR array, they are used to assess the results. Coming to the treatment, the therapies, if tailored to the patient-specific symptoms, give the best results. We should avoid the allergen. Cold compresses help by conjunctival vasoconstriction, thus reducing the hyperemia and edema. Lubricant eye drops help to dilute and flush the allergens and inflammatory cells from the tear film. Wearing large wraparound sunglasses can be used to reduce contact with aeroallergens and improve photophobia. The conventional treatment we all know, but antihistaminics and mast cell stabilizer cannot suppress the activation of free neutrophils and eosinophils, and long-term use of glucocorticoids can cause serious side effects. So the first line treatment is a dual activity agents which provides immediate relief of antihistamines and the prophylactic benefit of mast cell stabilizer. Among the available many, the olopatadine have the most popular role. The steroids reduce the inflammatory cytokine production. The ester-based steroid, loteprednol etaponate, is the preferred agent. The ketone-based topical steroids are used for the severe cases. And among topical NSAIDs, ketorolac tromethamine was approved by the US FDA for the treatment of seasonal allergic conjunctivitis. The topical mast cell stabilizer only, like sodium promoglycate 2%, they can be best utilized on a prophylactic basis. Coming to the immunomodulators, they are the topical calcineurin inhibitors like cyclosporin A and tacrolimus. They are steroid-sparing agents in chronic allergic conjunctivitis, which becomes steroid dependent. They suppress the T lymphocyte proliferation and inflammatory cytokine activity, thereby inhibiting the histamine release from mast cells and basophils and reducing the eosinophil recruitment. The immunotherapy involves downregulation of the T2 response and upregulation of regulatory T cells that produce inhibitory cytokine, leading to a reduced end organ response to allergy exposure. There are two varieties, the subcutaneous immunotherapy and the sublingual immunotherapy. They are useful in treating patients with recalcitrant on chronic allergy not responding to regular treatment. What it does, it changes the phenotype of T cells from Th2 to Th1, as happens in when tolerance develops as a natural course of the disease. They can also be applied in children, but it requires a strict regime of desensitization, and so it may be difficult to treat children below 6 years of age. Desensitization consists of two phases, an induction phase that lasts 5 to 8 months and a maintenance phase that lasts 3 to 5 years. The new kid on the block are the biologics, which block the underlying inflammation pathways bonding with specific biological molecules, but they are still not approved for treatment of allergic eye disease. The most common ones are the omalizumab, which is a humanized monoclonal antibody binding with the unbound IgE, and dupilumab, which is an interleukin-4 and interleukin-13 pathway inhibitor, which shows efficacy in patients with asthma with elevated eosinophil levels. This is in a nutshell how the inflammatory mediators release after the allergic disorder starts and the various stages where the new biologic molecules can work. Selective glucocorticoid receptor agonist or SEGRA includes mapracorat, which diminishes the recruitment of eosinophils and inflammation, inducing cytokine production in experimental ocular models. So this is in short is a treatment algorithm. The first line we use the dual activity agents. If not responding, the ophthalmic steroids. Still not responding means oral histaminics, immunotherapy, and other immunomodulators. So where do we involve an allergist? When symptoms remain uncontrolled after empiric therapy, when desensitization needs to be determined, and when immunotherapy is indicated. The role of epithelium in severe allergic conjunctivitis, the epithelial glycocalyx actually provides a barrier function through association with the carbohydrate binding protein galactin-3. The epithelium physically inhibits the inhibition of allergens. So eye rubbing leads to the biomechanical and biochemical alterations. It injures the epithelium and leads to cytokine release like MMP13, interleukin-6, TNF-alpha. And there is loss of barrier function, consequent exposure of corneal fibroblasts to allergic cytokines in tear fluid, exacerbating the allergic inflammation, and thus rubbing leads to keratoconus. The known molecule of ribamipide, which is a mucin secretagogue, can exert its anti-inflammatory effects on the ocular surface by inhibition of TNF-alpha, decreasing the production of interleukin-6 and interleukin-8 cytokines. In very severe cases of allergic conjunctivitis, they require systemic immunosuppression with cyclosporin A, tacrolimus, or mycophenolate mofetil. The scleral contact lens in chronic allergy-induced limbal stem cell deficiency can play a beautiful role by decreasing the surface inflammation and giving an increase in the visual acuity of the patient. Like this patient, we had a vision from 636 to 69. The surgery can be considered in very recalcitrant cases. We can do papillary resection. We have to take care of the cataracts if present. and superficial keratectomy, limbal transplantation, or even keratoprosthesis in end-stage diseases. So supporting patients with severe ocular allergy requires adequate knowledge of the molecular mechanism, the use of novel treatments, and the involvement of an interdisciplinary treatment group. A thorough history and physical examination is key in identifying the allergic conjunctivitis and ruling out other diagnoses. Thank you so much for your patient hearing.
Thank you, Dr. Somana, for covering such a huge topic in such limited time. So as Dr. Sumana has pointed out, there are certain things which we need to remember while treating these patients. Number one, see, the spectrum varies from as mild as a seasonal allergy to as severe as a VKC causing a limbal stem cell deficiency. So treatment has to be tailored depending upon the situation, the age of the patient, the how much medicine he can afford, he can take, and all those things definitely have to be taken into consideration. Number two, as she pointed out, see, there is an association of children with VKC and keratoconus. So please look for the cornea, tell them to avoid rubbing, and that point is also very, very important. Number three, that essentially the treatment of allergy is steroids. The trick is how early you start them and how early you can get away from them. So that is what the art needs to be understood and learned. Of course, now there are a lot of drugs which are available in the market, and they are used in multiple combinations so as to get rid of steroids very early. Finally, what she has mentioned about scleral lenses, VKC causing limbal stem cell deficiency, these scleral lenses or mini scleral lenses are a boon to us. They give the patient very good relief, both symptomatically and visually. So, Dr. Sumana, in your practice, what percentage of patients would you see who are allergic, who are simple seasonal allergy, and what percentage are severe, like VKC kinds?
Please, can you hear me?
Yes, please go ahead.
Yeah, the most patients are seasonal and perennial varieties only. Severe variety of VKC are actually those patients who are getting treatment from various sources and not responding, and they present quite late to us. And this percentage are small, but when they present, they are quite severe in appearance, and it takes a lot of effort to control them, and the steroid dependence becomes a huge issue. So mostly they are seasonal, but VKC is bad VKCs are there.
Yeah, that's very correct. So one thing also what we have learned from Dr. Sangwan, we all are fellows of Dr. Sangwan, and he used to teach us, which is very relevant, that allergy is a systemic disease. So when a patient with limbal inflammation comes to us, a lot of people shy away from giving high dose of oral steroids as well. We use that in our practice, and we believe that if a patient comes to us with limbal disease, patient should be started on high dose steroid very, very soon, because limbal inflammation is such that it has to be controlled very, very fast. Otherwise, it will lead to a limbal stem cell deficiency permanently. Swapna, anything you want to add to what Dr. Sumana has told us already?
Yeah, I think everything has been very well covered. Only thing I would like to add is VKC is probably best treated by first talking to the patient and finding out if the patient is still symptomatic or not. Sometimes we see a lot of signs on the ocular surface, but does not really mean that the patient is symptomatic. Sometimes the eye has those papillae, has burnt out disease, and the patient is not symptomatic. But a lot of times this mistake is made where we are treating the papillae, we are treating things which are not actually causing symptoms to the patient. So the best thing I always tell even my fellows is you have to talk to the patient, find out what the range of symptoms are right now after a considerable amount of treatment.
Very correct, very correct. Don't treat the redness, don't treat the watering, treat the itching. That is what we are taught, and that should be done. Thank you, Swapna. So we move ahead now to the next talk. That talk is supposed to be by me. So probably I'll share my screen now. The host has to allow me to share screen, please. Who's the host here? Miss Swati? Miss Shweta?
Yes, sir. Yes, sir. You share
Can
this.
you please, can you please allow me to share my screen now? Yeah.
Share the screen, sir. Open the PPT. Yeah.
Yes, now it's. So I'll be talking about acute chemical injury. I hope my slide is visible.
Yes, sir.
Okay, I'll start. So what I'll be covering in my talk today is how does a normal corneal epithelium heal? What are the patterns of healing in chemical injury? What happens in limbal ischemia? What is the body's defense system to promote ocular surface healing? And regarding the AMG or the amniotic membrane graft, what, when, and how used, how it helps, when to use it, and what if it is not used. First things first, what we have to remember is that alkalis are more dangerous than acids, conventional to wisdom. Okay, because alkali it leads to a deeper penetration into the ocular tissues and into the anterior chamber, and it leads to a much more severe damage as compared to acids. However, the treatment goals and the management goals remain the same whether the injury is caused by acid or alkali. But in alkali, we have to be more aggressive and more fast. Again, first things first. This patient came to me 2 months after injury, had undergone 3 times amniotic membrane grafts elsewhere, and he was told that the AMG is somehow not working in your eye. And what we found out was there was a lot of retained tuna on the upper lid. So whenever you see a patient of chemical injury, please make sure that you take the patient to the operation theater or make the patient lie down, evert and double evert the lids and the fornices, and make sure that there is no retained tuna. Otherwise, whatever we are doing is futile, and this tuna has to go. Otherwise, this will lead to a chronic, persistent chemical injury. Second point which I want to stress is almost always a routine medical treatment should have steroids. See, again, in a country like ours, a lot of people are afraid of giving steroids in presence of epithelial defects, because what is feared is that the steroids would cause the cornea to melt away, and it could cause an increased chance of infections. What you need to understand is that there's a very severe ocular surface inflammation which is going on, and if you don't give steroids at that point in time, it will anyways cause the cornea to melt. So steroids are the mainstay of treatment along with other supportive treatments in case of acute chemical injuries, and we should not shy away from giving steroids even if there is a presence of total epithelial defect. So again, we come to the pathophysiology of a corneal damage. So whenever there is a chemical injury on the ocular surface, it leads to a corneal and a conjunctival epithelial necrosis, a disruption and occlusion of the limbal vasculature. More severe injury would lead to a loss of limbal stem cells. Now, once these limbal stem cells are lost, if the conjunctivalization or the vascularization of this ocular surface takes place, it leads to healing. Otherwise, it leads to persistent corneal epithelial defect with sterile corneal ulcerations, melts, and severe complications. We'll see them in the coming slides. So, a normal corneal epithelium would heal centripetally, radially inwards with a speed of around 1 millimeter per day. So, epithelial healing does not cross the center to the opposite side. It comes from radially from the limbus. So, for the epithelium to heal, limbal stem cells, which are a continual source of corneal phenotypic cells, have to be normal. And if there is only epithelial damage and the limbal damage has not occurred, this corneal epithelium will heal very nicely without any scarring. As again, if there's an epithelial defect like that shown in this image, this epithelial defect will heal from all 4 sides, radially inwards, at a speed of around 1 millimeter per day. What if the limbus is destroyed too? So as you see in this picture, there's a focal limbal disruption, focal limbal stem cell deficiency, which has happened at 7 to 8 o'clock areas. Limbus is destroyed, but the vascularity of the conjunctiva, limbus, and episteria is preserved. And hence, because the vascularity is preserved, the conjunctiva epithelium grows over the cornea and prevents the patient's own tears from melting the cornea away. This is body's protective mechanism of preventing the melting. So this leads to a vascularization and conjunctivalization called as pannus, which is growing over the cornea from the conjunctiva. This is if the epithelium is destroyed and limbus is destroyed, but the limbal vasculature is present. This was how the cornea heals. Now, what about the corneal stroma? Earlier, we looked into how the epithelium heals. What happens when the stroma is also damaged is the healing of the stroma is also modulated by the cytokines which are released from the epithelium. So what this slide tells you is that even for a stroma to heal nicely, an intact epithelium is paramount. So the goal of us cornea surgeons or any ocular surface specialists is to form a epithelial healing so that everything beneath it heals well. So what happens in mild burns or severe burns? Clinical course. So mild burns means that there is only an injury to the conjunctival or corneal epithelium, and the limbal vessels, the epithelial vessels, and the scleral vessels are spared. Whenever there's an injury to these vessels, we term it as severe burns. And so the gradation of injury would be, number 1, the mild disease would be only the injury to the epithelium. Second would be limbal ischemia. Third would be a episteal or a sterile ischemia. Now we learn what if we don't intervene. What is the natural history of ocular surface burn? So if simple injury, type 1 injury, only injury to the epithelium, the limbal vasculature is preserved, the epithelial vasculature is, the epicleral vasculature is preserved. This would lead to a complete repitalization with a corneal phenotype of epithelium. In about 1 to 2 weeks, there would be no scarring, very nice injury to have, if at all. Image I showed earlier, type 2, where there is a sectoral loss of limbal stem cells, localized limbal stem cell deficiency, it would lead to a vascularization from the conjunctiva and it would prevent corneal melt. Now comes the important type 3. This is type 3A, wherein there is total corneal epithelial defect, ground glass cornea, but there is a presence of limbal stem cell blanching, but no scleral ischemia. So because scleral ischemia is not there, conjunctiva from all 4 sides would grow over, conjunctival over the cornea, form a pannus. This will lead to a tectonically stable and a scarred cornea. Not a very good phenotypically cornea, but the eye is saved for potential treatments in future. As against, if there is also a scleral ischemia and if there is no scleral ischemia, but the vascularization is not taking place from the conjunctiva, this would lead, and the pannus is not forming, this would lead to scleral perforations, ulcerations, and melts. So comparing this image with this image, both are bad, but if we end up having this image as compared to the 3B, this is still better because of potential treatment options in future. The most severe and the worst case scenario is when there is associated scleral ischemia, because in this case, there would be no conjunctival healing because there is no vascular supply to the growing conjunctiva. And this would definitely lead to melts if this is not treated in time. It would lead to sterile melts, progress to perforation, cataract, glaucoma, hypotony, and eventually a thiazical eye. So principles would include removing the offending agent, as I told in the first slide, promoting ocular surface healing, controlling inflammation, support reparative processes, and prevent complications. The goal of treatment, as I told, is to have a earliest possible stable and an epithelialized corneal surface. Ideally, I'm very happy if the epithelium is of corneal, as in grade 1 or grade 2 injuries. If we are not able to have a corneal epithelium, conjunctival epithelium is sought after. And even if a conjunctival epithelium we cannot have it, then we are here to provide a ready-made epithelium to the ocular surface whenever the repair is not taken care of. Surgical intervention, we would always want to debride the necrotic epithelium, necrotic conjunctiva and the corneal epithelium. This is absolutely essential irrespective of the grade of injury. It is more important to excise necrotic conjunctival tissue because it acts as an aidus for infection and acts as a continual supply for acid and alkali. The end point is when there is a surface bleeding happens while touching the tissue, that means that tissue is viable, and that is the time we should stop removing the excessive corneal and conjunctival epithelium. The goals I had already mentioned. This ready-made epithelium, which can be provided to the ocular surface, is called the amniotic membrane. A few slides about that. What is AMG? AMG is a ready-made epithelial surface which minimizes stromal damage by patient's own tears. It gives a basement membrane for the epithelial cells to attach over a damaged corneal stroma. It has an anti-scarring, anti-angiogenic, and anti-inflammatory properties. We can attach this on the ocular surface both by the use of sutures or with a glue. Doing a sutureless surgery is easy, less cumbersome, causes less bleeding, and is always preferred. So in such injury, injuries of type 4 where there is scleral ischemia, you would always want to supplement the surgery with tenonplasty, wherein you would advance the patient's own tenons and stitch it to the limbus, so that the tenons provides the vascularization for the limbus for the scleral ischemia to be taken care of. So cases with severe limbal or capillary ischemia, tenonplasty is a must to prevent complications. Otherwise, these would melt away or get infected. The aim is to re-establish vascularity and aid in corneal or conjunctival healing. Finally, one more thing which we have started doing now is that in severe grade injuries, grade 4 to 6 injuries, where the treatment options are medical treatment, amniotic membrane, or cadaveric limbal stem cells, we have started doing SLET and acute chemical injuries. We published this last year in IGO, wherein this was a case which presented to us with 4 to 5 grade 4 to 6 injury, wherein the pannus was removed, the necrotic conjunctiva was removed, a 3 millimeter peritomy was done all over. If you can see the images F, G, the limbal explants were divided and spread over as we do in routine SLET, and transfer was done at the end. And this patient healed very nicely at the end of around 3 to 4 months. So this is what we have started doing in patients of acute chemical injuries. It is said that in patients of acute injury, you should not be wasting away the tissue of limbus. But as what we see in cadaveric SLET, if the cadaveric SLET is working and giving you a epithelialized surface, I think taking a 2 millimeter limbus from the other eye would serve well. So that is what we have started doing, and that is what can also be done. taking care of all the principles which I have mentioned earlier, there's something which we have started. So to conclude, the key points in management are, while you assess for the epithelial damage, you should always stain the conjunctiva as well, because conjunctival stain is as important as a corneal stain when you are checking for a chemical injury. The severity of injury would be starting from epithelial injury, which is least severe as regards the limbal ischemia or the scleral ischemia. The retained chemical or tuna has to be removed at all costs. The goal of management, as I mentioned, is earliest possible stable and epithelialized ocular surface. We should always have a low threshold of AMG and tendinoplasty in grade 3 to 4 chemical injuries. Overdoing is better than underdoing. And a definitive surgery for vision can be taken care of after 6 months of acute treatment. Thank you. And I am open to taking questions, if there are any. Okay, Purvasha, do you have something to add to this, please, for the benefit of the audience? Then Swapna will come back to Swapna after this.
It's a very comprehensively covered topic, and it's important that immediate management is done, and all the general ophthalmologists as well as the medical officers are aware of how to deal with the emergency situation, so that prognosis is better in later phases. So it's very important that there is awareness regarding initial management, which consists of a good wash, irrigation, which is the most important predictor of prognosis later, and removal of any residual tuna or any other chemical particles which are there by everting the lid and doing double eversion under topical anesthesia. Even if it's a kid, we need to still do it, more so in a kid actually, even though they are uncooperative. But it is very important to stress upon the fact that primary first aid or management of acute stages the most important management criteria for further prognosis.
Very correct. Swapna, you have the chance and the privilege of working with Dr. Sayan, who has taught us all about this. Any points to add here?
Yeah, I mean, very comprehensive talk. All important points were very well covered. Would like to emphasize further the importance of topical steroids. We still see cases every day where topical steroids have not been started in the acute phase. And I feel that is the primary treatment modality in every acute chemical burn. And that has to be started in a very intensive manner right from the moment the chemical burn is diagnosed. Second point, would just like to emphasize about the importance of a tarsography also. So if I'm doing an AMG, I almost always do a tarsography along with it, because there's no harm. The risk benefit ratio is always very low when it comes to a tarsography. The benefits are always higher. We can always release a tarsography later. But if I'm going to do an AMG for a grade 3, grade 4 burn, and I'm going to take the patient in the OR, especially a pediatric patient, I'll always couple it with a tarsography. Helps reduce exposure, helps improve epithelialization rates, also fast epithelialization in these cases.
Correct, very correct, very correct. So again, I just like to add one point on steroids, as she mentioned again. So when I just came out of fellowship, that is around 2014, we had a CME here, and the CME was attended by, I think, around 70 to 80 people. And I just asked, I was presenting the similar topic of acute chemical injury, and I had a show of hands of what drug not to be used in. The question was, which is a drug which should not be used in acute chemical injury? And trust me in saying this, of the 70 to 75 people who were there, 65 of them said steroids should never be used in acute chemical injury. So that is what the common perception is, that steroids are drugs which are not supposed to be used. And that is what, if people who are watching this presentation today can take only one message from this talk, the most important message is, please give steroids as and when the patient comes to you. Because giving steroids in the first 2 or 3 days is paramount for these patients to do well in future. Very rightly said, Swapna.
Yeah, I think the general fear always is that there is an epithelial defect, there's a high risk of infection. But in chemical burns, there is so much of acute ocular surface inflammation going on that this epithelial defect is never going to heal unless we give anti-inflammatory medications like steroids. So I think that point is always completely missed, and there's always a fear of a corneal infection being introduced.
Also, that what we've seen, the general practice, even those who think that steroids are necessary, what they start with is either a loteprednol or a fluoromethalone twice a day or thrice a day. I think you have to go all out with steroids. You have to start prednisolone or stronger steroids like Dexa and give them in proper doses, like maybe 6 to 8 times a day. So it's important to also then monitor the intraocular pressure and rule out any steroid response. But it is important in the acute phases, at least for the first 2 weeks.
Yeah, one last thing I'll mention before we move on to Dr. Swapna. See, if you don't give steroids, the cornea will melt away. And if you give steroids, there's a less chance cornea would melt away. The problem is, if the cornea starts melting away, even when you give steroids, ophthalmologists would attribute the melting to giving steroids, which is false. The melting is happening because of other factors, and if you would have not given steroids, melting would have taken place earlier and faster. So please don't attribute the melting which happens in the first few weeks of the injury to steroids. It is not because of steroids. It is mostly because of lack of steroids or inappropriate dosing of steroids. Okay, so with that message, we move ahead. Do we have any questions? The host, let me know if there are any questions, okay? I can't see the question screen. So we move on to Dr. Swapna, who is a dynamic leader in her own field. She's working in the ocular surface department at LVPI. And she'll be talking to us about a very important disease called as cicatricial conjunctivitis. You know, a lot of people are having difficulty in diagnosing and managing them. Swapna, please, over to you.
Thank you so much, Dr. Rajat. And I would like to also thank the organizers for inviting me to give this talk on this very important topic of cicatrizing conjunctivitis. So cicatrizing conjunctivitis can result in severe dry eye, end-stage ocular surface disease, and permanent corneal blindness. Why should we diagnose this entity early? Because in the chronic phases, the different etiologies are clinically indistinguishable. The treatment in end-stage disease is almost a type 2 keratoprosthesis because of the severe amount of dry eye. And some of the entities which cause cicatrizing conjunctivitis have significant systemic morbidity too. So I'll be showing 2 cases just to highlight how should we go about differentiating the causes of cicatrizing conjunctivitis. So in our practice, most probably the diagnosis of cicatrizing conjunctivitis, the 2 most common diagnoses are always SJS and mucous membrane pemphigoid. So I'll go about, because these cases come to us in a chronic phase, in the late phase, they're referral cases. And I'll just try to highlight what we actually ask for and look for to differentiate between these 2 causes. So this is a case of a 76-year-old female who presented to us with left eye irritation and foreign body sensation since 2 months, diagnosed previously as dry eye disease and was on lubricants. So this eye was the eye in which she had the complaints. It was 20/30. The other eye was normal. So as you can see, the lid margins are rounded, but there is this amount of canthal sort of shortening and some amount of keratin at the canthus. If we invert the upper eyelid, there is some amount of subtarsal fibrosis that can be seen, very subtle. And there is this amount of fibrosis also in the inferior tarsal conjunctiva, and there was inferior fornical shortening. All of this was very subtle. She had dry eye, Schirmer's was 3 millimeters. The entire ocular surface has taken up diffuse staining of fluorescein. So the provisional diagnosis here was left eye chronic cicatrizing conjunctivitis because of the medial canthal shortening, because of the inferior fornical shortening and the subtarsal fibrosis. And she also again had severe aqueous deficiency dry eye with pseudophakia. So the differential diagnosis here, so chronic cicatrizing conjunctivitis can be of a lot. There are a lot of etiologies which lead to this disease. There can be only ocular disease, there can be ocular dermal diseases, or there can be skin diseases with a secondary manifestation in the eye, multisystem diseases, and there are some miscellaneous rare causes too. In this beautiful article by Dr. John Dart from UK, this article was published in 2017 in the Eye, and this talks about differential diagnosis of cicatricial conjunctivitis. So as you can see, all these images have this tarsal congested conjunctiva, the subtarsal fibrosis, inferior fornical shortening, symblepharon, and the cornea is also affected in a lot of these cases with LSCD because of also the severe dry eye. But the differential diagnosis in each of these cases is different, like you can see here. So how do we go about trying to find out what the etiology is? So this is an algorithm that we have published in the Indian Journal of Ophthalmology last year. So the questions that we generally ask is this present since childhood? Is there any history of trauma that would lead to, is there any history of chemical burns, any history of surgery done previously, any head and neck radiotherapy, allogenic bone marrow transplantation, any use of glaucoma eye drops, any association with dry mouth, joint pain. So with this kind of history taking, we try to eliminate some of the etiologies which can lead to cicatrizing conjunctivitis. So in this patient, all of this was negative. Finally, we asked the paramount question, was there any previous history of skin or mucosal involvement? And the answer was no. So it can still be mucous membrane pemphigoid. Mucous membrane pemphigoid has a variant which is known as ocular only mucous membrane pemphigoid, which can manifest with absolutely no other systemic involvement. So the next step here was to actually do a serological profile in the form of finding out if there is any autoimmune disorder like Sjogren's syndrome or secondary Sjogren's syndrome, and doing a conjunctival biopsy. So ESR was slightly raised, RA factor was negative, ANA profile was negative. So then we went ahead with a conjunctival biopsy. So the conjunctival biopsy for diagnosing mucous membrane pemphigoid should ideally be taken from both eyes, should not take a biopsy from scarred conjunctiva, should try to find where the normal conjunctiva is, where the conjunctiva does not look diseased or fibrosed, and try to take a biopsy from that area. We take a very small sample of 4 by 4 millimeters, full thickness till the bare sclera, divided into two, send 1/2 for histopathology, send 1/2 for diffuse immunofluorescence. The histopathology part is to rule out masquerades such as OSSN and sarcoidosis. We actually use OCT media and send it immediately to our pathology lab because it's right next to the OR, and they immediately start sectioning and freezing the tissue. But for practitioners for whom this is not available, the tissue can always be sent in Michel's transport medium to the pathologist. So for this patient, the biopsy actually came back positive, and there was the immunofluorescence for the basement membrane was positive. So the final diagnosis in this case was left eye mucous membrane pemphigoid with severe aqueous deficiency dry eye. So the treatment was, this algorithm has again been published in the paper that I just spoke about in IJO in 2020. So the treatment part is systemic immunosuppression for cases of mucous membrane pemphigoid. That is the most important part. And so here baseline blood investigations were done. We started the patient on oral mycophenolate mofetil, and the patient is on constant follow-up. We closely monitor the ocular surface, and we treat with topical lubricants for the dry eye part and topical steroids only if there is ocular surface inflammation. So what I would like to point out here is history taking is very important. Doing a very good slit lamp examination, looking at the fornices, the punctum, the canthus, the tarsal conjunctiva is very vital to reach the etiological diagnosis in cicatrizing conjunctivitis. And it is good to have a low threshold for conjunctival biopsy, because then you have an answer for that patient as to what that patient actually suffers from. So if we do not do all this, an eye which is like this can easily progress to this within a couple of years. So the next that I would like to present is a second case. This is the case of a 36-year-old female. The patient presented to us with after 12 years after an episode of chicken pox, according to her. And this is the left eye of the patient. As we can see, there is a canthal foreshortening, medial, lateral. There are dystachiatic lashes, and can be seen here. The ocular surface looks inflamed. There is a shortening of the inferior fornix. The lid margin actually has a lot of atrophic meibomian glands. Does not have lid margin keratinization, has dystachiatic lashes, as can be seen here. And the amount of subtarsal fibrosis is there right here, but not very, very intense. She has a lot of inferior fornicial shortening. There's literally no inferior fornix. And the cornea in the right eye is very severely affected with LSCD with corneal vascularization. The Schirmer in this eye was 4, and in the left eye, the Schirmer's was 5. The left eye, the cornea was still better than what it was in the right eye. Now, again, the diagnosis here is both eye chronic cicatrizing conjunctivitis, severe aqueous deficiency, dry eye, right eye partial LSCD. Now, here the differential diagnosis, again, ask all these questions, come to skin or mucosal involvement, and her answer was yes. So then we have something that we do for every patient. This is the SJS score. This we have published in BJO last year. And we ask a very detailed medical history of sudden onset of conjunctivitis, fever or drug intake preceding the conjunctivitis. Was there any skin involvement associated with necrolysis, peeling of skin on pressure? Was it associated with loss of nails on the fingers or toes? So all of this has a grading system. We give a +1 grade if any of this is positive. And also severe morbidity with admission in the ICU or the burn ward. If it was associated with mucosal ulcers, there's a negative scoring because that goes further in the diagnosis towards mucous membrane pemphigoid. Associated mucosal ulcers and recurrent mucosal ulceration or rectal bleeding. When we talk about the clinical examination, the skin discoloration, we always look at the general, the face of the patient, the hands of the patient, the feet of the patient. Is there skin discoloration? It can be hyperpigmentation or hypopigmentation. Are the fingernails or toenails disfigured? Is there posterior migration of the mucocutaneous junction? Or this is the image of disfigured fingernails and toenails in patients with SJS. Patients with SJS also have posterior migration of the mucocutaneous junction in the mouth. And this is what is lid margin keratinization and distichiasis. So for all of this, again, there is a score. And in this patient, there was history of sudden onset of conjunctivitis. There was history of this conjunctivitis and the systemic involvement of peeling of skin on pressure. There was history of loss of nails on fingers and toes, and also severe morbidity with admission in the hospital or the ICU. And she had disfigured toenails, fingernails, posterior migration of mucocutaneous junction in the mouth, and distichiasis, but no lid margin keratinization. So the score was 7. So if the score is more than 5, it favors a diagnosis of SJS. So what is the treatment for SJS? It again depends on what is the amount of lid disease, what is the amount of dryness, what is the amount of keratopathy. If the eye is dry, like this patient had severe dry eye in both eyes, the answer is always scleral contact lenses or minor salivary gland transplantation. So because she had severe aqueous deficiency dry eye with keratopathy, we wanted to fit her with scleral contact lenses, but the amount of fornicial shortening was so much that we were not able to fit scleral lenses, and hence we actually did a bulbar mucous membrane graft where we harvest mucous membrane from the labial mucosa and place it over the bulbar surface after resecting the symblepharon and allowing it to fall back. And followed by this, after 2 months, we were able to fit her with scleral lenses. So again, history taking, general examination, slit lamp examination, and using a scoring system, all of these were vital in this case to reach to an etiological diagnosis. So to manage cases of cicatrizing conjunctivitis as a whole, a complete autoimmune workup is always useful. We should have a low threshold for conjunctival biopsy in cases with an equivocals SJS score like 5 or less than 5. And evaluation for systemic involvement and timely initiation of immunosuppression is extremely important. These are different images of involvement with cicatrizing conjunctivitis like subtarsal scarring, inferior fornicial shortening, partial LSCD with symblepharon. This is actually lateral canthal shortening, medial canthal shortening, just a symblepharon with an ocular surface granuloma. This is a patient with LSCD with a persistent epithelial defect. This is complete dermalization of the ocular surface, and this is dermalization with an ankyloblepharon. So this is the entire spectrum in which chronic cicatrizing conjunctivitis can present to us, and it's very useful and helpful to the patients if it can be picked up in these early stages. So just coming to the differential diagnosis, this is a case of anhydrotic ectodermal dysplasia, where the patient has periocular vitiligo, alopecia, edentulism, where they have no teeth. So that's an easy diagnosis if you systemically examine the patient. Another common, not common, but a very commonly misdiagnosed entity is drug-induced cicatrizing conjunctivitis. So here, as you can see, this patient was on anti-glaucoma medications for a very long time, like almost 15 years, very poor ocular surface, corneal vascularization, and the medial canthum is like obliterated, medial canthus, and there is inferior fornical shortening in this eye. And there is a zipper-like shortening, and there's also punctal pouting, and there is a punctal fibrotic band from one puncta to the other puncta. So this happens because of the either component in the anti-glaucoma medication or the preservative, because these patients have been using it for a long time. This causes a lot of damage to the ocular surface, and most of the damage is limited to the inferior fornix. However, if a patient is on these medications for very long, it can involve the entire eye. And you've also seen cases with total LSCD with DICC, or drug-induced cicatrizing conjunctivitis. So when you have a patient where the upper fornix is open, but the medial canthus is completely closed, obliterated, and there is a history of usage of anti-glaucoma drugs, the diagnosis always goes in the favor of DICC, when most of the changes are inferior and around the puncta, where the drainage of all these medications is happening. This is a case of bullous pemphigoid, large ocular surface granulomas on the tarsal conjunctiva, on the bulbar conjunctiva, fornical conjunctiva. This is a case of linear IgA disease, again, granulomas on the inferior bulbar conjunctiva. This is linear IgA disease. This is actually a pagetoid spread of a sebaceous carcinoma. This is again sebaceous carcinoma. So that is also commonly misdiagnosed, and it can also present as cicatrizing conjunctivitis. So this is like one of the best articles out there on chronic cicatrizing conjunctivitis, and Dr. Dart covers practically everything you would want to know about this entity in this one article. We also published this article last year, out of which I presented some of the algorithms. And maybe somebody would find this useful too. I would like to thank my colleagues in the ocular surface team at LVPI, Dr. Sayan Basu, Dr. Pragnya Rao, and Dr. Swati Singh for all their help and support for managing these cases. Thank you so much.
Thank you, Swapna, for covering this exhaustive topic nicely. So what Swapna's talk tells us is that we are doctors first, ophthalmologists later. So we should be thinking beyond the eye, beyond the ocular surface. So you know what, I am now practicing in private practice now for the past 10 years. What we see are patients who are being given dry eye lubricants for dry eye over years, for years and years. And the ocular surface goes on becoming worse year after year. And when they end up to me, they end up with pictures which I've just shown, chronic cicatrizing conjunctivitis. So what the audience must learn from this presentation today is that the treatment of dry eye is not lubricants. You have to find out the cause for dry eye, why this patient is actually having a dry eye, because normally patients should not have dry eye. Normally the tears should be sufficient enough for the patient to survive for his life. So if the patient is having a dry eye, the surface is becoming bad, the lids are becoming bad, something in the ocular surface is not normal, please either diagnose them or refer them. Please don't wait for the surface to become poor and then wait for the treatment to be started. So I think that is the message for today. Yes, there are a lot of diseases which we have come up with, or they were already there. We have now decided to diagnose them. Those two papers are really remarkable papers. I have the fortunate chance of reading the second paper which you mentioned, which you guys have published. It's an amazing article. So if somebody has time and interest, they should be reading that article. But what message they should be taking from this talk of yours today is that if something is going on bad on the ocular surface, please think beyond lubricants, because there's much more life beyond lubricants. We have to start to diagnose these cases and treat them based upon their cause. So thanks for this wonderful talk, Swapna. I think we'll move ahead because we are short on time. Purvasha, are you there?
Yes.
Purvasha will be talking about PUK, another disease which is commonly present in the system. We see them left, right, and center, and she'll be telling us how to manage them nicely. Purvasha.
So thank you so much, Rajat. And at the outset, I would like to express my gratitude to Dr. Namrata Sharma for giving me this opportunity to present at the South Asian Academy of Ophthalmology conference of SARC Academy of Ophthalmology. And today, we'll just discuss a few points regarding peripheral ulcerative keratitis. So what exactly is peripheral ulcerative keratitis? And we would be discussing what are the clinical features, why is it important to discuss this, what would be an approach to a patient with PUK, and what are the treatment options. So When we talk about PUK or peripheral ulcerative keratitis, it is basically a disorder of the juxtalimbal cornea. It is an inflammation basically, which is characterized by a very typically crescent shaped destruction and inflammation at the margin of the cornea. So it is perilimbal. It is associated usually with an epithelial defect. There are stromal inflammatory cells which are present, which is basically evident as a stromal infiltrate at the advancing edge, which is seen, and there is progressive stromal degradation and thinning, which is present. So usually, this is what PUK presents as, and it could be small to start with, and then it can slowly involve the entire area or the limbus. So, coming over to the clinical features, it could present at any age. Even cases at 3 years of age have been reported. It could be unilateral or bilateral, depending upon the cause and the systemic associations. And usually, it presents with severe pain, which is disproportionate to the actual clinical signs that are present. And there is redness, watering, photophobia, which the patient will complain of. Vision in the early phases is not affected because this is peripheral, but later on, as the condition progresses and there is progressive stromal degeneration and degradation, then central cornea and the central cornea is again involved. There might be progressive loss of vision also. And the typical, as I have already mentioned, the sign is a crescentic perilimbal corneal ulcer, which is visible with a subepithelial infiltrate right at the edge. So these are the clinical features which would alert a person with a diagnosis of PUK. And when you're actually examining this patient on the slit lamp, we should always do the fluorescein staining and document it as to how many clock hours of the limbus are involved, what is the depth of the infiltration, if there are any signs of an infection which are present, or there is the documentation of an overhanging edge at the advancing area. And we also look for scleritis associated the perilimbal scleritis or limbitis, and presence of an AC reaction and iritis, which is to be documented or looked for. Then posterior segment evaluation is important in such cases. If we can do an indirect ophthalmoscopy, or if the posterior segment is not visible due to corneal edema, then we can also do an ultrasonography B scan. And if we have an ulcer which is there, we always do a corneal scraping for all the cases and send it for diagnosing any bacterial or fungal scrapes, like we take for microbiome culture as well as sensitivity. And we also do a detailed systemic examination, as I will just talk about in a few moments, and a proper immunology consultation is sought. So these are the basic points which we should take care of. So as you can see here, it could just present as a tiny peripheral erosion along with slight stromal infiltration here. But as you can notice here, there is this associated with a nodular scleritis component here. It could also present later in such a situation where the entire perilimbal area has been involved. There's severe thinning of the cornea, and there's just a central island of cornea which is left because of stromal degradation and infiltration. The peripheral cornea has vascularized in an attempt to heal this, and the active edges here will take up stain, and there is this overhanging edge over here which is visible. And in certain cases where it is associated systemically also, and there's progressive thinning at the peripheral limbal area, then there might be a perforation and you might see iris prolapse through that. So all these will require treatment either in the medical or in the surgical form. So what are the differential diagnoses? It could be an ocular infectious or non-infectious cause. It could be because of various pathogens like bacteria, acanthamoeba, fungus, and viruses, which are mentioned here. Or in the non-infectious cases, it could be Murren's ulcer, TMD, PMCD, keratoconjunctivitis sicca, blepharitis, marginal blepharitis, neurotrophic, neuroparalytic causes, and others. And if we look at the systemic symptoms, systemic associations or differential diagnoses, it could be either again systemic infections or non-infectious cases. And TB is one of the most common ones in our country, and along with HIV. And for non-infectious cases, it is the most common one that we diagnose it is with rheumatoid arthritis, followed by Wegener's and GCA, SLE, polyarthritis nodosa, and other ones like relapsing polychondritis and systemic sclerosis. So these are the ones that we should actually take care and keep our minds open to these diagnoses. And certain systemic symptoms that we should look for are given in this table over here, and we should specifically look for these signs, and these might clinch the diagnosis or the cause of the PUK which is happening in the eye. So why is it important to actually know so much about PUK? Because it is a potentially devastating disorder, and it might actually be a clinical presentation, the prime clinical presentation of a underlying even a fatal condition. So systemic autoimmune vasculitic disease like rheumatoid arthritis and Wegener's granulomatosis, which can be potentially fatal, might present initially as a PUK. And this might precede the systemic manifestation about 25% of these conditions. And it's very important to remember that the 5-year mortality rate for untreated rheumatoid arthritis with either a PUK or scleritis is approximately 50%. That is 1 in every 2 patients might have a potentially fatal disorder harbored in the body, and we can take care if we are vigilant enough. So when we come to talk about rheumatoid arthritis and associated PUK, it is the most common systemic disease which is associated and constitutes around 34 to 42% of these cases. And high risk factors are a presence of nodular rheumatoid arthritis or rheumatoid arthritis which has been there since more than 20 years, or if the RA factor titers are very high, or the anti-CCP antibody titers are very high. And it suggests a systemic vasculitic phase of RA. That means the entire system has already been involved and it's in the advanced stages. Talking about GPA or Wegener's granulomatosis, it is the second most common systemic disease associated, and it is in 50 to 60% cases, the ocular involvement is seen, and it often manifests at the onset of the Wegener's granulomatosis. Another condition, which is polyarthritis nodosa, which shows ocular symptoms in about 65% of the cases, and PUK presents in less than 10% of the cases. Nevertheless, it is important because 85% death rates are seen if it is untreated. Other causes which we've already discussed are SLE, progressive relapsing polychondritis, and systemic sclerosis. Another entity which is talked about is Morin's ulcer, which is basically when you've excluded all other DDs and we cannot find a cause, and this kind of a PUK is basically after all the systemic investigations and all are done and ruled out, then that can be labeled as Morin's ulcer. This has basically two kinds of presentations. One could be very aggressive and bilateral, which is generally seen in younger age groups. And the second peak that comes is in the elderly age groups, which is usually indolent and not very aggressive, but still can involve the entire limbus. So that is Morin's ulcer. So what are the baseline tests or lab tests or serological tests that can be ordered once you suspect a diagnosis of PUK? Generally, a complete blood picture is to be done with erythrocyte sedimentation rate, RA factor, anti-nuclear antibodies, as well as ANC, ANCA is to be done. A PA view of the X-ray of chest has to be done to rule out tuberculosis. A Mantoux test can also be done. Liver function as well as renal function is to be done, and routine and microscopy examination of urine has to be done. One can also do an FDA anti-absorption test for syphilis as well as an hepatitis C antigen or an HIV also can be done. And additional testing is basically indicated by the review of systems and physical examination findings that we find during the comprehensive evaluation of the patient. So based on serology that we order for rheumatoid arthritis, very specific is the anti-CCP antibody, as we've seen. And for vaginals, it is the C-ANCA, which is almost 99% specific. For SLE, it is the anti-double-stranded DNA antibody, which is more than 98% specific. And systemic sclerosis, these two anti-topoisomerase 1 antibody as well as anti-centromere antibodies are basically almost 100% specific. Polyarthritis nodosa does not have a specific antibody that we test for, but HPS-AG antigen is basically associated in more than half of the cases. So these are the serological tests that can be performed, and you can tailor make these for each case of PUK depending upon whether you suspect an infection or not. So coming over to the management, basically topical steroids are used as starting therapy, especially in mild to moderate cases, and this is in the form of prednisolone acetate. And if there is a systemic association that you suspect, then oral prednisolone in the dose of 1 to 1.5 milligrams per kg body weight can be started. And if it is very severe systemic association that you're suspecting, and any of those tests come positive for autoimmune diseases, then IVMP or pulse methylprednisolone can also be given. Then side by side, we also start the systemic chemotherapy, systemic immunosuppression, basically with the primary drug that you can start with is methotrexate, or in severe cases with azathioprine or even cyclophosphamide. Along with that, the surgical part that we cover is the conjunctival resection. Basically, we the excision of conjunctiva almost 1 to 2 clock hours from the limbal edge of the lesion is excised, and 4 mm away from the limbus, away from the cornea, is excised basically and resected, and that leads to usually this is what is described in textbooks, that leads to management of the extreme inflammatory mediators that have been brought by the conjunctival vessels to the perilimbal area and to the cornea, and that along with superficial keratectomy and the removal of the overhanging edge can be done. And the area that is thinned out in the periphery, the stroma that is now very weak, can be actually fortified by using your tissue adhesives like cyanoacrylate glue, which basically acts as a barrier for the tear film cytokines or the inflammatory mediators present in the tears, which are then having access to the stroma, which is exposed. So tissue adhesives can be put or applied along with the bandage contact lens. So the even sometimes if there is too much of thinning, then amniotic membrane grafting can also be done. For peripheral perforations like the ones that we saw, there could be application of tissue adhesives with bandage contact lens, or it could also be managed by using a tenon patch graft, which is actually taken from under the conjunctiva in the healthy area. So a patch graft can be harvested and can be put into the perforated area, and that can later be also with the supplementation of systemic and topical steroids can be managed. A multi-layered amniotic membrane graft can also serve the similar purpose. And if it's a large perforation, then a banana-shaped graft or a crescentic and circular patch grafts can be done. They could be penetrating or lamellar. And if there's too much of thinning of the entire cornea, then a tectonic PK can be done. It could be a full thickness or a lamellar graft. So all these can be taken up, but the mainstay remains the topical as well as the systemic immunosuppression. And we have to keep the patient on strict follow-ups, and compliance has to be checked. And we have to look for recurrences, especially in cases with systemic involvement, because even if after we've done a PK or a graft, these cases can recur, and the disease can again infiltrate into the new grafts, and that again requires further management. So stepping up systemic immunosuppression might be then indicated. So we have to keep a check on the management there. And these are a few pictures. This is the one with where the conjunctival resection has been done and the overhanging edges have been removed and the tissue adhesive has been applied for this case. And here there is a banana graft or a peripheral crescentic graft that can be seen. So this was a study by Dr. Namrata Sharma's group, and this has been published with more than 70 cases, 75 eyes of PUK that were managed. And if you see, mild to moderate disease responded well with just medical management in the form of maybe topical and systemic immunosuppression and healed well, whereas severe disease required more than 50% required a primary surgical approach. And recurrences were also more common in severe disease. So it's important to keep this in mind that severe disease does require aggressive immunosuppression along with surgical modalities. So points to remember here are the leading edge basically which is seen is undermined, it is crescentic in shape, infiltrated stroma is visible and there is de-epithelialization, and that should ring a bell that this is PUK. Rheumatoid arthritis is the most common systemic disease which is associated, and PUK often manifests at the onset of vaginous granulomatosis. So it's important to recognize it and find the cause. And the serology might show anti-CCP, which is more specific than RA factor positivity. And Murren's ulcer is basically a diagnosis of exclusion, and we still need systemic immunosuppression also in that. Physician and rheumatology consultation is very important. We always work in coordination with the rheumatologist and for stepping up or ruling out infections before you start the immunosuppression. Even during the immunosuppression, which is to be continued, we consult the rheumatologist always, and there are repeated and regular serology tests that are done, the LFTs, the RFTs, everything is to be monitored. The step-up immunosuppression before and after any surgical intervention that is planned so that there is no recurrence of the disease. And all patients are to be monitored for very long periods, maybe even lifelong. So always think about recurrence in case there is any kind of revisiting of the patient with symptoms. So thank you so much for this opportunity.
Thank you, Prabhasha, for such an exhaustive talk and covering the topic so nicely. So actually, I was making a list of points to re-emphasize, and the last 6 points which you have mentioned are exactly the points which I was supposed to re-emphasize again. So again, we are doctors and not only ophthalmologists, so we should be treating the patients as a whole. Investigate them properly. Start early treatment because these diseases have a potential to cause systemic damage as well. And you know what? Always have a rheumatologist beside you, because these rheumatologists, they work. If we and rheumatologists work hand in hand, this goes very well in treating the patients as a whole. So I think we are anyway short of time and lagging behind. So we'll move ahead. She's covered the topic beautifully, and without further ado, we would invite Dr. Shilpa now. So it's just a tweak in the program. Dr. Shilpa will be presenting first, and it will be followed by Dr. Pallavi's talk. Thanks, Prabhasha. Thanks again for a very, very wonderful talk.
Welcome, Namrata ma'am, to the session.
Thank you, Purvasha. Fantastic presentation, like always, very complete.
Thank you, Dr. Rajat. Can everyone see my screen?
Yes, please go ahead.
Yes.
So I'm Dr. Shilpa from Nara Netralaya, Bangalore. Today, I will be taking you through a few cases of dry eye disease, and we will be seeing a stepwise approach to a management of these cases. Now, all these cases are those with a chronic dry eye disease, for which we manage them with something beyond lubricants. Different diagnostic modalities were employed, and different therapeutic modalities were employed in a stepwise manner to treat these conditions. The first one is a 55-year-old female who presented to me with complaints of blurred vision, sensitivity to light, and a foreign body sensation from past 10 years, but very severe since a month. Now, she was already diagnosed with primary Sjogren's syndrome, but still she had persistent joint pains despite being on HCQ therapy. On presentation, her vision was slightly defective. due to her corneal conditions, where she had multiple punctate epithelial erosions and numerous filaments, as you can see here. Her dry eye evaluation revealed a decreased tear meniscus height. The TBUT was abnormal because of the filaments. Now, the Sika's ocular staining score was 4 and 8 respectively, and her Schirmer's was 0. So this is a case of primary Sjogren's syndrome with a severe aqueous deficiency dry eye with a persistent filamentary keratitis, and the systemic disease is only moderately controlled. So the aim of our therapy is to fight the filaments, reduce the inflammation, and increase the tears on the surface, for which different methods are used as highlighted here. So let's look what we did for our patient. We wrote a letter first to the rheumatologist to kindly assess the patient and initiate extra immunosuppressants in order to achieve a better control. Started her on preservative-free lubricants, gel in anti-inflammatory, steroids, and continued her HCQs. So with this, there was no resolution of filaments, and the filaments were too much over the entire surface, so we cannot do such a large debridement. So then we thought of adding N-acetylcysteine, which is a mucolytic agent. Now this is usually available as 20%, which is very stinging to the eye. Hence, you can reduce it to around 5 to 7% by adding it to the artificial tears. So you subtract 6 ml of artificial tears from 10, you get 4, to which you can add 2 ml of mucomix that is available commercially in order to get a 7%. Now with this, there was a drastic improvement in symptoms and signs of the patients, and the PEs and the filaments reduced drastically. At this point, I wanted to go ahead with a punctal plug for her because her Schirmer's was very poor. There are different types of punctal plugs available. Well, plan was to go for a temporary plug, either a short duration or an extended duration. However, this patient was not keen for any kind of invasive intervention. She wanted to continue with glasses that she was already using, which were moisture chamber glasses. Now, these glasses contain a silicone or rubber tube at the back of its surface, which fits on to the patient's face around the eye. And it is seen that these moist chamber glasses improve ocular comfort and tear film stability in many patients of Sjogren's syndrome. So she was comfortable with this and didn't go forward with a plug. So of all the strategies that we wanted to do for the patient to treat her, it is important to understand that not all patients may accept everything you do, but most of it, if you're able to imply and solve the problem for the patient, that is a good result. Moving on to my second case, a 71-year-old male presented with excessive tearing, foreign body sensation, and itching from past 2 years. Now, he was a known case of glaucoma, had already undergone cataract and trabeculectomy on multiple AGMs, and he had a history of multiple episodes of follicular conjunctivitis from the past 2 years. His vision was defective due to his dry eye condition, and he had a large discs. He had a ptosis in both eyes, which was age-related. He had severe mebumin gland dysfunction, and he had thickened skin over lids with excoriation suggestive of dermatitis. He also had multiple punctate epithelial erosions, both on the cornea and the conjunctiva inferiorly. Dry eye evaluation showed a decreased tear film breaker time, but otherwise, if you see the tear meniscus height and the Schirmer's test, they were almost normal. The staining pattern was poor, as I said, inferiorly. So we went ahead with the IDRA scan. Now, the IDRA scan looks at multiple parameters of the patient. So as you can see, starting with the lipid layer thickness, it was altered more in the right eye and all right in the left eye. You can even see that the non-invasive breakup time and the tear meniscus height are more reduced in the right eye compared to left. The mammography showed equal loss area for the lower lid, but for the upper lid, the loss was more in the right eye compared to left. So this scan is an addition to your regular slit lamp evaluation and your dry eye testing. Especially it is important because when you're comparing right eye to left eye, this is probably more indicative of this. And also the symptoms of the patient were more in the right eye. So this corresponded to that. So this is the diagnosis of a mebumin gland dysfunction with the evaporative dry eye, complicated with dermatitis and AGM-induced ocular surface disease. So what now? So the plan of therapy and aim of therapy in this patient is completely different from the previous. Here we need to improve mebumin gland function, tackle the inflammation, and supplement tears in the following modalities. So patient was given warm compresses, chloramphenicol, doxycycline, HPMC gel, and continued his AGMs, which we could not stop because of his glaucoma. Now with this, there was improvement in the conjunctival and corneal signs. However, the dermatitis and the MGD persisted. That is when cyclosporin and oral steroid called deflazacort was added. Now, deflazacort, unlike Vizolone, can be given for short term. Usually, I start with 6 milligram BID for 1 week, followed by 6 milligram OD for another week. With this, many of the patients, the dermatitis improved. So there was an improvement in dermatitis. However, there was waxing and waning of the MGD-related symptoms. At this point, we decided to go for a EI therapy, which is the intermittent pulse light therapy. Now, through EI, we give an infrared nerve stimulation. Now, this not only stimulates the parasympathetic nerve system, but also causes vasodilatation, which increases the functionality of the Meibomian glands. So we proceeded with 3 sittings, which was given in day 1, day 15, and day 45. And after this, more than the signs, there was a drastic improvement in the symptoms of the patient, which is much more important than all your clinical signs. And the patient almost stopped complaining. And we saw a drastic improvement in that. And of course, his Whitlam findings and the parameters improved. We continued him on warm compresses. Even if you do your EI, the warm compresses need to continue. That as well as your anti-inflammatory and your lubricants. So whatever we decided to do for this patient, we almost implemented everything, and the patient had a good result. Now, this is my last case of a 50-year-old female. She was a professional, a school principal, and she complained of redness, stinging, and burning sensation and foreign body sensation for 6 months. And she also complained of ankle pain. Now, her OSDI scoring was 58.33, which is suggestive of moderate to severe dry eye. And she presented with a good vision, but her conjunctiva and cornea showed multiple erosions. Now, we went ahead with the dry eye evaluation. The TBUT was reduced. The Sherman's test was 5 and 6 respectively. And we went ahead with the oculus keratograph. This showed that the tear meniscus height was 0.2 and 0.3 respectively in right and left. And even the non-invasive keratograph breakup time showed a right eye to be more affected than the left eye, as you can see here with the red and the orange indicators. So this also told us that the right eye is worse than the left. Now, this is a case of moderate to severe aqueous deficiency dry eye. Query a Sjogren's syndrome because of the classic punctate epithelial erosions that we saw. So we wrote a letter to rheumatologist. She was not diagnosed earlier, to evaluate her. And the aim of the therapy here was to reduce the inflammation and increase the tears on the surface. So we started her on CMC, HPMC gel, cyclosporin, and topical steroids. And the diagnosis made by the rheumatologist was that of rheumatoid arthritis because her blood tests were positive. So then she was initiated with anti-rheumatoid treatment, and along with her topical dry eye treatment, she was very comfortable. Over 3 months, her Sherman's with anesthesia improved and her TBUT also improved. However, 2 years later, she came back to us as a very unhappy patient. And when we redid the evaluation, her TBUT was reduced and the Sherman test values were also reduced. So we were wondering what happened because her anti-rheumatic therapy was going on. So on evaluation, we realized that apart from rheumatoid arthritis, she had a vitamin D deficiency. She also had developed hypothyroidism, had reached menopause, and she was working in an environment with a lot of air condition for long hours. So this is what exaggerated her dry eye. So at this point, apart from the topical therapy, we added omega-3 fatty acids. She was given thyroxine and vitamin D supplements by the physician. And after which after this treatment, she improved. So apart from what we initially planned to reduce the inflammation and increase the tears, we had to add supplements of thyroxine and vitamin D later to get a good remission in this patient. So to conclude, these were 3 different cases of dry eye. First one was that with aqueous deficiency, diagnosed with Sjogren's syndrome, presented with a filamentary keratitis. Second one was the evaporated dry eye with Meibomian gland dysfunction, complicated with dermatitis and ocular surface disease secondary to AGM. And third was the aqueous deficiency, newly diagnosed rheumatoid arthritis with complicated with nutritional and hormonal changes. So every case is different and every case requires a plan which is best made at the start. And a good beginning helps in the long run while customizing treatment in all the chronic dry eye patients. Thank you very much for the patient listening.
Thanks, Shilpa. Thanks for a nice talk. And people at NN, Dr. Rohit Chetty's team are doing excellent work in this field. And we see a lot of diagnostic gadgets coming up now, and these are really helping us in the management of dry eye. What Shilpa's talk has also again emphasized is that we are doctors first and ophthalmologists later on. So, we should be taking a patient as a whole whenever there is ocular surface disease, whether it is dry eye or a PK or a cicatrizing conjunctivitis. Always look at the symptoms and the signs other than the eye, and you can come to a clinical and a workable diagnosis and help the patient. So, Shilpa, I have a question for you. So, we in the past few years we have seen Dr. Rohit Shetty's team discussing about MMP levels. So, is the MMP9 testing has it become a routine part of your dry eye management these days in NN?
No, we don't do it for all patients, but some patients who are like not responding to a conventional therapy, and even after immunosuppression, those with aqueous deficiency, and those who we give the evaporative and give IPL therapy and not responding, probably we go for a MMP level. We have the facility in one of our centers in Narayan Nethralaya, so we don't do it as a routinely for all.
Okay. And one more question I have for you is that the new tests which have come up, like those by Johnson Johnson company, I'm forgetting the name. So you do them regularly, these tests of dry eye disease, or you again do them in a different subset of patients?
Almost all, for almost all. Now, since we have the machine, we are doing it for almost all. The IDRA and the keratograph. So we are doing it for almost all the patients.
It really helps, getting this objective signs and
Yes.
documenting them and seeing them over a period of time that they're improving. It really helps and to assess how the ocular surface is improving.
Correct. But whatever you do, the symptoms of the patient is the most important indicative of everything.
Definitely. So there are a lot of times when we see that the symptom score is less, but there are a lot of signs on the patient's eye. So always we are told we have to treat the patient, not the machines, and not the reports. So that's very correct. You have to take care of the patient's symptoms and treat them preferentially.
Yes.
Thank you, Shilpa. Thanks a lot for your talk. And we come now to the last talk of this session by Dr. Pallavi. Dr. Pallavi, I believe, is here. Dr. Pallavi, are you there? Yeah. So she is again at Shankar Eye Hospital, Bangalore, and she'll be telling us about how to make a approach to LSCD. Dr. Pallavi, over to you, please. Thank you.
Yeah, thank you. Good afternoon. Am I audible?
Yes, ma'am. Loud and clear.
Yeah, I have some bandwidth issues, so I cannot put my video on. So at the outset, thank you for this opportunity, Dr. Amrita Sharma and the organizing committee. I will be talking about limbal stem cell deficiency, algorithmic approach to management and decision making. We all are aware that actually the stem cells are located in the periphery of the limbus and they're protected at that area in the palisades of Vogt. These cells actually are the ones which are necessary for the maintenance of the pristinity of cornea. The cornea is a privileged immunity. It has nourishing nerves and a milieu of moisture. But for its optical function and maintenance of the barrier, live limbal stem cells, which provide the boon of avascularity, and the most important, that is a respect of cell individuality, is essential. So anything that causes this limbal stem cell deficiency, either congenital or acquired, which is by the fact looks with conjunctivalization and corneal vascularization as a hallmark, can be detrimental for the cornea. So if you see congenital causes, majority of them have PAX gene abnormality like aniridia or Peters anomaly, to name a few. But most of it is acquired. A normal cornea like this, because of either imbalance in the form of trauma, in the chemical injury, thermal injury, or because of drug reactions like Stevens-Johnson, or autoimmune disorders like OCPs, or even sometimes because of chronic inflammations, keratitis, failed grafts, can lead to this clear crystallized cornea becoming very hostile in the presence of a bad area because of absence of the stemness of that surface. So what is LSCD? It is defined either as a total or partial superficial corneal vascularization and conjunctivalization in the absence of the palisades of Vogt. So how do we diagnose? Majority of LSCDs are clinical diagnosis with thorough history and examination. But here I want to emphasize two most important aspects. One is the adjuvant impression cytology, where impression taken on a simple OPD basis can actually diagnose the altered morphology or phenotype of conjunctival cells there. And even sometimes the immunohistochemistry shows the absence of those particular histokines. Whereas enterocity is now a very essential part of our armamentarium. It is the one which actually can be used for staging the disease. It is also used for identifying the type of sector involvement, and it may show the abnormalities at different stages of the disease. So my algorithmic approach is surrounded by these three main questions: whether the deficiency is with wet surface or dry, whether it is also associated with scarring, and if it is, whether it is unilateral or bilateral. So in a patient with presence of LSCD in a wet surface, the most important parameters we know that if it is partial, usually it is managed by medical management with drugs or medicine. And if it is total, then either we go ahead with the options like cultivated limbal stem cells or go with the conjunctival limbal autografts. If it is bilateral, definitely we have to go for related or cultivated cells. So let us see what are the advantage, disadvantage. When we go for the keratolimbal grafts, the advantage is, yes, there is no antigenic load and it is very fresh tissue, but disadvantages, it can produce iatrogenic limbal stem deficiency. We can't take more than 6 clock hours. And if we see the cultivated cells, yes, the advantage is very minimal 2 millimeter of tissue is taken and it avoids the risk of donor eye LSCD, but disadvantages, not everybody can afford because lab facilities and exuberant cost for this kind of procedure. So limitation of these conventional surgical options in cases with LSCD, with wet eyes, is that if you go to see here, if you do the conjunctival grafts with limbal cells, it may cause problem. If you go for the cultivated, it's cost. If it's cadaveric keratolimbal grafts, then lifelong immunosuppressant. There was a lot about Comet. Comet could produce vascularization, and that is why it has a limited factor, though little bit modifications are there these days. So recently we have been now using the simple limbal epithelial stem cells transplantation in these unilateral cases or bilateral when we do allogenic. And here, when we don't do normally is when it is very severely dry eye, and never combine with the lid and exhale procedures. Always we have to understand that here the basis, some 3 or 4 important points is we have to understand that getting a right plane is the first indication for a good surgical outcome. And not all patients can get vision just by doing SLET. This is for those cases who have had a severe injury and have a conjunctival pannus on the surface and then in a healthy conjunctival epithelial cells on the contralateral side. So here, as you can see, once the plane is obtained, we can see a clear Bowman's membrane and underlying good stroma. And there we are procuring on the other side the cells from the contralateral eye. A traumatic provision of these cells have to be done. And then they are being placed over the surface on an amniotic membrane, which acts as the one on which these cells tend to grow. So the challenges are there in this procedure. But SLET actually, when done in the right case, in the proper way, is very gratifying. And in such cases, you may not require anything, but give them glasses or contact lens to give vision. But however, when it is bilateral, like in this case, the right eye is already undergone some procedure, left eye is something which still has a probability. The patient underwent first the symblepharon release. We did a mucous membrane graft and then did an allogenic SLET of the father. And then patient now is enjoying ambulatory vision with scleral contact lenses. So this is how the SLET is done. Now coming to when there is limbal stem cell deficiency with dry surfaces, but not so bad with corneal scarring, what do we do? So this is a case where usually persistent keratinization is the issue, symblepharon formation is an issue, or you'll see the LM case in these cases. So in these patients, doing a mucous membrane grafts as well as giving them pros lenses, like as you can see this patient in the both these cases, he improves very well and is able to live an ambulatory life with management with these adnexal problem surface and providing a pros lens. However, we end up ultimately sometimes with LSCD with scarring like this, where patient needs an additional procedure apart from just getting the limbal cells on the surface. And that is when, if it is the wet eye, usually the type 1 Boston is where we do this kind. But here we have to understand that the procedure usually is done only when bilateral involved and the other eye doesn't have visual potential is when we are looking it into consideration. And the outcomes are in short term, 3 to 5 years have been quite good with the Boston. The main challenge in chemical injuries, what we have seen is the extrusion of the processes and the periprosthetic melts. So however, this option is available and should be tried in the severe forms of cases where grafts cannot work. However, we can later look into this sometimes when they are not able to, then we may have to go in some cases for the modified MOKP or the Boston type 2 procedures where we are trying to get the tooth as the biological implant here using the mucosa. This has challenges of doing it in a stage form, but long-term outcome means severe dry eyes with limbal stem cell deficiency, the MOKP actually has got an advantage. So as you can see here, this is the stage 2, which we actually do at a staged procedure of nearly over a period of 3 to 6 months, where we initially procure, put it in the pouch, and then this is the OLA, which has been now been implanted over in the last stage. And over this, we'll be putting the mucosa and then create a small opening and give the patient an opportunity to see through this. So even though Kpros seem to be there, but they're only for the end stage cases in this. So this is how the outcomes are, and patients tend to do well, but they are a lifelong journey with the doctor forever. So last, to conclude the algorithmic approach. So my approach is like this. If there is a wet surface, if it is unilateral and mild, medical management, or go ahead with SLET. And if it is bilateral, go ahead with the allo-SLET. And if in both of these cases, anytime there is corneal scarring, give an option of staged PKP or a DALK. If neither of this works, and if it is bilateral, then we'll have to go for a type 1 Kpro. If it is a dry LSCD, then unilateral or bilateral, punctal plugs, symblepharon release, and mucous membrane grafts, pros lenses, sometimes even a minor salivary gland can act as an adjuvant to increase the wettability of surface. But if it is very severe with corneal scarring, options are very much the last ends, that is the MOKP, type 2 Kpro, LVP Kpro through mucosa, or the other osteo Kpros. So with this, I end my talk, and these are my references. And thank you. I'm open for questions.
Yeah, thank you, Dr. Pallavi. So treatment of LSCD, limbal stem cell deficiency, in the past 10 years, it has gone a radical change. Thanks to Dr. Sangwan and his group, and Dr. Geeta and her group at SN. We have a lot of options now for patients. What the most important slide from your talk, Dr. Pallavi, which I would like the audience to know, is that management radically differs whether the patient has a dry surface or a wet surface. So we cannot be doing limbal stem cell transplantation procedures in patients who have dry surface. They would not work. So the first and the foremost thing which a doctor or a treating ophthalmologist has to decide is whether the patient has a dry or a wet surface, and the treatment guidelines are based on that. Also, one thing I would like to stress here is that we should be avoiding doing limbal stem cell transplantation procedures in acute inflammatory eyes, and we should wait for the eyes to become chronic and then do these visual rehabilitative procedures. So you are working in Shankar Eye Hospital. So what I would also ask you is, what would you say to the practicing ophthalmologists on how should they be approaching doing Kpros in private practice, keratoprosthesis?
Thank you, Rajat. My threshold for Kpro from now past 10 years, I've been doing Kpros and even the MOKP since past 5 years. I feel the private practitioners should be very careful about knowing when they are planning for a Kpro. There are times where we have seen patients who have undergone bilateral Kpros, and then that's a big mess. So only when they know that they are able to follow the patient and they are able to give that commitment to the patient and educate them, that is when they should be taking up. And it should always be done when both eyes are involved and the better eyes having vision less than 660. So that is very essential, which I think the private practitioners should understand that.
Yes, very correct. So I call Kpro a Brahmastra, and Brahmastra has to be used only when there is no other option.
Yes.
So that is what has to be told very nicely to the patient also, that if you are opting for a Kpro, that means if something now goes wrong in this side, we don't have any other option to fall back upon. So all these things should be taken care. And one more last point I would mention is a will of the patient, will of the doctor. A person who is doing a lot of these procedures in private practice, I'm doing it for the past 10 years now, but then you should have a lot of time, you should spare a lot of time explaining these patients, taking care of these patients, because they would demand a lot of time in future as well. Okay, thank you, Dr. Pallavi.
Yeah.
Thanks for everything. Nice.
Thank you, Rajat.
Yeah. So with this, we come to the end of the session. We had a very nice session with interesting talks. I believe we had some interesting messages for the audience who are attending this. Thanks to the organizers of the conference for allowing me to moderate this session. Thanks to my co-speakers, and many thanks to the audience who were there. Thank you. See you. Bye-bye.
Thank you so much, Dr. Rajat.
Thank you so much, Dr. Rajat, for being an absolute amazing moderator, and all the speakers. You were amazing. Listening to you was quite insightful. Any delegates who have questions for our speakers can use the Q&A tab and send us the questions. We are here for quite some time now and can answer them in like next 2 minutes.
Do we have any questions till now?
No, sir.
So what the message we want to convey is that we are doctors first and ophthalmologists later on. So we should be taking care of the patient as a whole, not the eye only. And that is what ocular surface specialists do. You have to look beyond the eye. Okay, I think that should be all.
Sir, I think we do not have any questions, so I would like to conclude for the session. Sir, over to you for the concluding note.
Okay, thank you. I thank the organizers, the speakers, and the audience. Thank you. See you sometime in future. Bye-bye.
Thank you,
So
everyone.
much. Moving further, we have the next session on cornea potpourri, and as chairman for the day would be Dr. Radhika. Moderator would be Dr. Sharon. Over to you, ma'am.
Good afternoon, everyone. I welcome you all to this session. I request Dr. Radhika Natarajan, who is the chairperson of our session, to give the opening remarks and introduce the session and call the first speaker. Thank you so much for joining us, ma'am.
Yeah, thank you. It's lovely to see you back again, along with so many familiar faces in the panel. And I've been really bowled over by the earlier few sessions, listening to perspectives from across, this part of the globe. So to continue with this, we have a set of interesting talks today. And I request you to start the session yourself, Sharon.
Okay. So we have a very interesting set of different talks across ranging, as the session name suggests, cornea potpourri. So, and I think it would be very useful for all our audience and us. It's always a learning experience for each of us as we join sessions, learn from each other. So without further ado, I request our first speaker, Dr. Aditya Pradhan, who will be speaking on a topic which is very important, that is of managing Descemet's membrane detachment. Over to you, Dr. Aditya.
Yeah, thank you, Sharon, for the introduction. I'll just share my screen now. Yeah. So, are the slides visible?
Yes,
yes, yes.
Yeah. So, moving on, I thank the organizers, Dr. Sharon and Dr. Radhika Madam, for the very kind invitation and the inclusion in the session. So I'll be focusing primarily on the Descemet membrane detachment, which is seen after cataract surgery. How do we recognize it and how do we manage it? I have no financial interest to disclose for this presentation. So as the talk proceeds, I will be taking you through the introduction, the risk factors, the clinical features, how do you image the DM, and how do you classify and manage it as well. So basically, as we all know, the Descemet membrane is the basement membrane of the corneal endothelium. The endothelium is a monolayer of cells which rests on this. It is around 8 to 10 microns thick. Way back in 1927, VV identified and named this typical condition. But in 1928, Samuels was the one who gave us the first systemic classification. The factors are many which are implicated in this, but basically a weak adhesion somewhere in the Descemet stromal interface is one of the primary etiologies of having a Descemet membrane detachment. Also, certain dystrophies like Fuchs endothelial dystrophy and PPCD are also implicated as being more prone to having a Descemet membrane detachment after any intraocular surgery. So the risk factors can be divided into three. One is the preoperative, one is the intraoperative, and the other are the post-operative or the delayed causes. So right from the beginning in your evaluation, if you see the patient is quite old or has a very dense cataract, or there is lack of inadequate anesthesia during the surgery, or there is a previous history of chemical injury or neovascularization, these are all red flags, and you should be very well prepared that these patients are more prone to having a DMD on the table. During performing the surgery, especially cataract surgery, if the clear corneal incision is either too small for the instrument to pass through, or it is oblique, or it is ragged, mostly this happens because of the blunt instruments which are being used, or while putting the instrument or removing it from the anterior chamber, you apply too much of pressure. The total ultrasonic time, if it is more than 60 seconds, is also well-known risk factor for causing a DMD. in the post-operative period or the delayed causes it. Sometimes it occurs spontaneously or bilaterally because of the dystrophies I have mentioned earlier. Also, unrecognized corneal ectasia, especially when the patient has become senile and has come to you for a cataract surgery, can also predispose to having a DMD. Also, the dystrophies like mentioned before. So the symptoms are basically the patient will tell you that there was hardly any visual improvement after the surgery, or there is a gross diminution of vision after the same. And if the patient is quite observant, they may tell you that there is something white which has appeared over the cornea, which was not there before. It can be either very focal or diffuse whitening. There can be a very gritty or a foreign body sensation due to corneal edema and subsequent watering as well. But what you see on the slit lamp is basically, if you make a very fine slit, you will see a translucent membrane which is present in the anterior chamber. And on the left side, you see a diffuse corneal edema. On the right, you have a very focal edema. If this keeps on persisting in spite of your treatment, that is basically more than 2 weeks, you should definitely have a high index of suspicion for a DMD. Sometimes a double anterior chamber may be seen as well in a very extensive descemet membrane detachment. So how do you image the same is basically we have 3 tools with us. One is the gold standard, that is the anterior segment OCT. Also, you can employ ultrasound biomicroscopy or a gonioscopy for more peripheral descemet membrane detachments. But for all practical purposes, a thorough slit lamp examination, and if you have access to ASOCT, nothing like it. So the management is basically either conservative or surgical. So in conservative, you have the application of hypertonic saline eye drops and eye ointments to reduce the corneal edema. However, there are no studies which show that these treatments do definitely help in the reattachment of the DM. Also, topical steroids do help in reducing the inflammation, which may give you a clearer view of the anterior chamber and help in a better examination. In the surgical method, you have the desmetopexy, which is the current gold standard of management. Desmetopexy can either be done with the injection of air into the anterior chamber, or the isotope expansile concentrations of either C3F8 or SF6. You have mechanical tamponade in which you fill up the anterior chamber with a very high viscosity viscoelastic, but that is not currently being used by many of the ophthalmologists. You have a transcorneal suture fixation, which has been described in the literature, but again, not a very popular method, maybe tried as a last resort in very extensive DMDs. You have desmetotomy, in which you give relaxing incisions if the DM is fibrosed. And last not but the least, if everything fails, you have to resort to either endothelial or a full thickness penetrating keratoplasty. So I'll be focusing more on the desmetopexy part of it. But before that, when would you like to conservatively manage the patient? So basically, if it's a small peripheral planar DMD in which the edges are not scrolled yet, or even if it's a non-planar DMD with non-rolled scrolls, may also respond to your conservative management. So this article in 2015, they designed something called as the HELP protocol, in which the height, the extent, and the length of the DMD was classified into 3. And the height was classified again into 3 zones from the distance from the pupillary center. And then they took a decision whether to medically or surgically manage the patient. So anything which falls in either of the 3 zones and which has a height of less than 100 microns and the length of the DMD is less than 1 millimeter, you can consider for medical management in zone 1. In zone 2, it can range between less than 100 and again less than 1. If it is between 100 to 300 microns, the total height of detachment, and the length of detachment is between 1 to 2, you can again consider it for medical management. Similarly for zone 3 as well. But when do you go for surgical management? If it's a non-planar DMD with a scrolled edge, the length of the DMD is more than 2 millimeters as seen on the anterior segment OCT. If the DMD is involving the visual axis, and all those DMDs which you have tried in the previous slide and tried a conservative therapy but have failed to respond, and now the time has come to do the surgical management. So there are 2 different algorithms again available in the literature. One is the ASOCT based algorithm for the DMD, and again the second part of the HELP algorithm in which the surgical management is done. So another classification was given by Susan Jacob et al., in which The analogy of the DMD was given to that by used by the vitreoretinal colleagues. So terms like rhegmatogenous descemet detachment, tracheal descemet detachment, a bullous detachment, and a complex detachment have now entered into the lexicon of the corneal specialists. And based on the configuration on the ASOCT and the slit lamp, you have all these different options to manage the DMD. So another new article which has come in the recent past, that is in 2020, is that they identified the types of DMD depending on the involvement of the predescemetic layer. So there was type 1 in which both got detached, type 2 in which only the DM was detached. And the mixed one was the layers were detached like in type 1, but they were also separated from one another. And then depending, they were further classified into rhegmatogenous or non-rhegmatogenous, depending on the absence or the presence of a tear in both the DM or the PDL. So definitely the discovery of the PDL has changed our understanding of the DMD part as well. So desmetopexy is basically the injection of a gas into the anterior chamber, first described in 1967. It is the current gold standard. However, air just given into the anterior chamber gets rapidly absorbed. So these new gases were borrowed from our retinal colleagues, that is 14% of C3F8, which lasts for 6 weeks in the anterior chamber, or 20% of SF6, which lasts for around 2 weeks in the anterior chamber. So basically, if you use this, you have a reduced need for repeat injections into the anterior chamber. But keep in mind that a micropore filter must be attached to the syringe when you are withdrawing these gases. So what are the steps and the pearls in doing this desmetopexy? Basically, first identify the type and the location of the DMD via thorough slit lamp examination. If you have access to an anterior segment imaging system, nothing like it. Do the anterior chamber paracentesis via either a MVR blade or inject it directly into the anterior chamber via 26 or a 30 gauge needle. Keep in mind this entry must be opposite or very away from the site of the DMD, which you have marked, and where the DM is actually still attached. Slowly inject a single continuous bubble of gas, achieve a complete fill for around 15 minutes, and then reduce it around 8 millimeters bubble size. Suture the side port as well. An inferior PI is mandatory if you are planning to discharge the patient with a complete air fill. Please beware, never inject forcefully or suddenly into the anterior chamber or especially at the area of the DMD. Beware if there is any vitreous in the anterior chamber. Avoid multiple small bubbles. Try and achieve a single bubble into the anterior chamber. To that purpose, a 1 ml insulin or a tuberculin syringe compared to the larger capacity syringes is more than enough. The entry should be just enough to accommodate the width of the cannula if you are using one. Please ensure there are no leaks. So the entry must be very small. Pupillary block has to be recognized. It is present in around 11.6% of the cases. Uret-Zavalia syndrome can also occur in the cases of desmetopexy. If you don't recognize that there is some predesmetic fluid, either aqueous fluid or viscoelastic present, if you don't remove this, the DMD will never resolve. And please ensure that the IOL is actually stable before injecting the gas. Many of these cases are referred from surgeons. The surgery is done elsewhere, and we actually don't know what has happened in the anterior chamber because of the poor visibility. So if you suddenly forcefully inject the air, the IOL, if it's not stable, it may drop into the vitreous cavity. So I share 3 cases which I saw in the past around the lockdown period, 2 years or so. So this lady was referred for cataract surgery done elsewhere with a non-resolving central corneal edema. So if you see just on the broad illumination, the edema is present, but once you make a slit, you see this nice desmetic detachment hiding behind, also seen on the anterior chamber. So you just go in and inject air very slowly. So this photo that has been immediately taken after the air has been injected. In our institute, we follow this protocol just to make sure that the DM is actually attached and there is no fluid in the supradescemetic space. And these photos are at 1 week of presentation. There is some subconjunctival hemorrhage, but the cornea has improved dramatically as shown by the ASOCT. As you can see, this is the incision site from which the DMD actually originated to begin with. And this is the photograph at around 3 months after the desmetopexy. The cell count has definitely gone down. So this is another thing to keep in mind when handling these cases. So this is the second case which again presented to us with a small central striate keratopathy. Looks innocent on the diffuse illumination, but once you make the slit, you see a small descemetic detachment. We waited for a week, tried conservative management, it didn't resolve. The ASOCT revealed a more extensive DMD than what was seen in the slit. So we decided to intervene and inject air. So this is the bottom picture is immediately after injecting the air. We have a complete airfill, the DM is attached. This is in the evening when the patient was about to be discharged. You can see the volume has drastically gone down, but the cornea has cleared considerably. And this is around 7 weeks. The BCL has been put in place and the cornea is considerably cleared. And the last case in which there was again a diffuse corneal edema, but you can see this very straight line behind the corneal section in which the DM is detached, but it is more than a month old and it has become fibrosed and taut. So this management requires something else. However, before it came to the clinic, it was managed at 2 different places in which first a air injection was done, nothing happened. The trampoline effect, the DM stayed taut. Then a transcorneal suture fixation was done. But again, as you can see, the DM is as it is. The sutures never pass through the actual DM detachment. And now, at the last resort, a descetotomy was done in which an inverse cystitome was used and a 360-degree relaxing incisions were given throughout. And you can see immediately after the complete airfill was achieved, the DM has attached quite well. This is around at 1 month of follow-up in which the cornea is cleared up considerably. The cell count expectedly has been less because of the repeated interventions, but at least a major surgery was avoided. So at the end, even if the initial surgery fails, the descemetopexy fails, it is worth going inside again and doing a repeat descemetopexy rather than going straight forward towards a PK or a EK. Just identify the configuration of the DMD before doing any more surgery. So DMD is not uncommon, it is sight-threatening if not recognized and managed on time. We need a thorough pre-op slit lamp examination. Watch out for any corneal dystrophy in the other eye as well. Sharp instruments are needed and use less ultrasonic energy and time. If the persistent edema is seen, please have a high index of suspicion for a DMD. Use ASOCT if available to you. But the management is customized as per the case. There is no one size fits all. And if in doubt, refer to your cornea colleagues on time. Thank you so much.
Aditya, that was a very comprehensive presentation. I'm sure all general ophthalmologists, even cornea surgeons, would have benefited by that. So you brought home all the right points as to how recognition of a DMD is first of all most important, because if we don't recognize it, there's every chance we will exacerbate it. So if you recognize it, probably you can use the opposite port or you can use the light pipe to identify where it is and so on and so forth. And once you recognize it, the management will entirely, like you rightly said, depend on the duration of the DMD and the morphology of the DMD. You beautifully showed cases where it was caught immediately versus late. And, the fibrosis made all the difference to whether it will go back or not. The couple of quick questions I have for you are that you seem to have used air in most of your cases and they all seem to have done well. So do you have a logic whereby you decide to use air versus gas? And if so, what could that be? And in these cases of DMD, where you work with very limited access, you could probably be making 1 or 2 ports to enter the eye. How would you do the pupil and the PI management? Or would you consider that important at all because you're only using air, which is short-lived?
Yeah, so answering the first question is air versus the isoexpansile gases. If it's caught on time, like a so-called fresh DMD, so to say, in which the DM is still mobile and not fibrosed and the anterior chamber inflammation is not so much, I would still go in with air rather than use the isoexpansile glasses. Because if you just wait for around 15 minutes or so with the complete air fill, it is more than enough to attach the DMD from. This is rather from our experiences with endothelial keratoplasty, in which tamponade of around 10 to 15 minutes does attach the lenticule. But with the the final case which I showed, in which the DM was fibrosed and taut, and we had to give those relaxing incisions, I would rather give a more longer duration acting gas like SF6 or C3F8, in which there is maybe a propensity for the DM to again fall back due to a rapid absorption of the air. And regarding iridotomy, no, because we are not doing it primarily because we are doing these cases basically in the morning and the patient is discharged in the evening. So before discharge, we are seeing the patient, and on table, we are reducing the air bubble to around 8 millimeters when the patient is shifted to the recovery room. So the chances of a pupillary block, especially with just plain air, are quite remote. But if you are planning to use a longer acting gas, it is a good idea to do a inferior PI, either with a vitreous cutter if it is available, or if the view permits beforehand, you can even do it with a glaze.
Right. I totally I'm on board with those concepts over there, because the air of the gas works as well as the endothelium works basically. So the physical pressure is not going to do anything as long as the endothelial pump does not kick in to kind of attach the DM back. That's the major force that attaches. So we're just giving the crutch support in the form of this injection. So like you rightly said, the healthier the endothelium, the earlier the detachment air itself will do the job, versus if it is limping back to normal, then you need to maybe use longer acting gases. A couple of quick points that I might also want to add are that the concept of pre-Descemet's layer has also thrown some insight into our method of repair, where in cases like hydrops which are causing the DMD, where almost always the pre-Descemet's layer is also involved, Duval's layer is also split when the fluid gushes inside, there maybe there is a role for compression sutures in the stroma alone rather than dealing with the Descemet's. Of course, that won't work when PDL is intact and the Descemet's is detached, and there is no role for compression sutures over there. And the other important investigation that I usually do, besides the very relevant ones that you mentioned, is the basic slit lamp photo of the patient. Because sometimes I find that very, very useful to have it on table for me to know the attached from the detached area. Because you look at it like this, the patient is on the slit lamp, they're photophobia because of the bullous keratopathy, because of the corneal edema. And with the slit beam, you really don't know where the Descemet's is attached and detached. And intraoperatively, unless you have an intra-op OCT, it is not possible to delineate that area. High contrast, low illumination photography on the operating table helps me to understand the detached from the attached area. And this is many times very useful if I have to do the suturing, because the case that you showed that was managed outside, the sutures had just not touched the DM at all. So for the DM to get engaged, you have to always go from the attached to the detached area. So when you're going from attached to detached, you're 100% sure that you're impaling the Descemet's membrane. And that delineation becomes very, very easy to make when you have a nice, bright, contrast photograph with you, is what we have found. So those were excellent points over there. So we'll move on to the next talk, which is by none other than our dear Sharon, who's an excellent clinician and researcher and speaker herself. So I'm going to invite Sharon to share her talk on pearls on DALK for us.
Before I start my talk, I didn't do justice, I think. Dr. Aditya is a senior consultant at Disha Eye Hospital, and they do a huge volume of excellent work in that part of the country. And as you can see from his talk, he really brought out some very good points which are loaded with clinical experience and judgment. And Dr. Radhika is a very, very senior teacher to a lot of us. Senior ophthalmologist, professor of ophthalmology and deputy director at Shankar Nethralaya, Chennai. And she's really, given us so many pearls of wisdom whenever we've had discussions on clinical cases. So with that, I will move on to my talk. I'll just share my screen.
Thank you, Sharon.
Right, are my slides visible?
Yes, ma'am.
Yes. Okay. So deep anterior lamellar keratoplasty is a surgery which has over the last many years become more and more popular. But somehow, as compared to the other lamellar keratoplasties, it somehow often takes a back seat. And we'll be discussing a few reasons why that may be and how we can get the best outcomes out of this surgery. So obviously, we all know why we prefer a lamellar keratoplasty, and that's because once we are not touching the endothelium, leaving behind a part of the patient's cornea, we reduce the risk of graft rejection significantly. Because it's not a full thickness surgery, there is excellent wound strength. And that really shows up because we've had patients where they've had a trauma to the eye post keratoplasty, and in spite of that, even though the graft host junction opens out, at least we know that it's not an open eye. There's less risk of intraoperative complications, that being, mainly like expulsive, or when there's a very high eye pressure, then we're not that concerned about those kind of complications. And the recovery time and healing time is faster and very good in these patients, and especially because we do DALC very often in slightly younger patients who have keratoconus. Then in these patients with the higher risk of graft rejection, it's always a little reassuring if we do a lamellar procedure. Also, we have noticed a very high, chance of many patients being steroid responders or getting, the rise in eye pressure due to the steroids. So if we are having a procedure which is lamellar, we can then taper the steroids a little faster. So the indications of DALC are fairly varied, but basically any pathology which affects the anterior mid or deep stroma, leaving behind a fairly healthy endothelium DM would be our indication. That's not absolute. We still do DALC in some cases where there is a minimal affection of the DM endothelium in terms of a scar. But of course, other areas where there's a lot of cellular changes would not be ideal. So of course, advanced keratoconus is one of the most common indications, various dystrophies and other ectatic conditions. So when we are planning the deep anterior lamellar keratoplasty, of course, we need to keep in mind what is the underlying pathology that we have. As I said, it has to be something which is restricted to the anterior mid or deep stroma, leaving behind a fairly healthy endothelium. It's always useful to know the depth of scarring or the pathology, and that is judged both at the slit lamp, very, very importantly, and if you have access to any imaging modalities like the anterior segment OCT, it also helps to measure the depth of scar. So very often at the slit lamp, when we look at the patient, we may note a scar, but it's important to note down the size, the depth, and if there is any endothelial involvement, a good idea to mark exactly where. For example, even if there is a scar post hydrops or post any infection of the endothelium, it's important to note whether it's in the visual axis, what is the size, so that if we choose to do a manual lamellar keratoplasty, we would still know whether the residual scar would be in the visual axis and affect our visual rehabilitation. So it's important to note this rather than just note down on something like an apical scarring. Even if there is a scar, it's important to note and differentiate a hydrop scar from a non-hydrop scar. The reason being, if we feel that this patient has had an acute hydrops where there was a rupture of the DM endothelium at some point, we may choose to avoid a big bubble technique of doing the DALC and go ahead with a manual dissection in these cases. So there are various DALC techniques which have been described. The Anwar's big bubble technique is probably the most popular and followed a lot, but there are a lot of very useful techniques, including the manual dissection techniques of various forms. And I do believe that we need to understand and master multiple of these techniques, and then you really feel confident of doing this surgery, because you never know what may get thrown at you during the procedure. I think one of the best things about this surgery is that you don't really need too many fancy instruments or gadgets, and most of it would already be available to us in our ORs. What you do specifically require for this surgery is either a guarded depth knife or a trephine where you can, like a suction trephine where you can mark out how deep you're going into the stroma. We definitely need something to do the bubble, so either a 30 gauge needle or a cannula for that purpose. Blunt tip scissors, I think, are extremely useful. They may not be essential, but they really make dissection much easier on the surgeon in that sense, on our nerves, because the chance of you rupturing inadvertently reduces, and the rest is fairly straightforward and simple. You could also get various dissectors that are available, but again, they are not at all, they're not essential for you to perform the surgery. So we'll just start with the basic big bubble DALC procedure. And as you can see, I'm just showing the DALC part. And what you have to really concentrate on is when you're doing the procedure, look at the tip of the needle or the instrument. So what is important is the location, the direction, and the depth. As beginners, very often we may feel concerned of going towards the center of the cornea because we know that to be the thinnest part of the cornea. So we tend to go towards the periphery, but what will happen is that you may not be able to achieve the desired depth, maybe too superficial, and then you'll just develop a lot of opaque bubbles and not the big bubble per se. Okay, to try and decide the depth once, so in this video, you can see that I've already removed the anterior lamella, and that I do by usually taking a 300 gauge depth knife, 300 micron knife, then, marking it out peripherally and then dissecting at that depth. However, most of our cases would be less than 300 microns. So when we reach the center, the thinnest point, you have to be extremely careful that you do not inadvertently perforate right in the first layer. The advantage of doing that first layer of dissection is that it's much easier to get to your depth or the correct depth to get your big bubble much more easily. Of course, a lot of surgeons do directly inject the big bubble without doing the anterior dissection. The next point, once you've achieved your big bubble, it is important to release the bubble. That is the next step. And if we understand the anatomy of this whole scenario, we now have an anterior layer, which is formed by the posterior part of the stroma, and an inner layer, which is formed by the DM endothelium complex. And depending on whether you have a type 1 or type 2, your predesmatic layer could also be with the inner layer. So now, and the air bubble, the big bubble which you formed, is between these two layers. So we have to release. So it has been dissected, but we do need to remove that residual posterior stroma as well. So that is the next step of posterior dissection. So few things which are important here. You can see that I have put one small amount of viscoelastic on the central part of the cornea. And now I'm doing a paracentesis. Both of these points and both of these steps are to try and reduce the pressure of the eye so that you do not have a very rapid egress of the air. In case we do not reduce the pressure, the bubble, when we release the bubble anteriorly, the bubble can come out very suddenly, and you may inadvertently nick the inner layer as well with the tip of your instrument. The viscoelastic also helps to prevent this sudden release. So once the pressure is little reduced, you can see now it's called the brave slash because you have to blindly go and make a nick. So I'll just repeat that. You can see that there's a egress of aqueous. This again is a very important step. So after we do the paracentesis, we put in a small bubble into the anterior chamber. And this double bubble, that is the bubble, big bubble which is there, and the bubble in the anterior chamber, as you can see, the bubble remains in the periphery. This tells us that your big bubble is still intact. And even though here it's quite evident and very easy to visualize where the bubble is, sometimes if you get a very large opaque layer in addition to your big bubble, it becomes difficult to anticipate or see where your bubble or whether the bubble has released. So by the movement of the peripheral bubble into the center of the AC, you will be able to know that you have properly released the bubble. The next step is the posterior dissection of the stroma. And this step has been, shown. You'll have seen multiple videos where after the brave slash is made, you basically divide the posterior stroma into quadrants and remove the residual stroma. The few points to keep in mind here, of course, I said the blunt tip scissors are very useful. The air bubble in AC helps us to make sure that we've not made any microperforation, because a sudden release of air would be very easily visible. One point which is different from a penetrating keratoplasty is that here we avoid too much of fluid being poured, unlike a PK where we would like, our assistant would be pouring fluid. Here we would avoid it during this dissection. Keep a dry bed so that if there is any microperforation, that fluid is immediately visible and you can handle it well. Now, what are our alternatives? So when there is a deep corneal scar, it does not necessarily mean that we go ahead and do a penetrating keratoplasty. Wherever possible, you would still try to do a manual dissection, or as long as the residual scar is not too long. So we have to make a very good assessment of it. In a post-hydrops case, as I mentioned, it's probably better not to try a big bubble, because the force of the bubble, the pressure of the bubble could cause that break to reopen. In these cases, the manual dissection, which can be either malaise or the groove and peel technique, are very useful. And I do encourage everyone who is doing DALCs to always know these techniques, especially in the starting stage. If you don't get your bubble, you can fall back on this technique and still get excellent results in your visual outcomes post-operatively. So when all goes well, it's very nice, but there can always be challenges with the bubble. So be aware of which instruments. You may get past a sharp instrument, or you may get past a tooth instrument. So you need to be very aware. Be aware of the direction of the air and the pressure required and the type of tissue separation. So how do I know that the bubble will form? So this is something that I found quite useful when we are training people. And if you look at that video, you see that there's that just like a blotch of opaque bubbles which forms and stops. If I continue to inject in that same area, that bubble is not going to form, because there is no directionality to it. There's just a, like a whole clump of bubbles. In contrast to that, please note the other video. And I'll just slow it down a little. But if you can look very carefully, at these edges, there are these spokes which are starting to form. And that usually would imply that your bubble is then separating the posterior part of stroma and going between the posterior part of stroma and into between your DM and endothelium. And then you are more likely to get the bubble. So even though normally if you see they both start very similarly, they both have a blotch of opaque bubble here. And ideally, I should have stopped it, especially because the bubbles are then tracking back and coming to the periphery. So these are standard things that we say the bubble would not form. But if you see these spokes coming forward, then it means that your air is tracking into the right space. And if you keep injecting, your bubble is then going to form. And this is very helpful, especially in extremely thin corneas, where there's not much of stroma to separate, and the bubbles tend to form more of the opaque bubble layer. The next question that many people ask is, how many times can you try the bubble? And there's really no hard and fast rule to it. But in this video, you can see that we try multiple times. Okay. The ideal way would be to avoid the area where you tried already, because the air would tend to keep tracking into the same area. But just try to understand why the bubble is not forming and then get. So this is the situation where I was saying, because of the amount, the bubble did form, but because of the amount of opaque bubble layer, it's very difficult to assess. In such a condition, even when you release it and you're doing the posterior dissection, it is much more difficult to visualize. And the air in the AC gives a good idea of what is happening with your bubble. Now, one more very important thing to realize is what to do when your air enters the anterior chamber. So please note how the air is coming in. Okay. So if you see in this case, the air is coming in from the periphery. Okay. So our worry when we see air in the anterior chamber is whether the air is, we made a microperforation and injected air directly. So you just have to look at the direction of entry, and if it's coming in from the periphery to center, it's actually air which has tracked, as you can see, it's tracked peripherally along the edge of the cornea, the limbus, gone through the trabecular meshwork and come into the anterior chamber. So in this case, you can still try for your bubble in a different area. If you've got the bubble directly coming into the center, then you may have made a microperforation. And in that case, it's better to go ahead with a manual dissection. The last thing is that what can happen is you made your brave slash, but it was not large enough. And so your needle does not, your scissors is not going into the right space. So you can see that there is a brave splash, but actually the posterior part of the stroma, the opening is extremely small, and the scissors is not able to go into that small area to further dissect. In this case, you can put in a small instrument. In this case, I've used the needle to increase the size of the slash, only that, that final DM, just probably, there's the posterior stroma, and then you can continue with your dissection. So these kind of, point ideas to sort of save surgery do help. If all else fails, you can go ahead and do a manual dissection. And this I specifically put in to show that at maybe the initial recovery is slower, but even with manual dissection at around a year, you're not going to make out too much of difference between them, not even on the anterior segmentosity, not in their visual recovery. So it's definitely a good idea to do a manual dissection as long as you can go deep enough, maybe to 50-100 microns. It's not that the surgery does not have complications associated with it. You can still have perforations, and in that case, then be careful. You may develop a double bubble, a double AC the next day. If you have to leave a bubble behind in the anterior chamber to tamponade, you can get pupillary block glaucoma. Many of these patients have surface-related issues because of allergies, so you can get graft vascularization and stromal rejections. But still, these are things which are manageable, and these patients do well. So thank you very much for a very patient listening, and I'm open if anyone would like any questions.
Thanks a lot, Sharon. You spoke of me as being a teacher, but you seem to be the better teacher over here. So thank you for that step-by-step elucidation of each possible thing to expect and its complication. I was especially blown over by that particular segment where you showed the branching out of the air sign. It's something intuitive that we know, but you brought it out so beautifully that people will look out for it. Since the surgery itself was spoken of in such detail, I have a couple of quick clinical questions in the same context to you. That in this day and age of PROS lenses, I'm finding that increasingly a lot of keratoconus patients are benefiting with PROS contact lenses without the need for surgery. K-conus seems to be our primary indication for DALC surgery itself. I've also found that especially when keratoconus progresses in terms more of ectasia than scarring, because ectasia and scarring are the two ways that a cone can progress. When the ectasia is more and the scarring is less, the PROS does a very beautiful job. But then these patients also have very low pachymetry sometimes, which precludes them from undergoing cross-linking. We now have the custom procedures here, but even they have not caught on fully. So my question to you is that if you have a patient in whom the PROS lens improves the vision, but the pachymetry is too low for any kind of cross-linking, do you continue the patient with the contact lens because the vision is good, or would you opt for DALC because tensile strength is less?
Actually, what you said is so relevant with the PROS lens. So the scleral lenses give fantastic vision. Even in a scarred eye, actually, we are amazed sometimes by how well they see. I think our decision-making would depend on multiple factors. One is if it's a very young child or a very high risk of progression, then we'd keep keeping a very close watch on this. But if they're already very thin, and not even with all our options of thin cornea cross-linking, we cannot cross-link them, then we would explain that whole choice to them, saying that we cannot cross-link. Your only option is to eventually have a transplant, but we need not jump to doing a transplant if they're okay to wait for some time. It's not that everyone in that age of progression progresses. We found a lot of people who, don't progress, even though we may see the various risk factors. So there's no harm waiting if they are too thin to cross-link. The next thing is that if they are not in the age of progression, or we know it's a stable eye, but it's already very severe, I always tell them both options. So the surgery and the contact lens, and give them the choice of it. And, even if sometimes do a trial, a contact lens trial, because many of them may not be aware of how much their vision can improve with the contact lens. They've always been used to their glass vision, and they can't believe that your vision can be that good. So it's important that they see and understand it, because the thought of contact lens, and especially these large lenses, are sometimes daunting for them. But when they see how good their vision can become, then sometimes they switch and say, okay, maybe it's worth that effort. So a lot of different factors in the judgment, but yes, it has definitely changed the way we, rehabilitate many of these patients.
I'm totally on the same page there, that giving a trial of contact lens helps, because here the concept of pinhole vision is the maximum improvement does not apply in keratoconus. So I also give them what is called as a trial. Sometimes, they pay only for the trial and not for the lens itself.
True,
so that later the adaptation can kick in. And the point that you made about progression also, I have found that daunting for myself, because 250, 300 Paki is the stage where progression becomes difficult to assess. I'm sure you'll agree with me that extremes of ends of keratoconus, the very early form festive ones and the very advanced scarred ones, progression becomes where all the tests fail in those extremes, and it's very difficult to record the progression. So I think if contact lens does a good job, we will make every effort to make them use it. And of course, do the surgery for the ones who can absolutely not tolerate or not willing for it, even though we might have explained everything. One last question. I know we're running short of time, but I can't stop asking you questions. So one last question to you is that now seems to be, the fancy for stromal lenticule surgery in keratoconus. While earlier thought process was that if we remove all diseased tissue, then the interfaces become more clear. So tensile strength will anyway build how much of a tissue you add, but the original tissue has to be removed for the interfaces to be clear, was the original thought process which led to DALC. But then the lenticule surgery has changed that notion, because you have not one but two interfaces over there. So I'm sure being a master surgeon, you would be a right person to tell me, given a choice between the two, how would you choose?
So again, ma'am, depending on the tensile strength, definitely, as you said, whatever we add, it's going to add the tensile strength. If there was significant amount of scarring associated with the thinning and ectasia, then obviously we have to remove that scar to try and get the visual optical axis clear. If not, without the scar, then the Bowman's inlay or those kind of inlay procedures definitely have a role, if temporizing, if not anything else. But I think that that interface, intuitively, I think what's happening is that that interface and the scarring which is there also helps to stop the progression of these cases. And then, of course, the additive effect of the tissue. So, and the scarring doesn't seem to be very visually significant. But
right, I agree with you, because if you break it down and see, CXL itself is a controlled scarring procedure. Yes. So maybe the same effect is got by. And how many of your DALC patients, I'm curious to know, still need contact lenses after suture removal? Does DALC always guarantee contact lens freedom in your hands?
No, ma'am, absolutely not. So, and that is again something that is very important to explain to them. We are not expecting them to be absolutely spectacle or contact lens free. But one thing which can happen is that if they had, redid only a scleral lens, then we may be able to fit them with some smaller lenses. RGP lenses also may fit them, because the curvature is so much more regular. And of course, their spectacle corrected vision does improve. It may not go to 6.6, but what was a CF 3 meter not improving will definitely, improve to 6.24, 6.18, 6.12, 6.9. So that is the amount of difference, but definitely not 100% contact lens or spectacle free.
Right. So the dependence becomes lesser and the fit of the contact lens becomes easier.
Improves
is the point that you're trying to make. Very well explained. And thank you so much, Sharon. And I hand the baton back to you to take the meeting forward.
Thank you, ma'am. Our next speaker is Dr. Charita Puranik, who is a consultant at Virinchi Eye Care. And the great thing about Charita is that she is not only a clinician, but also a researcher par excellence. And she has, even in private practice, she has made it a point to do a lot of basic science research. And I now see that she has her own clinic as well, Dr. Charita's Oculus Regeneris. And we welcome you, Dr. Charita, for your talk on new drugs in cornea.
Thanks a lot, Sharon, for inviting me to give this talk. Thank you, Dr. Radhika. So far, the session has been going great. And I've been admiring my presidents, Dr. Aditya and Dr. Sharon's presentations. Today, actually, in this potpourri session, I'm going to talk about the newer drug in cornea. So I had the opportunity of going through side effects of Ripasudil as case submissions for the previous Saocon 2021, which just happened. And in that, we came across a lot of cases of honeycomb epitheliopathy, which were being used off-label for corneal indications. Now, I'm going to share with the kind permission of the participants of Saocon also these images. So we received, Dr. Nikhil Gokhale saw this patient who received Ripasudil, Netrasudil for around 2 months, the indication being Fuchs dystrophy. And after 1 month of use, he noticed a slight diminution of his central vision. When he presented, he was already on Ripasudil for the last 2 months. On examination, we can see this reticular epitheliopathy almost bisecting the pupil or even covering it partially. On stopping of the Netrasudil, it took almost 2 months, after which the honeycomb pattern on the microbullate disappeared. Now, the second case is that of, again, Fuchs dystrophy, wherein Dr. Rajesh Vogla has performed a desmid stripping only and started the patient immediately on Ripasudil. Now, post-operative day 3, this is the image wherein we can see overlying the area of stripping, we can see the reticular pattern, honeycomb reticulopathy pattern, whereas the peripheral cornea seems to be pretty much normal. This is again documented in the anterior segment OCT. Third scenario is again Dr. Nikhil's case, wherein the Fuchs endothelial dystrophy with the cataract, and you can see that there are reticular pattern epitheliopathy in the periphery and more of pseudophakic bullous keratopathy, sort of bullous keratopathy-like lesions in the center. This is another case shared by Dr. Uma Sridhar, whom she had started on Glanatex. So thus far, we've been discussing the pharmaceuticals manufactured in India. Dr. Uma has started using Glanatex or Ripasudil manufactured by the Miyagi pharmacy from Japan. And I think this is one of the longest follow-ups that I have encountered. So she started the patient on Glanatex in 2018 and has managed to look at the specular microscopy at all the stages and image almost the same points at all times. So she has shown that there were improved counts in the peripheral areas. However, in the central area, there was a slight decline. And the patient, as long as she was on Glanatex, was noting an improvement in the quality of vision, although it didn't actually translate into either the number of endothelial cells or the thickness of the cornea. But as soon as the patients was shifted on the pharmaceutical manufactured in India, developed raccoon eyes, conjunctival hyperemia, and intolerance to the Ripasudil, and therefore discontinued. This is one of my own cases wherein the patient has a long history, actually, post cross-linking, which was done for a very thin cornea. So there is unindicated cross-linking that was done elsewhere and then presented to me because of the central scarring and a high cylinder. So when he presented to me, he had this central haze. And then after a couple of years, he also developed endothelial cell loss as compared to the other eye. So here I'm showing only the right eye endothelial cell density, that is 2029, as compared to his normal left eye, which was almost 2700. So considering that there was there was the beginning of endothelial cell loss in that eye, and he was also being very photophobic and symptomatic, I started him on Riposudil. Now, 6 months after Riposudil, he actually became better symptomatically, and in fact also did not develop any epitheliopathy for that matter. So now we have a lot of case scenarios that I have shared in this last 5 minutes, wherein couple of patients have developed the honeycomb epitheliopathy, and my patient and the previous patient have not developed any epitheliopathy. So that brings us to the question of and also we have seen spontaneous resolution of the epitheliopathy in some. And in the DSO case, Dr. Fogler shared that he's anticipating that the patient will recover. So that brings us to the question of when do we use this now, this drug, this new thing that we have in our hands? What are the indications? There are a lot of situations, and more commonly in our scenario in India, we see iatrogenic endothelial cell loss rather than Fuchs endothelial dystrophy. So do we use it in diffuse or focal or gut age changes? When do we use it? Now, if we look back at the mechanism of action, so we know we've been taught all along that the endothelial cells are stationary, arrested in the G1 phase of the cell cycle. So the ROCK inhibitor, in short, instead of going into the molecular level, I'm going to say it actually pushes the cell to re-enter the cell cycle and then multiply. So it has been shown and to promote wound healing of the endothelium, and it's been effective at preventing post-cataract surgery decompensation. And it has also enabled cell-based therapy by which they've successfully injected endothelial cells in Japan. And the molecule itself regulates cell cycle, cell migration, proliferation, and its apoptosis as well. And one of the first publications of use of the ROCK inhibitor was by Okamura et al. Now, what they have done is they've created an endothelial cell damage model in monkeys, and half of the endothelium, if you can see here, has been destroyed. In two sets of animals. So the first set of animal was the control group, which received only phosphate buffer solution as topically 6 times a day, and the other group received the ROCK inhibitor suspended in phosphate buffer solution. And obviously, you can note that the group that has received the ROCK inhibitor has improved drastically in the period of just 14 days. Now, the next, if we look at the available data in human studies, we can see this publication from Japan, wherein they have studied the effect of Riposudil in patients post-cataract surgery. So this is actually, although the label itself is pretty deceptive, they've actually done a retrospective evaluation of glaucoma patients who were on Riposudil and underwent cataract surgery. So the glaucoma patients underwent cataract surgery, and post-cataract surgery was started on BID dosage of Riposudil, which is not an off-label indication. And then what they noted was the rate of increase in the thinnest cornea thickness 1 week after the surgery in the Riposudil group was much lesser as compared to the control group, which did not receive any Riposudil. Now, also they showed that the mean endothelial cell density loss, both 90 and 120 days after surgery, was 4.5%, and in the Riposudil group, and much more in the control group, which is sort of going with what the general trend of our thought process, that it's going to work. And another review article by Dr. Mosherfa shows that there is also, he reviewed almost 50 articles and publishing the effect of ROCK inhibitors, and concluded that there is a strong evidence of significant decrease in IOP, increased healing of corneal endothelium, and decreased progression of diabetic retinopathy. Now, another article that we came across was by Dr. Maxey. So Dr. Maxey actually did a comparative study between 10 patients who underwent DSO versus 8 patients who underwent DSO with Riposudil. And he showed that the group that had received the ROCK inhibitor recovered vision more quickly, had higher than average endothelial cell density at 3 months, 6 months, and 12 months, and no decrease in the peripheral endothelial cell density when comparing the counts. So now actually this can be put a little differently. What they actually did was, in the group which had undergone only Descemet stripping, they compared the peripheral endothelial cell density before the procedure and after procedure. Now, what is the logic of this? So the logic of this is that if you actually strip the central, say 5 millimeters, so this is just a rough estimation. If you strip the central 5 millimeters of Descemet from a 12 millimeter cornea, then you're actually removing 17% of the endothelial cells. And a 17% of endothelial cell loss would mean that if there is a migration of the cells, then the peripheral cornea would probably have a decrease of 10% after a stripping. However, this decrease was, although this decrease was noted in the DSO only group, it was not noted in the DSO plus ripasudil group, which means that actual proliferation is happening. So we're still debating whether is it proliferation or is it just sliding that's happening. Now, another randomized control trial, much awaited, was done by the Price group, and they had 29 subjects divided into the ripasudil versus the placebo group, and they showed again. And they did not measure the endothelial cell density in this group because they included quite a few cases wherein the cornea was having a significant amount of edema, but they used this thickness, central corneal thickness, at 1 month and at 3 months of the after starting the ripasudil, and significant improvement in the scotopic corrected visual acuity was seen at 3 months. However, they didn't find any difference in the disability scoring. Now, again, now with all that evidence in hand, it brings us to the question, when do we use it? So I would just putting together all this collective knowledge that we have seen from everybody else, it would be interesting to note that of all the cases that were presented, none of the honeycomb epitheliopathy was developed in cases of glaucoma, wherein the ripasudil was used for glaucoma, which means that having a significant endothelial cell reserve would probably mitigate this development of this side effect. But then we have also seen cases wherein the epitheliopathy has vanished and the cases have recovered on their own. So that said, also another guideline would be, probably it would be nice to exclude cases where post-cataract surgery, the DM is still detached, because we know that from the DSO publications that we need a clear margin for the cells to either migrate or also to repopulate themselves. Then pachymetric assessment may be probably a nice way to assess the cases on a serial basis, and specular microscopy probably not that great an option. So I would like to take any questions. Dr. Radhika can fire away, and she's been a great moderator. I must appreciate the way she's been conducting. Thanks a lot, Sharon, and thank you.
Sharon is the moderator. I'm just her follower. Okay, since you asked Charuta, that was a very, very nice compilation of what we know about selective endothelial removal and ripasudil as of now in literature. You put all of it together in one plate. So I also should confess that we've had limited experience, but it's been the same as what you projected. That basically you seem to need some amount of endothelial reserve for the Rho kinase inhibitor to work. So if you have a frank corneal decompensation or total Descemet's detachment and you're expecting it to work a miracle, I don't think it does at all.
Absolutely.
And in the brands available in India, still stinging and allergy seem to be much of an issue. The question I have for you is that I also understand that the honeycomb pattern of the corneal epithelium, the so-called anterior corneal mosaic, can be seen as a normal phenomenon sometimes. Like if you make the patient close the eyes and put some digital pressure on the eye and then apply fluorescein, quite often the anterior corneal mosaic throws up a honeycomb-like pattern. We do not put fluorescein in normal eyes and check most of the time for obvious reasons. I also understand that post discontinuation of ripasudil, the honeycomb pattern disappeared. So it's not normal. But do you think that the normal is somewhat exaggerated to produce the epitheliopathy that you saw? Do you even feel that the two are connected? the
Yeah,
anatomy
absolutely,
and
ma'am.
this
Like if
variation.
we compare the pattern of bulle that we see in a pseudophakic bullous keratopathy, that's one which does not maintain the normal architecture of, cell to cell. So there's something happening wherein the gap junctions are not damaged, but yet there's edema developing, something of that. That's what we are probably, that's coming up as a very nice honeycomb reticular pattern. So obviously has nothing to do with our endothelial honeycomb, but it has something to do with the cell-to-cell junctions that are in the epithelium without being damaged. So we see in pseudophakic keratopathy, because of the long-standing edema in the stroma, that probably the epithelial gap junctions are damaged, whereas that has not yet happened, and we're sort of pushing it to happen.
So I think it may be very interesting to do a study whereby we have 2 or 3 sets of patients. One set in whom the cornea is normal, and we put fluorescein to elucidate the anterior corneal mosaic, the so-called normal epithelial pattern. The mosaic does not outline hexagons as individual cells, but clumps of cells together form a kind of, if not hexagonal, a polygonal pattern. One, arm. The second arm being people with bullous keratopathy or any form of corneal decompensation who are not on ripacidil to analyze their fluorescein pattern of the anterior cornea. And lastly, the fluorescein pattern of the anterior cornea of people who have used rho-kinase inhibitor. So if we have a multimodal imaging of all the 3 types of people or patients, then probably we'll get a better picture as to, now we know this is happening. We'll probably get a better idea as to why it is happening, and more importantly, what makes it go away. Sharon, Aditya, anybody else wants to comment?
I just have one very quick comment. So I have used the Indian version, which is no financial interest, but the Ripatech, which is there. And I had one patient who got the Glanatech from abroad. I don't know whether he was very happy with it and he felt a great improvement. But as you showed in your studies, and even we have found that when we try to measure it, there's not that much of significant change. And we even did a confocal microscopy, because very often, the specular doesn't show any cell morphology in many of these cases. But the confocal did pick up cells, but we couldn't, even on confocal, didn't see any morphological change visible on follow-up. So do you think the actual molecule, even though they're all rho-kinase inhibitors, that version of the molecule, would you think that would matter between all of them?
Yeah, I mean, I can't, like, again, in NFI, but I did try the Glanatech for one of my patients as well, and he also developed a little bit of epithelopathy, so which was much lesser than what we saw with the others. But then again, see, I'm not defending anybody here. Now, the number of side effects or the stinging is definitely more with the Indian formulations. But at the same time, the development of epithelopathy, we can't really comment, because it depends on the underlying result.
Also, yeah, the tissue itself,
So,
the corneal tissue.
we can't really blame development of epithelopathy on the formulation. But then again, they're not using it regularly either. So because of all the stinging and the burning, there's a lot of patients who are discontinuing the treatment or not using 4K Jaga 2. Those things are happening. So it's going to be really difficult to understand. If they can come up with a formulation equivalent, or if we can just, the company can enter India, that would help us.
Also, just for everyone, what is the dosage everyone is using with these drops? 2, 3, 4 times per day? Anything recommended?
The studies have shown, the one study has shown 6 times a day, the one which was used for cataract surgery.
Okay.
But
Because
6
it's a lot,
is too much. Yeah. 6 is impossible with our formulations.
And because it stings too much, I use it 4 times a day. And I think we can say it out loud. It's not for or against anybody, that the molecule definitely matters, as it does with many other formulations.
Absolutely,
also.
yes, I agree.
Sometimes ours work better, but this seems to be one case where I have not used Glanatech, but this is definitely got a lot more left to be desired in the molecule that we have at hand right now. And also, I found one very simple test to be a good indicator. Totally agree that specular microscopy will not lead us anywhere very much beyond knowing whether this cornea is normal or abnormal. What I found more useful in my hand is to do a differential pachymetry. An absolute pachymetry is not very indicative, but a differential pachymetry, one which shows thinning out of the central cornea as in comparison to the peripheral cornea, would in my mind seem to be a patient who is improving. Rather,
Very nice.
a patient who has equal central and peripheral corneal thickness or unchanged central to peripheral corneal thickness ratio is one who is not improving or actually worsening, is how I would use that test.
Very nice point. Excellent point. We'll move on to our next talk. Thank you, Charuta. Our next speaker is Dr. Anita Venugopal from Arvind Eye Hospital, and she'll be speaking to us on non-resolving keratitis and what are our options for management. Over to you, Dr. Anita.
Afternoon to one and all. Am I audible? My screen is visible?
Yes.
I take
You're a
this
little soft,
opportunity-
but I think that's because you're just soft-spoken.
Thank you. I thank SAO Organizing Committee and Dr. Sharon for this great moment. And my talk is on non-resolving keratitis. What next? Corneal ulcer, which does not show any indication of healing within 2 weeks of proper medical therapy, is termed as non-resolving keratitis. It may lead to corneal melt and perforation if left unattended. An approach to a patient with a non-healing ulcer. First, rule out all adnexal issues like lid and duct pathologies, diabetic status of the patient to be assessed, and ensure proper drug compliance. Rule out viral etiologies through PCRs. If already patient is culture positive, think of some polymicrobial infections along with the existing organism, or if the culture was negative already, think of some atypical microorganisms. For both situations, we have to go for re-scraping after cessation of therapy for 24 hours, and then confocal microscopy and molecular genetics have to be made use of to identify an unknown organism causing non-healing ulcers to start the appropriate therapy. Every time in literature, newer and rarer emerging pathogens have been published every time, and I've mentioned some of these newer emerging bacteria in my presentation. Atypical mycobacterium, previously considered to be very rare, nowadays it has become a little common because of increased incidence of refractive surgeries and also immunosuppression in patients with cancers, etc. So they present as with an epithelialized surface and deep infiltrate satellite lesions, mostly in immunocompromised cornea or in immunosuppressed individuals. Early recognition with a clinical suspicion of this organism and initiation of combination of clarithromycin and amikacin would definitely give you a favorable response in these patients, but there is higher incidence of recurrence. Pythium keratitis, it is more frequently being noted in meetings and literatures nowadays. They have a very varied clinical presentations, and they are clinically indistinguishable from the fungal keratitis, both clinically and microscopically at an early stage. So management of these patients is also very difficult, and the prognosis is very poor. Another set of rare and emerging pathogens are from pigmented group of fungus, Xerohilum bipolaris species, and Scedosporidium keratitis. The latest the report on Scedosporidium species was in contact lens related keratitis, which was reported by Casano et al. The author has identified this organism only after explanted in the explanted cornea after TPK. Cholicotrichium species is another newly emerging pathogen. Recently, we also had experience of this organism in two of our patients, but this causes very superficial ulcer in our patients involving the visual axis, and they responded very well to natamycin. These are rapidly growing fungus which was grown in culture within 48 hours. Recently, fungal keratitis caused by Pseudo-Listeria boydii has been reported by Isadi et al. Very interesting point to note that because it is a newer emerging pathogen, it was sensitive to a newer group of antifungal agents like itraconazole, posaconazole, capsaicin, etc. And it was resistant to amphotericin B, 5-fluocytosine, fluconazole, and natamycin. Hence, identification of these organisms with a clinical suspicion and antimicrobial sensitivity or antifungal sensitivity is needed to achieve a favorable response in patients with non-resolving keratitis. Microsporidial keratitis is another entity in which the stromal keratitis has a very poor prognosis with a high rate of failure of medical therapy, requiring TPK as high as 73.5% in most of the reported cases in literature. Clinically, they resemble HSV keratitis and fungal keratitis. Next in the list would be the polymicrobial infections as a cause for a non-healing keratitis. Recently, higher incidence has been noted in the literature by Gonzalez in his series of patients of 656. He has reported as high as 46.5% of his patients had polymicrobial infections. And acanthaviva was also found to be associated with other organisms like fungus and bacteria. And so hence anticipating all these co-infections is also necessary for early diagnosis and timely management of these patients. So another very important problem associated with the challenges for treating bacterial keratitis would be the drug resistance. In patients with methicillin resistance and moxifloxacin resistance, and even now we have vancomycin resistance species, and linezolid is being effective in these kind of keratitis. Colistin is effective for multi-drug resistant Pseudomonas aeruginosa, imipenem for multi-drug resistant gram-negative bacteria, nocardia, and non-tuberculous mycobacteria. So as ophthalmologists, it is important for us, and we have to take the responsibility to prevent the spread of this resistance by choosing an appropriate dose of antibiotic therapy, using the right antibiotic, and avoiding misuse of the antibiotics in simple allergic conjunctivitis and viral conjunctivitis. Next would be of course, the adnexal issues. Is very frequently missed by our clinic fellows and PG students in patients with corneal ulcers. This has to be very much taken care of because in many of the reports on studies, they have reported that 47.3% of the Nottingham infectious keratitis study, they have reported ocular surface diseases of very common risk factors. Other risk factors such as mentioned earlier, diabetes mellitus and other debilitating illnesses, immunocompromised state also has to be looked at, and contact lens usages, topical steroids, topical antibiotics, glaucoma medications also taken care of. This is an interesting case of a child who presented to us at 6 months of age with a corneal ulcer in the left eye. Scraping was done in GA and it revealed no organism, so we started with an empirical therapy. She was responding well, and so we discharged her. And again, during her first visit, she presented with a corneal ulcer at the right eye. So this time we were surprised to have the bilateral keratitis, and on close observation, we could find out that the child was pleasantly looking at the slit lamp light without any photophobia and signs of inflammation like watering, tears, etc. So we thought we would have missed the congenital corneal anesthesia in this patient. So this is another case of lattice dystrophy in a 40-year-old. She had underwent PPK in the right eye, and she was awaiting for the same procedure in the left eye, during which she presented with this ring infiltrates with the central ulcer. This ulcer or the infiltrates did not resolve with multiple drugs and amniotic membrane grafting, and there was a recurrence also. So then in literature, we later found out that the amyloid in the stroma itself is an inciting agent for inflammation. So this was a sterile infiltrate, which has to be differentiated from the infective keratitis, and starting a topical steroid definitely improved the prognosis in this patient. Poor compliance is a major thing which everyone has to ensure, because we are seeing a lot of patients, and this the poor compliance to the drug therapy has to be taken care of in each and every visit. It is very much important to check the drops, the amount of drops the patient has used, everything, and also the eye drops, how it is being used, whether it is hygienic or not. And the follow-up is also very important to avoid the devastating complications. Drug toxicity, identifying this, it's a very simple thing which if identified early, it definitely will help in promoting epithelialization, because whenever the peripheral ulcer is showing healing response, better to taper the antimicrobial or antifungal therapy and do a gentle therapeutic scraping and to promote re-epithelialization. So if repeated cultures are being consistently negative, corneal biopsy, AC tap, and molecular diagnostic methods can aid in diagnosis if the infrastructures are available. And this pulsed field gel electrophoresis and immunofluorescent assays for diagnosis of HSV keratitis, they are more sensitive, they are more specific than PCR and GIMSA stain. Another very important equipment, like all of us would be using, is confocal microscopy. Journey et al. Has compared the specificity and sensitivity of diagnosing acanthamoeba keratitis in the corneal scraping with the confocal microscopy, PCR, and culture. And he found that the specificity in all three methods were 100%, and sensitivity of confocal was more than that of PCR and other corneal scraping. Fresna et al., they have done a study on and observed that there were specific cellular features of the host, the organism in the bacterial, fungal, and acanthamoeba keratitis. And finding out all these cellular features, identifying this would definitely help in identifying the organism at an early stage for all this non-resolving keratitis. So how to manage this non-healing ulcers? Despite of this topical therapy, if the patient is not responding, there are other factors like the surrounding the dry eye or the ocular surface disorders, everything is ruled out. But in spite of this, we have found out the organism also, and then proper drug therapy is also going on. But there is a non-healing ulcer. Then directly delivering the antibiotic or the antifungal directly to the site of keratitis has now become a novel method. And we are all been definitely using intrastomal oriconazole, and a few authors have tried intrastomal antibiotics also. Kahn et al. Has used cefuroxime, and tobramycin was used by Steve et al. For recalcitrant bacterial keratitis in a 70-year-old patient with phacotunnel infection.
Dr. Anika, I'm so sorry to interrupt. We're just short of time. So can you sum up?
Yeah, definitely. Surgical debridement, definitely it is a very valuable method to remove the load of the fungus or the antibiotics. This allows a smooth stroma, which is necessary for reepithelialization. Amniotic membrane transplants and conjunctival flaps, torsographies, and PAC-CXL, which is a photo-activated chromophore for keratitis with CXL. This method has been termed as PAC-CXL in 9th CXL Congress in Dublin because to differentiate it from its usage from keratoconus. So since after its proposal, many studies have been in literature, which with the promising results have come up for both bacterial and fungal keratitis. And for perforating ulcers, tissue adhesives, bovine pericardial membrane patches are being tried by a few authors, and anterior lens capsule transplantation. These are novel methods, and Tenon's patch grafts are serve purpose. They were serving a lot during COVID times. So whatever the gold standard treatment, I would say, would be early therapeutic keratoplasty, which directly eliminates the bulk of the infected tissues and the load of microbes. So these are patients with non-healing ulcer treated surgically. This I would end up my talk with this last case of a very interesting case of a non-healing epidefect in a post-cataract surgery patient. She presented to us 1 month later after the surgery, and she had a non-healing epidefect which was not responding to any treatment. So we scraped the edges of the epithelium and examined in the smears, and we could identify fungal filaments, and culture later revealed unidentified hyaline fungus. The patient responded very well to oriconazole. Thank you for the patient listening.
That was a wonderful talk, Dr. Radhika, Dr. Anita, and unfortunately, due to the time constraint, we won't be taking any questions for you, but very, very well covered, and I'm sure the audience really benefited. Our next speaker is Dr. Suchasmita from Pune. She is a consultant at Dinanath Mangeshkar Hospital, and she'll be speaking to us on a very interesting technique called PKMO, which is penetrating keratoplasty with minimal endothelial replacement. Over to you, Suchasmita.
Good afternoon, everyone. I would like to really thank the esteemed panel members, dear Dr. Sharon, for involving me in this session, and also the organizing committee for this wonderful meeting. So I will be speaking regarding the penetrating keratoplasty with minimum endothelial replacement. Now, this is a surgery when we would want to do a penetrating keratoplasty because there is no other go. The central cornea is having a significant problem, which is preventing the patient from seeing clearly. But at the same time, the endothelium is healthy in the periphery. So we do not want to sacrifice the endothelium of the recipient. A typical example being an advanced keratoconus with a significant post-hydrop scar. As Dr. Sharon rightly mentioned in her wonderful talk that for small amount of haze or opacities, we should still do a DAL because that offers much more advantage compared to a PK in a youngster. There are some cases, however, where there is a large and dense scar where if we do a DAL, the patient will not get enough clear vision, or the patient may be contact lens intolerant. So we are forced to do a PK. So here we often have to do a large diameter PK involving the entire cone, and we do not want to sacrifice the endothelium. The concept of minimum endothelial transplantation was rightly popularized by Busen et al. Their group studied vast number of pediatric keratoplasties, post-herpetic and high-risk keratoplasties, and they found out that if we replace only the central 6 or 5 mm of the endothelium, we are keeping behind 75% of the recipient endothelium. And if at all the central endothelium undergoes some reduction over a period of time or rejection, the peripheral endothelium can take over at least theoretically and protect the graft. So these are all the studies proving this concept. In their technique, they use a microkeratome and they make an anterior 200-250 micron lamella and a posterior 5 mm stem. In effect, it's a full thickness keratoplasty in the center, but it's a large diameter graft taking care of the astigmatism, and we are leaving behind the peripheral endothelium of the recipient. Now, in this surgery, which I am describing here, is a little bit different, done differently, possibly an easier method, and we don't need a microkeratome. So here we are making a kind of a somewhat like a DALK-like bed, like an anterior lamellar keratoplasty, and we are cutting out the posterior lamella and placing the donor with the central endothelium. So in effect, we are achieving three things. We are making a large diameter graft taking care of the astigmatism. We are replacing the center entirely, thus visually rehabilitating the patient. At the same time, we are keeping the periphery intact in the recipient endothelium. This also to some extent prevents the glaucoma because of the large diameter grafts. Now we have two cases presenting over here. One is a large diameter graft done in an advanced keratoconus with a significant scar in the center. This is a second case which had undergone, similarly, a keratoconus patient around 65 years old had undergone a PK many years back. And this was a small 7 mm graft, which was edematous. There was no scar, but there was like a 700 micron pachymetry suggesting that there was some endothelial dysfunction. And we can't retain that or do a DALK in him. This is an ectatic, again, a graft. The periphery is only 200 micron. So this patient could not tolerate contact lenses, and he had almost like 50 plus diopters of astigmatism. So here also we need to replace the central 7 mm, but we need to keep the peripheral endothelium, which is healthy. So these are the steps followed. In the donor, which was 9.5 to 10 mm based on the case, we peeled off the peripheral donut of DM by marking it using a 6 mm trephine by partially punching it like this, and the central area was retained. In the recipient, we cut out a DALK in an anterolamellar fashion. We cut out the anterior stromal layers by dissection, and the central 6 mm or 5.5 mm was cut out in the full thickness like this. And this donor was placed on the recipient. Before that, an inferior PI was done, and suturing was similar to PK. And in the end, we placed a air bubble to oppose the layers. In the first case, I did not use any full thickness sutures. I had put air, and for 3 days, all the interface, the peripheral interface was nicely fused. But on the 4th day onwards, I noticed some kind of a gap in the periphery, which I was worried about in the peripheral skirt. So I took him up and to put a full thickness suture inferiorly, only in one area. After this, over the month, there were multiple pockets of separation, but at the end of 1 month, it was interesting to note that the entire periphery fused. In the second case, I took a full thickness suture right at the beginning, anticipating this. But all the other areas also, the graft host interface fused over a period of 1 month. This needs to be observed in more number of cases. How this happens in spite of these layers being not opposed in the initial period. This is how the graft host junction looks after 1 month. And the astigmatism also was another concern. But what was good to see was there was around 1.5 astigmatism in the what patient accepted in the spectacle correction in one case. In the second patient, it was 2 diopters. However, the topography did show more than that, like 8 diopters of astigmatism and 10, but the acceptance was like this, and patients improved to 612, both the patients are from hand movements. And the periphery showed some interface haze, as you can see, which cleared over a period of time. One patient has completed 4 years and the other more than 1 year. Both patients underwent phaco for pre-existing NS3, which we anyway had planned to do a second procedure, and we did this at 6 months post cataract surgery. Visualization was not an issue because the central area was, we were able to do a phaco smoothly. So what are the other cases which may, suppose we are doing a DALC and there is a central perforation. Maybe we can, instead of converting it, if it's a large perforation, can we do a similar procedure by keeping behind the patient's endothelium itself? It's just a thought process. And even in a HSV keratitis where there is vascularization. And another situation would be post-trauma when there is a central corneal thick scar like in a child. Peripheral endothelium is still healthy. So if the patient cannot tolerate RGPs and all, can we still do some procedure like this? But we must choose a patient with a sufficient anterior chamber, because here there is a small problem that what if the inner edge does not fuse? See, if you can see these gaps, they fuse over a period of time, and they fuse like this. And yeah, the endothelium was also quite okay, more than 2000 and around 1800 like that at the end of the follow-up period, even in spite of the cataract surgeries. And one of the patients was amblyopic from childhood. I chose these cases because they were poor prognosis case and did not want to do it in proper, healthy eyes. And yes, so these were the concerns. And inferior PI, and possibly we can take a full thickness bite if we feel that the lamellae are not fusing. So in the traditional Debusson's keratoplasty, they did notice that in some cases in the central interface, there can be a gap and we need to rebubble. In this situation, we are not having this problem because it is a full tissue. We are not disturbing the central cornea, but the periphery can be an issue. How more number of cases need to be studied to see that if it really works. I'll just leave you with a short video. So this is the donor around 9.5 mm and 10 mm. Just taking a partial punch there with the marked trifine, and just like in DMEC, how we score the this thing, we are peeling out the periphery instead of the center and leaving behind the center. Now you may say why we are peeling it off. We can even put it like in a non-peeling Desmet, like how in DSEC we don't peel the endothelium sometimes, DM. But probably the additions will be better. That was my thought process. The second case, the periphery doesn't look very elegant in this procedure, but it seems to be working, and possibly we need to do it in a better technique in the future cases. So this is a central 7 mm graft, which is already was there, and it's edematous, though there is no scar. So I'll just speed on this up, do an inferior PI, and then put the thing and air bubble. So this is a central edema. This was pre-op, and this is the post-op in the same case. The PACI was 478 in one of the cases at the end of follow-up, and the other one was 535 at the end of follow-up. Suggested that the endothelial health is good. Doesn't look cosmetically so good on the slit lamp, but when we see them just like that, it's not visible, the scar. I also would like to acknowledge that this got published this year in September in Cornea as a techniques paper. Thank you very much.
Great presentation, Dr. Suchasmita. Very, very interesting technique. And yes, congratulations on the publication. In the interest of time, we won't be taking questions just now. We'll move on to our next speaker, Dr. Nandini, who will be speaking to us about something which is quite valid, graft rejection, possibly secondary to COVID vaccination. So, Dr. Nandini, are you here?
Yes, ma'am. Am I audible?
Yes.
Yes.
Please
Good
go
afternoon, everyone. At the outset, I would like to thank Dr. Sharon and Dr. Radhika for choosing me for this talk. So without wasting much time, I'll start my talk. All of us have witnessed that COVID is responsible for...
Nandini, you just share your slides. We are not seeing them.
It's not visible, huh? 1 minute. I'll close and I'll share it.
Play it as a PowerPoint first and then share the played screen.
Oh, I have to play it as a PowerPoint. Huh? Okay. Okay. 1 minute.
While she's setting up, I would like to congratulate Dr. Suchasmita on both the technique as well as her paper. And also, I'm awe of the fact that she's the only person in whose hands the line drawings can actually look better than the computer graphics drawings.
So true.
Can I start now?
Yes, now.
It's visible?
Yes.
So all of us have witnessed that COVID has caused millions of deaths across the world. In order to reduce the morbidity and mortality and to limit the rapid spread of the disease, there was invention of immunization against this COVID. The advantage of immunization is it protects an individual against the disease and it reduces the severity of the disease. However, we do see hypersensitive reaction to vaccination, which is very low. At the same time, those who have received the transplant, there is always risk of rejection. So coming to my talk proper, so cornea transplantation has huge rate of success because of the ocular immune privilege what it has. So Almighty is kind enough to us that he has protected the ocular environment from the immune response to have a clear vision. And that is where we have this immune privilege. So immune privilege consists of, there is absence of lymphatics and blood vessels in the cornea, and there is lack of MHC type 2 antigen presenting cells, which makes the donor invisible for our own immune system. There is an intraocular immune dampening microenvironment, which usually keeps the functional T cells in silent along with the T regulatory cells. So how does this COVID breach this immune privilege and cause graft rejection is what I'm going to explain. So what happens when a person gets a COVID-19 disease? So the virus would enter and it starts replicating inside the cells and causes a increased immune dysregulation, which increases the cytokine levels and the antibody mediated response. So all this will create a pro-inflammatory kind of microenvironment, which makes the person more susceptible for developing graft rejection. And also when the person develops a severe disease of COVID, he also has the lymphopenia. So whenever a person has a severe disease, we should question ourselves that whether he develops graft rejection or not because of the lymphopenia. So what happens when a person receives a vaccine? So whenever a person receives a vaccine, he develops both the antibodies as well as the immune response, and the antibody levels peaks by around 3 to 4 weeks, at least for a month it peaks, and then after that it starts deteriorating by around 3 to 6 months. The cellular response, we start seeing the helper cells and the cytotoxic cells. Along with that, the interferon and the interleukins also circulates. So thus the vaccine mediated mechanism would be the direct pathway using the T cells and the indirect pathway using the memory T cells along with the antibodies. So coming to this slide, I want to show this slide because we also should know when would the antibody appear and when it starts reducing. So as I mentioned earlier, the antibody against the COVID usually reaches peak by around 3 to 4 weeks, that is by around month, and it stays, it maintains a plateau for around one more couple of months. After that, it starts deteriorating, and by the end of 6 months, the antibody levels will become will reaches below the threshold level that it would require a booster dose. So what happens when somebody needs a booster dose at 6 months? So if somebody is not opting for a booster dose, then after 6 months would be an ideal time when you want to plan a regraft or a fresh keratoplasty for a awaiting patient. But when person receives a booster dose, the antibodies would be reaching the levels which is more than a threshold, so that the immune response would be severe. So when you do a keratoplasty at that time, we should think that because of the higher antibody levels, would we have a severe graft rejection and it would lead to any irreversible resolution. That is what we should keep in mind. So to summarize the thing, whenever we have the COVID-19 disease or vaccine, it is going to potentiate the active T cells, and it is going to alter your immune dampening microenvironment along with the regulatory T cells. And our scientists in the lab at Narayan Nethralaya, they have also seen that whenever a person wear a mask, there will be hypercapnic effect, which would increase an inflammatory response on the ocular surface, which makes the person more susceptible to develop graft rejection. Thus, it leads to graft rejection. So coming to the literature review, so I have divided based on the vaccine causing graft rejection and the disease causing graft rejection. I will be explaining why. So after vaccine, there was around total cases which was reported in literature were 70, and the days of presentation ranged from 3 to 21 days, and most of the papers have used the topical treatment, and most of the cases recovered with the treatment by around 1 to 6 weeks, except for one case where they had a failure. Coming to the graft rejection which happened during the COVID disease were around only 3 cases, and it was noted only into mild to moderate cases who had a mild to moderate disease of COVID, but not a severe disease. As I mentioned earlier, severe disease patient would have a lymphopenia, whether he manifests or not, that is what we should keep it. And the day of presentation was immediate, and all the 3 cases underwent a repeat graft. That is what I noticed. This is a slide which shows a comparison. So when a COVID graft rejection happens after a vaccine-induced graft rejection, that is actually reversible with the treatment, but with the disease, the chance of recovery was which was not seen. One thing what I would like to tell is, during the disease, is it because of the severe immune response we are seeing this, and the authors had planned a repeat graft within time frame of 1 to 3 months. That is what I was thinking. The authors would have waited for some more time, and they could have seen for the resolution, because I had experience in one case which I will be showing in my subsequent slide. So when we sum up all the cases, the chance of recovery of corneal graft rejection was around 80%. So when I was looking at the other non-ophthalmic organ transplant, the best scenario what I came across was the chance of recovery was only around 50%. In that, the kidney and the pancreas had a very bad outcome compared to the liver. Liver did not have much impact of COVID on the liver transplant or any failure. So coming to our experience, we had a young female. She was a student. She underwent PKP for contact lens induced scarring. Immediately after PKP, within almost 1.5 months, she developed a acute graft rejection. So 3 days later, she turned out to be RT-PCR positive along with her family members. So the standard treatment protocol for the graft rejection was started. So even after 4 months, her graft did not recover. So even we were thinking to do re-PKP. So we advised her to finish off her vaccination regime. And she came to us in the first week of December, and we were surprised to see her graft, that her graft had recovered, and except for the paracentral haze, you can see there is mild posterior stromal edema, and her vision was significantly improved. This is what I want to tell you, like if at all the graft rejection happens after a disease, it's because of the immune response, severe immune response, the graft rejection would have happened. And so we need to wait and watch for a long time rather than jumping to do a re-PKP. So other 3 cases.
So sorry to just interrupt in between, but we just up with the time. So can I ask you to conclude the session, please?
So all the other 3 cases happened following the vaccine, but the 3 cases recovered beautifully after topical treatment. So to complete my talk, to establish the cause and effect, we need to do animal model studies and to also check the blood, the T cell proportion in the blood, and we should also take the donor details to know whether the donor graft is sensitized to COVID. So with this, I would like to conclude that COVID-19 graft rejection is a vision-threatening complication. So the cause and effect relationship remains to be established. All patients who are having graft, we should educate them regarding this complication, and we should advise them to increase the dose of topical steroid when they are taking before the vaccine and after the vaccine. And early recognition and prompt initiation of the graft rejection treatment usually causes resolution in most of the cases, and keratoplasty can be planned 3 to 6 months after the last dose of the COVID-19 vaccine. Thank you.
Thank you,
Thank you
Nandini.
so much.
That was an amazing presentation, and you sensitized the audience very nicely about sensitization, which happens to the corneal graft after rejection. So I think we've already overshot our time. So I thank everybody for being over here and contributing, Sharon in particular, and thanks to the organizers. I hope all of you enjoyed the session as we enjoyed being inside of it. And my heartfelt apologies to the panelists of the next session. But I'm sure you hoped, I'm sure you enjoyed being a little bit of the cornea potpourri session yourself as well. So thank you so much.
Thank you. Thank you, ma'am. And
Thank
thank you
you.
to
Thank you
all
very
our
much.
speakers. Really wonderful talks.
Thank you so much, Dr. Radhika and Dr. Sharon, for being such a great moderator and the chairman for the session. Moving further, we have the next session on choroidal vascular diseases, where we are now and what has changed. And our chairman and the moderator for this session would be Dr. Prashant. Over to you, sir.
Thank you. Thank you so much. So, dear friends, here we are with the choroidal vascular disease session. Where are we now and what has changed? We are already late by 15 minutes. We will not be wasting much time on the formalities. Let me invite the panelists who are going to be with me, Dr. Somnath Chakrabarti, Dr. Shobit Chawla, Dr. Vasumati, Dr. R.P. Singh, Dr. Darais, Dr. Deepa Sharma, Colonel Sanjay Mishra, and Dr. Apurva Grover to be with me during the discussion part. So we have an elite list of panelists who are going to discuss this particular molecule. Yes, what has changed is basically we are all aware choroidal neovascular membrane was a sight-threatening problem which happens at a later age. The evolution of the treatment began with no treatment. 2 came the focal lasers for extrafoveal CNVMs, then came PDT, TTT, and now we have a pharmacotherapy with wide-ranging available molecules. But the challenge with all molecules was the number of molecules which had to be injected at a monthly interval. And here came the problem of compliance and affordability. Now on that, and we have a new kid on the block, that is rolosozumab, which promises the need of this treatment to be almost 2 or 3 monthly. Let us see through this presentation, can this particular new molecule stand up to the expectations which we have from this particular molecule. With this short introduction, let us directly move on to the first talk, and that is unmet need in the management of neovascular AMD. And we have Dr. Kairobi with us. Let me introduce Dr. Kairobi over here. Yes, she has been a president of Bombay Ophthalmic Association, a very charming lady who is also who has done vitreoretinal fellowship from Shankar Nethralaya. I think with this short introduction, we will directly move ahead with the presentation.
Thank you, Prashant.
And she's going to be my joint treasurer at Vitreoretina Society of India.
Yeah, I know. Thank you so much.
Most welcome, ma'am.
Okay, I'll just share my screen. Is my screen visible and am I audible?
Yes, ma'am.
Okay. Good evening, everybody, and thank you, Prashant, for the introduction. My talk today would be on the unmet medical need in the management of neovascular AMD. As we know that AMD is a burning issue in this world today, and we get more and more cases every day. Coming a long way from the beginning, where we've had patients where they were treated with laser, TTT, PDT, then came the anti-VEGFs, which caused a very paradigm shift in the treatment management of these conditions. And then as they evolved further to become more and more refined and more targeted, we are sort of now dealing with more unmet needs which we have to address, because earlier we were happy with even if they just maintained vision. Earlier we were happy with if they got one or two letters of improvement, but now we ask for much more things, and for that reason we need to address certain issues which accompany this. So this is my standard disclaimer slide. Okay. Now, AMD we know is a leading cause of irreversible loss of vision worldwide. Now, we have patients who are in the range of over 65 years, amounting to about 10 to 20% of the population, where neovascular AMD is 90% of the AMD associated visual loss, and it is a number one cause of blindness in the developing countries. What is estimated by the time it is 2040, about 288 million will be affected by this disease worldwide. In India, the prevalence is about 4 to 12% in a subgroup of greater than 50 years of age. And when we have to talk about the unmet needs, medical needs, we have to talk from three perspectives. That is the patient's perspective, the physician's perspective, and the healthcare perspectives, and then summarize it to find a solution. Now, when we talk about the patient's perspective, the frequent treatment monitoring and requirements place a heavy burden on the patients. The reasons why patients feel that frequent monitoring is unfeasible because, one, the high treatment burden. That is the burning issue in most of the patients, which is a monetary requirement for multiple injections that they have to take over a long period of time. The transportation issues, the time it is the time that is consumed in all this, and the reason then thereafter for patient discontinuation or follow-up is because of dissatisfaction with the benefits of treatment, the long distance travel to the clinic, and the burden of follow-up visits. Now patients would like to have lesser injections and lesser follow-ups. So the ARMD treatment and the reason for patients being lost to follow-up, this was seen in a multi-center trial which involved all the physicians, patients, caregivers, and they found that 72% of these patients were bought by a caregiver. So if the caregiver is not free, the patient cannot come. The time commitment, suppose somebody stays very far off, and right from the time that the patient gets prepared, he comes to the clinic, there's a travel time, there's a waiting time, there is a treatment time, there is an investigation time, and the post appointment recovery right up to going home sometimes measures up to 5 to 6 hours or even 9 to 10 hours, which is occupying the most part of the day, both for the patient and for the caregiver. And also the frequent visits that the patient has to come for post-injection visits, they have to be monitored. That also 67% of the physicians indicated that it would be desirable to reduce the number of office visits for monitoring. So we found that over a period of time, this is a study by the ASRS, we found that, because of all these reasons, that is the long distance, the burden of periodic visits, and also the burden of the treatment itself, the financial burden, social isolation, the probability of the dropouts in over the this occurred in the third to fourth year, where they found a considerable number of people just dropping out of this. So there was no adherence to the therapy, and the persistence of problems that they had continued. So from the patient's perspective, lesser injections and lesser burden of treatment with better injections which gave more gratifying results, fewer visits, and the ease of travel would be considered or would be factors which would aid this persistence of the patients for adherence to treatment. Now, from the physician's perspective, this was a study by ASRS where they said that the reduced treatment burden and improved uh, safety and the travel time, etc., would definitely benefit patients who are being treated for this condition. So there is a need for a very long acting sustained delivery where new treatment mechanisms of action, which are molecules which target very pointedly and which cause a dry effect effectively very soon, is what is desirable. The retinal fluid is a matter of discussion, where earlier in the fluid study they had mentioned that about 200 microns of fluid is okay, but now the current concepts are that we would like to have a really fluid free status, because any kind of fluid is indicative of disease activity. Now, physicians identify insufficient fluid resolution as the most clinical reason for switching to anti-VEGF therapies. Now, we have found that the patients have been treated by multiple injections, and then, the thing is that you don't get a desirable response, or you get a yo-yo response, so you tend to switch anti-VEGF therapies. So this is the real reason for switching anti-VEGF therapies, because you're not satisfied with the molecule that you're giving the patient for that particular condition. So from the physician's perspective, of fewer injections and better fluid resolution would make him happy. So what happens is that we need a compound which adheres to the treatment interval shortens, the visual outcomes are better, the disease activity gets allayed, the diagnosis should be done, and the time to allay this kind of this, or to make it shorter, is definitely, these are prognosticators which will lead to adherence of the patient to the treatment protocol that is given. So declining vision, drug cost, treatment choices are many, increased prevalence of the disease, monitoring needs, longer patient lifespan, and treatment regimens which are effective are the things which are desirable for getting an adherence of the patient and making a patient happy, and also the physician happy with whatever treatment he is undergoing. So a large unmet need still exists for patients, leading to avoidable vision loss, because treatment monitoring and burden causes non-compliance and under-treatment, that is, if you don't give the requisite amount of injections in a particular time, leads to suboptimal visual gains. So now we find that about 1/3 of the patients at 1 year follow-up had dosing more frequently than every 8 weeks. Now, treatment burden thus became a significant challenge in AMD patients. Now, considering what the studies say and what is the real world experience, we found that the number of injections which were suggested in the studies is not what happened in the real world data, because there you get less than 600 injections in the real world worldwide, whereas here they say that more than 8 injections or 9 injections would be required for a steady maintenance or improvement in the visual benefit. So under treatment played a massive role in the suboptimal gains in vision compared to controlled clinical trials. And these are, you see the randomized clinical trials and you see the real world experience, and you see the difference which really happens in real life, which makes the treatment not so amenable or pleasurable for any patient or physician. So we find that in all countries, the visual acuity maintenance in a long term requires intensive anti-VEGF treatment, and in all the countries you feel a steady decline over a period of time. So the treatment burden and the unresolved fluid gives rise to optimal gains, and because of this, this is a key obstacle in the management of AMD and maintaining a sustained visual function in these patients. Now, since this talk is basically on PCV, you know that there are certain diagnostic tools which also helps us identify one condition from the other, whether it is an age-related macular degeneration or it is a PCV. The ICGA is a gold standard, but the OCT, it gives us a lot of features which helps us identify. So important thing is that the caregivers, patients, caregivers consider treatment burden, and they highlight that the regular visits cannot be done because of multiple causes. And then we find that there is a critical unmet medical need to identify, characterize, and validate biomarkers which would provide solid guidance for any efficient individualized treatment. And that is the reason why the new molecules which are there now are helpful, because they help achieve those targets. So the need of the hour is an anti-VEGF which dries any fluid in any compartment, which has better penetrability, which has longevity, which has increased duration between injections, which is a blanket treatment for all ills, which is affordable, with lesser side effects, with better visual gains, and which is compensated by the insurance companies. And brolucizumab, we find, fits the bill. Faricimab is to follow because it will be, I think, one step, because it targets target stations, and this will reduce the treatment burden. It will reduce non-compliance, will resolve unresolved fluid issues with substantial visual gains, which we've already seen in the last year of treatment with this molecule. Just to present one case.
Ma'am, I'm so sorry to interrupt. The time's up. So can we conclude the session?
Give me half a second. I'll just
Yeah.
finish. This is a 69-year-old male who had multiple injections over 3 years, and this patient underwent finally 3 injections of brolucizumab with gratifying results and improved visual gains with no fluid status. Both patients and doctor is happy. So this was how the patient was after 3 years of treatment. This was after the first injection of brolucizumab, and this is on concluding the 3rd injection. So you find that the happiness quotient of any patient is definitely there when you are quick at your treatment and you have effective treatment and visual gains. Thank you so much.
Thank you, Dr. Karubi ma'am, for so elaborately eliciting the reasons why there is such a big gap and a void in the needs which the patient has as well as the doctors perceive. So without wasting time, let me welcome the chairman of this session, Dr. Lalit Verma, who was with the VRSI. Sir, welcome back. And so shall we proceed with the next talk?
Yeah, because number of talks are too many. I think we need to give adequate time to everybody.
Okay. So the next talk is going to be by Dr. George Maynath. He is a senior vitreoretinal consultant at Arvind Eye Hospital. Without much ado, everyone knows him. So I request him to share his presentation.
Hi, Kerobi, how are you?
Fine, Lalit, how are you?
Good. Nice talk. The word which caught my attention was happiness. Happiness for the patient and happiness for the doctor.
I know, that's all what
Very
we
important.
desire.
Yeah, carry on, George. Yeah, carry on, George. George, please carry on.
Yeah, sure. So, hello everyone. Let's look at the multimodal imaging in PCV diagnosis. I'll be talking about the ICG angiography because the next speaker is on non-invasive imaging in PCV. So, fortunately or unfortunately, PCV accounts for around 25 to 50% cases of neovascular AMD that presents to us in India and in Asian scenario, especially if properly imaged with SD-OCT and ICG angiography. So Everest study report 2 was the study which classified the diagnostic criteria for PCV basically on fundus imaging, orange subretinal nodules, serosanguinous PEDs, massive submacular hemorrhage, and then the ICG feature of hyperreflective nodule with or without a halo of hypofluorescence associated with branching vascular network. And these hyperreflective nodules could be pulsatile in the early phase of video ICG angiography, or best appreciated within the first 5 minutes of ICG dye injection. And now ICG angiography is the gold standard, either in single or bunch of great kind of polyps, which are best appreciated within the first 1 minute of dye-based ICG angiography. And these polyps may either leak in the late phase of ICG or it may wash out in the late phases. And another feature in the late phase of ICG is called late geographic hyperfluorescence or hypercyanosine, is also highly specific for the diagnosis of PCV. So these are the diagnostic ICG criteria for polypoidal lesions on ICG angio. However, we should also be aware of the mimickers of polypoidal lesion on ICG angiography. So let us look at one case example here. Here, left eye of this patient with a tall PED with sub-RP hyperreflectivity with type 1 neovascularization with or without polypoidal lesion with 6/9 vision on ICG angiography. Early to late phases, there is this upper part of the neovascularization hyper-reflective or hyperfluorescent nodule persisting till the late phase. So in this case, the earliest phase of the ICG, when tracked, this nodular hyperfluorescence is continuous with the vascular, choroidal vascularization, which bends acutely or changes the direction, and increase in the blood column at that location gives a hyper intensity to the ICG. So these round nodular lesions are called choroidal vascular knuckle on ICG angiography and could mimic a nodular hyperfluorescence of polypoidal lesion. Also, another mimicker could be early phase nodular discrete hypercyanosins seen on ICG. In this patient associated with an intraretinal hemorrhage at the macula. And in these cases, the clue is a right angle dipping of the vessel. And on fluorescent angiography, the leakage starts from the retinal circulation with intense leakage in the late phase, pooling of the dye within the intraretinal cystoid spaces. So we are looking at a RAP lesion or type 1 neovascularization. And now we have OCT angiography, which picks up the hyperreflective nodule intraretinally, which is the intraretinal neovascularization. And another mimicker for the polypoidal lesion, as we can see here in the mid phase of ICG angiography, there is a hot nodule, a hyperreflective nodule on ICG, and submacular hemorrhage and mimicking a PCV. Retinal macroaneurysms or RAM lesions can also produce hyperreflective nodule on ICG angiography. These small red lesions, well-defined lesions on the fundus, are seen as hyperfluorescent nodules on ICG angiography as well. So we look at this case example, left eye of this patient having an irregular PED with sub-RP hyperreflectivity, suggestive of a type 1 neovascularization with subretinal fluid. The ICG angiography shows a choroidal neovascular network. But what are these nodular hyperfluorescence or hypercyanosins in all phases of the ICG angiography? So it is very important to evaluate the side-by-side fluorescent angiography because this patient with choroidal neovascularization also seemed to have these nodular microaneurysms. The patient seems to have a mild NPDR with a choroidal neovascular membrane. These could also show as hyperreflective nodule, hyperfluorescent nodules on ICG angiography. So this, in the presence of a CNVM, can mimic a polypoidal lesion. These microaneurysms can light up as nodular hypercyanosins. So another situation is when you have only a blister of fluid at the macula without any other hemorrhage or exudation, and these kind of notched PEDs and subretinal hyperreflectivity is suspicious, and fluorescent doesn't show the CSC leak, but you have a stippled hyperfluorescent, again ICG, picks up the diagnosis of nodular hyperfluorescence of a polypoidal lesion. Again, cases initially diagnosed as chronic CSR with subretinal precipitates, and these PEDs are suspicious, sub-RP hyperreflectivity and stippled hyperfluorescence, as you can see on fluorescein angiography. And ICG is very useful in differentiating the mimickers of chronic CSC, which the leakage can be confusing on fluorescein for chronic CSC as well as type 1 neovascularization. ICG can establish the diagnosis of PCV. OCT angiography, as you can see here, picks up the high flow lesions of branching vascular network, but there is a low flow polypoidal lesion here, which is not usually picked up on OCT angiography. Here, there is a side-by-side comparison of ICG and OCTA of the same patient. The branching vascular network is comparably picked up in OCTA, but you can see the bright lighting up of ICG angio polyp, whereas there is a low flow lesion of OCTA polypoidal lesion that is not well picked up on OCT angiography. So I would like to show two more cases. One is in this situation, ICG angio is not useful in treating this patient. And next case is invaluable in treating that patient. So here, this 50-year-old female presented with a massive submacular hemorrhage, sub-RP hemorrhage, which we call as hemorrhagic PEDs, with backscattering of by the sub-RP blood here. And the initial fluorescein did not show any useful information. So the patient underwent intravitreal pharmacotherapy with aflibercept, and after 3 injections, and this is pre-corona patient. So now we have Paginax or brolucizumab is equally effective, or maybe efficacy-wise, it may be even more better. But this patient, the submacular hemorrhage is gone down considerably. The OCT shows almost normal foveal contour, and the inferior resolving hemorrhagic PEDs also can be seen. So here, at that moment, after 3 injections, when we do the ICG angiography, there are no polypoidal lesions seen. Already the polyp inactivation has happened, as we have seen in PLANET study, and even with the aflibercept or brolucizumab, the polyp inactivation happens here. You can see there are no polyps on the right-hand side on the ICG angiography. Even in the late phases, there are no polypoidal lesions seen. So here, ICG is not so useful for the treatment of this patient per se. And whereas when we look at this is at the presentation of this patient, and this is after only pharmacotherapy without any PDT or ICG angiography at the outset when the patient presented. Whereas the next patient, the ICG is so invaluable in this patient. Patient was referred as he's one-eyed, and these many number of anti-VEGF injections have already been given to this patient, and it is not non-responder, and the subretinal fluid and a very large PED under the macula. These many number of anti-VEGFs have been given. So the ICG of this patient shows a very large PED under the fovea. There is a branching vascular network and polypoidal lesions, as you can see, within that large PED. And this patient initially, because one-eyed at that time, this is also pre-corona, so this patient was treated with a low fluence PDT and Lucentis combination, as he is one-eyed, and he had a drying of the macula at that time. Within 2 to 3 months, he developed again fluid at the macula, and vision is maintained at 6/9. So initially, we switched to aflibercept with a drying of the macula. Second, there is even flattening of the PED with 6 parts vision. And 2-3 months later, he came back. He lost to follow-up for 3 months. Again, there is a recurrence. So we want to know what's happening to this patient. With third aflibercept, there is a drying of the macula. But then at that moment, surprising to see that the temporal polypoidal lesions have gone. There's a new crop of polyp, isolated polyp, extrafoveal, and inferior to the fovea. So this is in fact a recurrence, a new recurrence of polypoidal lesion in this patient who had received over 8 months, low fluence PDT and then aflibercept. So we went ahead with focal laser to that isolated polypoidal lesion combined with aflibercept. After 3 months, we have again recurrence with intraretinal subretinal fluid, the PED is rising up. So vision has dropped to 618 in the only seeing eye. So this patient, we again ICG, what's happening to the patient? He's not a real non-responder, he's responding, but then after 3 to 4 months, somehow, so when we look at the ICG, is again helpful. We see that it's not the temporal polyp, not the inferior polyp. He has a new crop of polyp on the nasal side of that large PED, which was there in the beginning. So at this moment, we had to do a standard fluence PDT in combination with aflibercept. Here, then we get a remission for the next 1.5 years in this patient with 6/9 vision is maintained. So just to recap, he had an initial temporal polypoidal lesion and the PDT was aimed only to the polypoidal lesions, not to the entire PED. And then a drying of the macula as second recurrence with 4 injections of aflibercept and focal laser to the new inferior polypoidal lesion. And now we have another fluid and or exacerbation where we had to do standard fluence PDT. So in this patient, when we look at the timeline, 2-year timeline, we see that there's a recurrence. We know that 8% recurrence of new polypoidal lesions. That is a particularity of this disease. Unlike a typical type 1 or type 2 CNVM, we have new polyps that is developing or recurring over the 2 to 3 year time frame. So in this particular patient, ICG angiography is invaluable in picking the diagnosis and guiding the treatment, whether it is PDT or focal laser or planning the treatment. It's not a non-responder to anti-VEGF. So I summarize that multimodal imaging is the way to go in PCV diagnosis and to differentiate from the mimickers, even on ICG angiography that we discussed. ICGA is the gold standard in PCV diagnosis, and especially we saw it's invaluable in anti-VEGF suboptimal responders and when planning a focal laser or photodynamic therapy. We know that I think the next Dinesh sir would be elaborating on that OCT and on-fast OCT imaging gives almost 85 to 90% accuracy compared to the gold standard, that is ICG angiography. And OCT angiography, OCTA, is an evolving technique where BVN is well picked up as we saw, but the polyps being low flow lesions are ill-defined. It's an evolving technique. Maybe we have better machines and software in the near future. Thank you all for your kind attention.
Thank you, George, for so wonderfully eliciting the role of ICGA in this era of OCT and OCTA, where most of the people do say that they can do away with ICG angiography. So now let's hear from Dr. Dinesh Talwar how he can do and diagnose a polyp without doing an ICG angiography.
Thank you, Prashant. I'm not saying you can do without it. I'm saying what is the alternative methods of doing without it.
Exactly, sir.
So there's a little difference between the two. But the fact is that the focus, I mean, actually, if you look at it, the issue really is that there is a focus on polypoidal choroidal vasculopathy. And we want to be able to diagnose it, and we don't easily have the ICG. A lot of people don't have the SLO-based ICGs. And without that, the imaging quality is not good enough. So that is why this interest in non-ICGA based imaging. But before I go further, this is my disclaimer and my financial disclosure. Now, as you all know, polypoidal choroidal vasculopathy actually presents with this kind of large subretinal hemorrhages with the presence of orange-red nodules. As you see over here, there are multiple such orange nodules in this case, which are highly diagnostic, highly suggestive of PCV, but they're not diagnostic, since small PEDs without polyps can have a similar appearance sometimes. The important thing is that there is this large subretinal or sub-RPE hemorrhages, which are more than 4 disc diameter in size, which are again suggestive, highly suggestive of PCV. So clinically, you can make a diagnosis in many cases. On ICG, as George showed you, you can see these clusters of small lesions. which are hyperfluorescent nodules occurring in the early phases. And when these are combined with the presence of the orange-red nodules, you have a fairly characteristic diagnosis of a PCV. And the presence of branching vascular networks, now called branching neovascular networks, also combines to confirm your diagnosis, though they may not always be there. So on fluorescein angiography, what you would see is a late leakage from an unknown source, as you see in this case. When you do the ICG, you have a fairly close, you can see the vascular network and you can see the focal polyps. Normally, you use a combination of the focal hypercynosins with BVNs or pulsatile polyps or nodular appearance, the hypocynosine halo, the orange-red subretinal nodules, or massive submacular hemorrhage to make your diagnosis. And these combined with, so the combination of the BVNs and the polyps with all these, with one of these lesions confirms your diagnosis. And this is another case where you can see the same thing. You can see in the early phase and in the late phase, some of them are still showing stabilization. They're still there. This is another patient where you could see the vascular network in the early case. You see in the late phase, you can see the polypoidal lesions. And this helps you to make your diagnosis. But can we make our diagnosis without this characteristic picture, which George has shown you and also shown you some of the mimickers? And if actually you look at it, what did he use for the mimickers? Non-ICG techniques. Recently, there was a study in ophthalmology where Jamie Chuang, who does a lot of work on PCV, has formed a consensus group, and they found their diagnostic criteria for PCV. And I'm going to basically highlight those. So these criteria include 2 fundus fluorescein angiographic criteria and 7 OCT features. And they've not discussed OCT angio, but we'll just shortly discuss that also. Among the fundus photographic features, what I just showed you, the presence of large subretinal hemorrhage, which may be subretinal or sub-RP, more than 4 disc diameter in size. Orange nodules, as you see in this picture on this side, both are signs of PCV. When combined with these OCT pictures, and what are the OCT features? You have sharp peaked PED. These are the 7 features. Sub-RPE ring-like lesion, complex or multilobular PED, double layer sign, thick choroid with dilated halar layer vessels, the fluid compartment. And what you see here and what George was telling, this is an NFAS OCT complex RPE elevation where you can see this, the RPE area, and you can see what looks like the branching vascular network over here. These are characteristic features. Now let's discuss them in a little more detail. The double layer sign is what you see over here. You look carefully. This is an undulating RPE line separated from the Brooks membrane line underneath. And if you look carefully, there seems to be a faint line in between. This is actually what a branching vascular network looks like. And because this is below the level of the RPE, now it's believed that instead of calling it a branching vascular network, it should be called a branching neovascular network. This is a sharp peaked PED. You can see this is a vertically, one of these walls is vertically up, and second has a high angulation. In this case also, you can see the thick choroid with dilated hollow layer vessels, because of which the choriocapillaries gets attenuated. You can see this over here. And of course, in this case, again, you can see the SRF, or in this patient, you don't have the intraretinal fluid, but even if you have a little bit of intraretinal fluid, it's still within your diagnosis. The sharp PED, as I showed you, the sharp vertical incline greater than 70 degrees on one side, or thumb-like inverted V projections. That's what you see. Basically, what happens is that the height to base width ratio is more than 1. So these are very high lesions. Within this, if you look carefully, you will find a sub-RP ring-like lesion. That's a round structure. Here it's more oval. Hyporeflective in the center with a hyperreflective outline, and the intensity of that reflectivity varies. Now, this is another very characteristic lesion of PCV. In addition to that is the complex or multilobular PEDs, as you see here. It looks like an M. You can say actually it looks like McDonald's, or a multilobular PED, as you see over here. These are all characteristic signs of a PCV. Now, how effective are they in making the diagnosis? If you have these three most important major diagnostic features, that is the sub-RPE ring-like lesion, NFAS OCT complex RPE elevation, and the sharp peaked PD, your chances are that you're more or less certain that you're dealing with a PCV. If you look at the double layered sign, you can see it has a very high negative predictive value. So if you don't have a double layer sign, the chances are you're not dealing with a PCV, but sometimes you can have a double layer sign and yet it may not be a PCV. So the specificity is much lower. Again, the orange nodule has a very high positive predictive value, as you can see over here. And finally, it's not necessary to have fluid to be made to make the diagnosis. There could be a situation where the fluid is not there, you're still dealing with PCV. So basically, this sums up what all features you need to make your diagnosis of PCV. Now, what about OCT angiogram? And OCT angio, I mean, if you see this patient, you can see the branch neovascular network. That is easy to see, but I could not, frankly speaking, easily make out what are the polyps in this case. But so let's say a combination of the SD-OCT with OCT angio can probably give you as much information as an ICG. And if you combine this with ICG, you can take away all the mimickers also. Then you have virtually a great diagnostic ability. But if you don't have the ICG, you can still make your diagnosis with fair certainty. Since I thought maybe my machine is not as up to date, maybe a newer machine may do the work. So I asked Darius Schroff, whom I knew has a better machine, to send me his patient. So he marked out a patient with and you can see that branching vascular and neovascular network is very, very clear. But the polyps, well, he marked them out. I am not too sure whether they are there. It's one of those things which is, I am not very clear about making a diagnosis of polyps on the OCT angio. Maybe with time that will become better. What are the things that these non-ICG techniques don't do? See, the ICG, I did this, and then I did post-treatment ICG, and I could see that this lesion has disappeared. Complete resolution has occurred. I don't think I'd be able to pick that up on the OCT, not so clearly. What about this case? Now, if you see here, the polyp inactivation, which seems to be the new thing which people are interested in, that is based on fluid resolution. That requires an OCT. So the OCT is anyway picking up one part of it. But the regression part, it did not pick up as well. And you can see over here, complete regression of the polyps was much more easily picked up on an ICG. Some degree of the RPED can persist for quite some time, even when the actual polyps have disappeared. At the same time, would we have any problem using the OCT to make a differentiation from PCV? Just to show you two lesions which were of RAP. easily diagnosed. I don't think you would have any problem making this diagnosis. This is early RAP and this is a stage 3 RAP. And I think neither way, even though there's a PED, you would confuse this with a PCV lesion. Neither would you compare, even though this seems to be multilobular. This is very different from what this is a occult type 1 lesion, which you will not mistake for a PCV lesion. So it's quite obvious that with we have a viable option for presumptive diagnosis of PCV, which and not just presumptive, but fairly certain presumptive, with a combination of fundus photography, especially if the OCT, especially if it has EDI, because the choroidal thickness can pick up. If the choroidal thickness is high, again goes in favor of a PCV. OCT angio, along with that, can provide us a consistent diagnosis of PCV with the ability to follow up the response to treatment. The presence of all the 3 major criteria which I showed you achieved an area under curve of 0.9. That means 90% chance that you would be making the right diagnosis. The only problem was that the negative predictive value was a little low. So you can't use this to rule out PCV, but you can definitely use it to make the diagnosis. So ladies and gentlemen, judicious use of fundus photography, OCT, and OCT angio, if available, can significantly improve our diagnostic abilities and understanding of the pathophysiology of PCV, and consequently our ability to treat our patients more effectively, even if we do not have ICG with us. And we should not think that because we don't have ICG, we won't be able to make a diagnosis of PCV and we can't treat these patients effectively. Thank you very much, ladies and gentlemen.
Thank you, Talwar sir, for making us understand how we can do away with ICG angiography, at least in majority of the cases. Well, we have diagnosed the case of PCV, or call it a CNVM. Let us see how to manage it, and let us hear it from Dr. Nishikant Borse, my dear friend, a vitreoretinal surgeon from Mumbai, who has, to his credit, 1 or 2 Ray Spettler Award. Over to you, Nishi. Can't hear you, Nishi. Nishikant, we can't hear you.
Yeah. Can you hear me now?
Yeah.
Okay, so just to sum up what we have discussed till now, we know that PCV is a different subtype, and typically it's the type of AMD where you will find an absence of pigmentary changes, geographic atrophy, or drusen, but there is presence of sanguineous maculopathy. You can have a hemorrhage, and you can have a different types. You can have a hemorrhagic type, which is predominant. You can have an exudative type, or you can have a mixed type. And we know that ICG angiography is the gold standard. But is ICG angiography the main thing for us to diagnose? That's what very nicely has been covered by Dr. Dinesh Talwar. Now, what are the unmet needs when we come to treating PCV? Number 1, it is underdiagnosed. A lot of cases I have seen which have been presented as AMD plain are actually cases of PCV. So we have to really learn through the diagnostic criteria, and even in absence of ICGA, like Dr. Talwar said, we can really pick up PCVs very well. We also don't have a very long-term clinical trial data to evaluate how the recurrence rates comes in and what are the long-term visual outcomes that we can have. And we also don't have any predictive clinical or imaging biomarkers which will tell us what would be sort of response to the therapies that we have. Now, we know that how Dr. Talwar has nicely shown that ICG is important where we can pick up a polypoidal lesion well. OCT is very accessible and it can actually help us in diagnosing and also in follow-ups. And OCTA basically picks up BVN better than polyps. But like you said, a good color photograph or a good fundus examination with an OCT can give you diagnosis in most of the cases, and therefore we can avoid underdiagnosis of PCV in most of the cases. And the 4 characters that have shown a notched or a hemorrhagic PED, a sharply peaked PED, a PED notch or a multilobulated PED, or a hyperreflective ring under the PED, any 2 of these 4 characters should definitely point us more towards a PCV than a normal AMD that we are talking about. Now, coming to the management of PCV, we know that we have the medical management in form of either PDT, anti-VEGF, or focal laser if it is extrafoveal, or a combined PDT with anti-VEGFs, or we go to surgical if definitely we have a massive subretinal or a submacular hemorrhage. Now, there are two concepts that have always come in on treatment of IPCV. One is polyp inactivation and second is polyp regression. Now, what it means? In inactivation, it means that you can still see polyps on ICGA, but there is no fluid. And that is definitely seen when you do anti-VEGF monotherapy. And polyp regression means polyp cannot be seen on imaging after you treat it, and that can be achieved by either PDT or a combination of PDT with anti-VEGF. Now, mind you, these two terms basically came in with the two big studies that were done. One is the PLANET study and the Everest study. And we always feel that polyp regression will be a perfect goal for IPCV management for us. But let us see whether it is really an ideal goal. Now, this is the case where there's a polyp inactivation. Well, you can on ICGA, on the right, you can see the polyps are still present, but the fluid is going down. And this is a case of polyp regression, where on ICGA after PDT, you can see after the photocoagulation and the PDT, the polyps have disappeared, and so has the fluid. So there is a definitely difference between polyp inactivation and polyp regression. And we'll always feel that polyp regression is the main thing, but is it so? Let us just see what the evidence is at efficacy and economics point two. Now let's coming to evidence. Evidence with most of the studies has shown that vision gain is more important. Rather than focusing only on polyp regression, a visual gain should be our gain, and not necessarily a polyp regression is equal to visual gain. So you can have a polyp inactivation with much better visual gain, and therefore anti-VEGF monotherapy will be more favorable in treatment of visual outcomes coming better. Everest and laptop trials have shown that although PDT is more effective in polyp closure, even anti-VEGF therapy itself seems to be better in improving or preventing visual loss. And there is no evidence that links a polyp regression to the visual gains. And even the ease, efficacy, and economics of doing PDT points more towards anti-VEGF therapy. And now with PDT literally being not available for treatment at all, I think most of us are going to weigh more and more for anti-VEGF monotherapy. Now, when we go to anti-VEGF monotherapy, we know that we have four main molecules that are available at present. Those are the aflibercept, ranibizumab, the unlicensed bevacizumab, and brolucizumab, which are there. And we know that two of these molecules, aflibercept and brolucizumab, are longer acting and having better penetrability on more action on the RPE side, and therefore they are more sort of preferred in treatment of PCV. Now, the PLANET study, which was the study which was done on aflibercept, which was basically monotherapy aflibercept versus a rescue PDT for the aflibercept patient, showed that the aflibercept monotherapy itself had a fantastic visual acuity gain, and it gave a very good favorable visual gain and a very high rate of polyp inactivation. And what you can see that most of the patients did fantastically well with this, and about 80% of these people needed about 8 injections. Another 10 to 12% patients needed more than 8 injections, and just about fewer than 8 or about fewer than 10% people could do less than 8 injections. So definitely, even though visual improvement was good, the number of injections needed were pretty high. Now, what happened when they did a treat and extend in this? When you did a treat and extend, about 60% of these patients or 40% of the other arm patients with the PDT arm could achieve an interval up to more than 12 weeks. So you can see just about 40% of the cases can be taken both with a treat and extend regime with use of aflibercept for more than 12 weeks. So that still goes to a very high number of injections. And therefore, we have to start wondering whether the new anti-VEGF or brolucizumab could be one of the injection that can be one of the biggest molecule to meet the unmet needs in PCV management. Now, we know that brolucizumab has got a fantastic molar weight when it goes into the cavity. It has got a better penetrability. Therefore, you have a much concentrated anti-VEGF in a smaller dose, and that can go up to the deeper things. We have seen with Saocon area that it has gives a fantastic amount of fluid resolution in all AMD cases. But what happens when you see the subset of PCV in Hawk trial? Now, in a Hawk trial, there were about 89 Japanese patients, and there were about 59% of the Japanese patients who had PCV, which was based on ICG imaging. Now, when you compared the visual gain that happened with brolucizumab in patient, we found that the visual gain was fantastic, about 11.4 in the 6 milligram group and about 10.4 letters in the 3 milligram group. So you can see about 11 letter gain that came in that is on par with aflibercept when we gave them a Q12 dosing with brolucizumab. And what was more encouraging is that 76% of the eyes could be maintained on exclusively Q12. So a far cry from 40%, your rate reached nearly double, that is 76% of these eyes could be maintained on Q12 interval, and 68% of these eyes could be maintained on Q12 in up to week 96. So you can see that there's a huge jump in the number of people who can be maintained on Q12 and therefore having a lesser number of injections. Now, can you predict how many percent of the patients will remain on Q12? Well, you can definitely have a predictive value that if the first Q12 is successfully completed up to week 20, then about 93.5% of brolucizumab patients can be maintained on week Q12 up to week 48, and thereafter nearly again 90% can be maintained up to week 96. So you can see that a profound number of patients can we have on Q12. And mind you, we have not even tried treat and extend in this case because this is a new molecule. Now, it not only a number of lesser injection, it gives you a fantastic resolution in the mean CST values by fluid resolution that we know that there is a fantastic fluid resolution in these cases. And the PCV patients with presence of IRF or SRF are much fewer at week 96 when we are using brolucizumab vis-a-vis when you use aflibercept. Also with the sub-RP fluid, which we are so concerned of in some cases of PCV, also are better off with brolucizumab versus aflibercept. So in summary, a significant unmet need exists in PCV, and maybe brolucizumab can show us the way and meet with this unmet need in the future. About 76% of the brolucizumab 6 milligram patients were successfully maintained on exclusive 12 weekly dosing, and about 68% up to week 96. So you can just say about 70% or 75% of the patients can be maintained on 12-week plus injection interval. And of course, like every case of brolucizumab, you will always see an early and a fast resolution of fluid just because of the superior fluid resolution mechanism that comes with brolucizumab. I'll just end my talk with two cases. I don't have the long-term results of this patient. They have just started off. You can see this patient in the right eye, there is IPCV. The other eye was having a PDT with ranibizumab done. And just with one injection, you can see the fluid has gone, and even the sub-RP fluid has resolved. And you can see a fantastic picture coming in just after one injection of brolucizumab. The another patient was of a hemorrhagic IPCV. The left eye has been scarred. The right eye, which was the good eye, had a large hemorrhage. It was a 74-year-old male patient with a vision of about 660. And with a single shot of brolucizumab, you can see a large amount of hemorrhage has disappeared, and the patient has got back a 618 vision. Thank you. Thank you very much for your patient listening.
Thank you, Nishi, for taking us through these various studies and showing the potency and the utility of this new molecule, which is now available to us. Now let us continue with the various presentations, case presentations, and let us see how this molecule really helps us and to what extent. The first presenter is Dr. Srinivas Joshi, another young guy from our country who has pocketed just 2 or 3 Res Butler Award. Over to you, Srinivas.
Thank you so much, Prashant sir. Thank you, everyone. So I'll be presenting a few cases, our experiences. These are the recent cases which I'll be sharing. So once again, thank you the organizers, and thank you Novartis for this, including me in this meeting. And here I'll be presenting a few cases. So I have no financial disclosures. So this is the case one. If you see, this is a 62-year-old female left eye diminution of vision since 3 to 4 months, diagnosed as left eye PNB. And this is the naive case, received brolucizumab injection in this female. Now you can see here, this was the subretinal fluid which was there before, and now you can see definitely there is a complete resolution. And also you can see a small kind of pipette here that definitely also has reduced to certain extent. Now you can see the octa, the pre-injection octa here, the neovascular network, and definitely there is a decrease in the vascular network on the OCTA 6 weeks post-injection. So this is the another case, 84-year-old male diagnosed with left eye occult CNVM, received multiple injections in the past and received the brolucizumab because he was not responding. So now you can see the amount of SHREM, which we can see. I'm taking into different sections and comparing it with pre and post. Now you can see the SHREM has absolutely reduced in this. You don't see any SHREM here. And definitely if you can see similar kind here, and another picture, you can see the subretinal fluid has completely resolved as compared to the pre and the post injection, and the vision has improved from 624 to 6/9. So this is the another case diagnosed as right eye disciform scar and left eye occult CNVM, and he received a left eye brolucizumab. And again, at this section, you can see there is some amount of pipette with subretinal fluid, which we see here. And definitely you can see absolutely the fluid resolution. And you can see a large amount of subretinal fluid, which has completely resolved. And also this is the another section which shows that there is again, so throughout this section, so I moved on through this whole lesion for you to show that how it has responded, and the patient improved from 618 to 6/9 in this case. So this is the another case, left eye showed diminution of vision, received 2 injections in the left eye 2 years back and lost for follow-up. So left eye was CNVM complex with IRF, SRF, PED. You can see here, this is almost like a sketic kind of spaces here, which we call it as a chronic edema, or you can, some authors have even described it as a skete, the chronic sketic spaces, which are the degenerative spaces. But definitely you can see there is a very good improvement from the pre and the post. And this is 3 months, 3 weeks post injection, and still we do not see any amount of fluid in this case. Similarly, in this section also you can see the sketic spaces which were there not only in the outer nuclear layer but also in the inner nuclear layer, which has given a complete resolution, and the retina looks pretty much dry in this case. So this is the another case of chronic CSCR with secondary CNVM. And here you can see the height of the PED has also decreased pretty well. And now you can see this PED has almost resolved with the complete resolution of the subretinal fluid here. And this is the small PED with amount of fibrinous or the SHREM, which we can call it. So that has also completely resolved. So this is the 2 months follow-up, and the patient is still maintaining well in this case. So this is the another case, right eye diminution of vision and diagnosed as PCV. Now you can see here with what Dr. George was also showing it, a large amount of PED. You can see there is complete flattening of that PED. We don't see the PED at all. It looks like whether the patient had PED before or what. So this is the another section. You can see a large PED here. Again, it was completely resolved. And see the amount of the subretinal fluid which was there. And that also has completely resolved. And now you can see the height of the PED which was there has definitely decreased from what it was in the pre-injection phase. And surprisingly for me, the patient improved from 3/36 to 6/12 in this case. So this is the another case where we usually call, you can see the edema or the SRF above the scar, which was very resistant to the treatment. And this is the 2 months, there is a complete resolution of the SRF in this case. And if you see the octa also here, you can see this is the neovascular network. And now this is the pre-injection. Now you can see the post-injection. Definitely there is a substantial decrease in the vascular network in the octa as well. So this is the another case where we had done with ERMP and ILMP in 2016, and we thought, let's see how it behaves in the vitrectomized eyes, and we gave a brolucizumab that she was diagnosed as left eye occult CNVM. And now you can see there were a few amount of intraretinal fluid which has definitely resolved, And here also you can see that there's a complete resolution and there's a drying effect in this patient as well, who has developed a CNVM. So this is the pre-injection vascular network, and here you can see this the post-injection. Definitely there is decrease in the vascular net. So we could see excellent visions, and it has maintained well for nearly 4 months in the vitrectomized eye as well. So these are last two of my cases diagnosed to have right eye peripapillary CNVM, and now you can see this was the lesion here, and definitely you can see there is decrease in the height of the retinal thickness in the peripapillary area, and what the SHREM we had here had definitely decreased in this case. And the patient symptomatically had reduced scotoma, is what they say. And this is another case, right eye diminution of vision. Right eye BCVA was 618 and left eye was 69. And now you can see this was diagnosed as a PCV with a branching neovascular network. Here you can see the branching neovascular network there. And here you can see on the ICGA and corresponding sub-RP network and FIPET on OCT and the ICGA as well. So again, the patient had history of multiple injection in the past and received brolucizumab. And now you can see there is a complete resolution of SRF in 2 months post brolucizumab. Now patient showed up with recurrence and pre-injection, and now with 3 months, 3 weeks, the patient is still doing pretty well. So this is the another patient who received 5 injection of ranibizumab elsewhere, high myopia, and he is an orthopedic surgeon. And now you can see definitely what was there, the subretinal fluid which was there before is better. And also you can see there's definite improvement. This was the first time in the doctor himself telling that he had a better contrast sensitivity. And it is almost more than 4 months now, and he is still maintaining well. So the patient was very happy and significantly improved contrast, which he said he never experienced with the previous injections. So this was my last case diagnosed as right eye CNVM, and here you can see the interesting case. You can see the polyp in the OCT as well, and you can see the FFA and ICGA pictures, and these are the corresponding polyps on the ICG. You can see on the OCT as well. And this was the started on aflibercept 3 monthly doses, and this was the way injections the patient had received before. And OCTA definitely showed dead tree appearance of type 1 CNVM on Octa. And but the patient stopped responding to aflibercept one day. That is the 2 months post aflibercept, and that is when we shifted from brolucizumab to we shifted from aflibercept to brolucizumab, and definitely you can see there is not only resolution of subretinal fluid but also decrease in the height of the FIPET. Now this patient presented back after 3.5 months. So roughly you can say around 3 to 3.5 months, this patient had tolerated well with the brolucizumab. So with this, I would like to acknowledge our fellow, Dr. Rajeshri Salvi, who helped me in picking up these cases. And thank you very much for the patient listening. So to conclude, brolucizumab was proven efficacious in various pathologies in PCV, occult CNVM, myopic CNVM, PNV, chronic CNV, even with the MULPED, that is a multi-layered PED, and also in the vitrectomized eyes. So thank you very much for the patient listening.
Thank you, Srinivas. We have a lot much to discuss with you after the conclusion of the last talk, because with a single injection, you in all the 12 cases, you had a response and no further coming back of the fluid. We'll have that at the end of the discussion.
Something to do with Hubli. It has something to do with Hubli.
Yeah. So let's move with the last part of our presentation. That would be again an experience from the state of Karnataka by Dr. Ramesh Venkatesh. Let's see the Indian experience from Karnataka, Bangalore.
Yeah, thank you, Dr. Prashant. Are my slides visible?
Yes, of course.
Yeah, so let me directly jump to the cases. This is case number 1, where you have a peripapillary PCV in a high myopic patient. He's a 72-year-old male. He's a diabetic and a hypertensive with a visual acuity of 6/8 and pseudophakic 6/8 and 6/9 and pseudophakic in both the eyes. So this patient does not have much of the SRF or the IRF, but has massive exudation and presence of a tall PAD. We do the ICG for this patient, and here you can see the polyps which are being seen in the peripapillary region, superior to the disc and even on the temporal side as well. So this patient receives 3 loading doses of monthly injections of intravitreal brolucizumab. This is at the end of after the 3 injections, at the end of the 3rd month, where you can see that the height of the PED had reduced, the exudations had reduced as well. So we wanted to be very sure whether those polyps which were there have regressed or not. So we did the ICG for this patient, and you can very well see that the ICG showed there was almost a complete regression of the polyps which were there initially. So this is the pre-treatment ICGA and the post-treatment ICGA, which clearly shows that with loading doses of brolucizumab, you can achieve a complete regression of those polyps. Let's come to case number 2. This is a 78-year-old male, hypertensive. He basically comes for a cataract surgery in the left eye. And what we find is the visual acuity in the right eye is 6/12 and left eye 6/18, and diagnosis of a CNVM in the right eye and a few drusen's in the left eye. The right eye doesn't show much on clinical examination. Everything looks fine, but this is what you see on the OCT. You have a PED with the orangish pigment getting accumulated overlying it, but no SRF and IRF. And since this patient had come for the other eye surgery, we decided that let him undergo the left eye surgery first. And by the end of 1 month, you can see that this patient has actually developed the subretinal fluid and intraretinal fluid as well. And this patient gets treated with intravitreal brolucizumab. And this is at the end of 4 weeks, where you can see that the SRF had reduced. But what's interesting is at the end of 8 weeks, there is a recurrence of the subretinal fluid, and therefore this patient receives the 2nd dose of brolucizumab. Now, again, at the end of 1 month post the 2nd injection of brolucizumab, you can see that there is a complete regression or reduction in the SRF and the IRF. But again, at the end of 2 months after the 2nd injection, you can see there is a recurrence. And this is a pattern which we have seen very frequently, even at the end of 3rd injection, at 1 month regression or reduction, and at the end of 8 weeks, there is recurrence. And this is at the end of 1 month post 4th injection, and the other thing is awaited. So what we have been seeing is that when you treat with brolucizumab, the recurrences do happen, and they usually occur at the end of 8 weeks. This is let's go to case number 3. This is a 65-year-old male, left eye blurring of vision and a visual acuity of 6/9. On close examination, you can see that there is a focal collection of hard exudation just supranasal to the fovea. And this is what you see on the clinical presentation on the OCT, where you can see that there is a small PED, there is an overlying STREM over it, and there is a subretinal fluid as well. And this is the EDI scan. So what you can see on the EDI scan, you can see the pachyvessels and the pachychoroid and the PCN kind of a picture and the polyp as well. So this was the ICG which suggested that this patient is having a pachychoroid neovascularization with development of a single polyp as well. And this patient received the 1st injection of brolucizumab, and at the end of 2 months post-injection, you can see that there is a tall PD, but the subretinal fluid and the STREM had regressed nicely. Now, this is after the 2nd injection, that is 4 months after the presentation, and there was only the PD, but no SRF and IRF. So we decided that we'll observe this patient. And this is 5 months post-presentation. Those exudations which were present initially at presentation had regressed nicely. But on the OCT, you can see that there was a recurrence of the fluid. So we wanted to know what is causing the recurrence of the fluid. Is it that because of the pachychoroid epitheliopathy, the fluid is not regressing, or is it because of the reactivation of the PCN, which is causing this recurrence? And therefore, we wanted to do an ICG again and then see what is causing it. And we did not find anything new. So probably there was a recurrence from the pachychoroid neovascularization which was causing it. So this patient was again advised another injection of brolucizumab, and we are awaiting the results for this patient. Let's go to case number 4. This is a 70-year-old female who presented with decreased of vision in the right eye. The visual acuity in the right eye is 6/24, left eye is finger counting 2 meters. You can see the extensive exudation which is present at the posterior pole. And this is how the patient presented to us, where she had this degenerative CME kind of upper spaces. Then you have the subretinal fluid. But what's important is that when you go along the inferotemporal arcade, you can see this PED and probably a polyp which is sitting there as well. So we confirmed it with the presence of the ICG. The ICG definitely showed that there was a polyp along the inferotemporal arcade. This patient was treated with 3 intravitreal ranibizumab injections. And this is after the injections with ranibizumab where the visual acuity had improved to 6/18. But the patient was lost to follow-up for 3 years. And then she comes with more extensive exudation, pigmentation, and damage to the RP, and the visual acuity going down to 6/96. And what you can see here is the bridge arch-shaped SRF, which we frequently see in cases of fibrotic or chronic cases of CNV and PCVs. And this patient received brolucizumab 6 milligram in both the eyes. And this is exactly after 1 month where there was a total flattening of the subretinal fluid, which we had. And this effect has been maintained even at the end of 4 months post intravitreal brolucizumab injection. So to summarize my cases, basically are a couple of them being a treatment-naive PCVs, the third one being a pachychoroid neovascularization with a PCV, and the fourth being a case of already treated PCV, which where the treatment was switched from ranibizumab to brolucizumab. So till date, we have given somewhere around 112 brolucizumab injections, where the mean number of injections has been 1.8, ranging from 1 to 8. And the main cases have been neovascular AMD, and 8 of those cases have been PCV cases, and treatment naive being only in 13 cases, most of them being already treated cases. And what we found at our center is that we did not come across any complications of intraocular inflammation, vascular occlusions, or vasculitis. So to conclude, brolucizumab is considered safe. When I say safe, it is S for safe, A is affordable, faster acting, and effective as well. So thank you very much for your patience here.
Thank you. Thank you. So well, you presented all the cases. Its number is 113, correct?
Yes, yes, sir.
Great numbers. So can I request all the panelists to join us for the discussion, last part of it, and let's initiate the discussion. Lalit sir, are you with us?
Very, very absorbing webinar. If I may conclude one line for each of the presenters, you see, Kerobi started with unmet needs of neovascular ARMD, and you see, she rightly pointed out about the cost, visit, long duration, and intensive treatments required. There's no doubt about all these things, the unmet needs which we keep talking about. And here is the role of newer anti-VEGF agents which are coming up, something like brolucizumab or faricimab, or even the other molecule which is coming up. Then we came to this ICG, and ICG role today, because non-availability of PDT, our frequency of doing ICG has come down, primarily because we are not doing PDT, hence ICG as only diagnostic we're not doing. Then Dinesh talk about that was very relevant, because you see, with the ICG not being available at every place, OCT and fundus photograph, I think, are reasonably good enough. I would not say they will match 100% to that, but reasonably good enough to suspect, or with around 85-90% of accuracy. And that ophthalmology article, I think everybody should read about that. And then Nishikant Borse, presented about his Planet and Everest study, which always, they are rival studies which we keep fighting against each other. And honestly speaking, me per se is never happy with regression. Inactivation. It's always regression which is the ultimate game point. Otherwise, you will keep having recurrences in all these things. You see, because branching vascular network and the polyps, everything has to be included in the LSS, linear spot size. Otherwise, you will have recurrences. Although patient may be happy, the fluid has gone down, but you will require continued or longer period of treatment. Given the choice, although PDT is not available, given the choice, PDT plus anti-VEGF in my hands gives the best kind of results in these PCV patients. Then we had fantastic, 12 cases by Srinivas Joshi. And I have more or less mirror images of photographs which Srinivas showed, although less number of patients. But you see the fantastic effect of brolucizumab on, and Ramesh Venkatesh also, on RPE flattening, resolution of SRF, and resolution of sub-RP fluid. And this is one place where brolucizumab, overshadows other drugs once it comes to flattening of RP. You see a lot of photographs of Srinivas Joshi, you could not make out whether there was any RPD. And same was the case with the usually last patient which Ramesh Venkatesh showed. You could not imagine that such kind of sheatic cavity was collapsed absolutely. So that was the beauty of this newer molecule Rodsumab. I think from
One
this.
question for Ramesh. The last case that he showed, which was large cavity, which looked like a degenerative cavity, was there any vision improvement?
No, sir, there wasn't any vision improvement.
Unlikely.
From 696 to 660, that was the vision improvement.
So now the question, then the real question for you is, now this is going to come back. So would you now continue to treat every time the fluid comes back, knowing that that this is a degenerative cyst where vision?
So may I Dinesh comment? I had one lady, 82-year-old lady, who had similar presentation at Ramesh Venkatesh. So the patient vision didn't improve. Finger counting 2 meters remained 2 meter only. But patient perception, she said, I want another injection because my I don't know what she said. Chamak gaya, she said. In Hindi mein she said chamak gaya. So she in fact was forcing me to give another injection. Although I did not, and this patient still in a follow-up. Vision didn't improve, but this collapsed. And patient, this lady, 82 years, still wanting another injection for that.
Yeah, the question is, you didn't give it. Why didn't you give it?
Because there was no fluid. You see, the fluid was not there. When you see last follow-up, I saw her in September, the fluid was not there. Therefore, I didn't give. If the fluid had reoccurred, I would have very low threshold for giving because patient is demanding.
Very true, sir. Even in a degenerative cyst, we do see such a dramatic response of the fluid as well as the symptomatic relief to a patient is definitely there. There is no second thought to it.
Yes, symptomatic relief. You see, the patient used the word chamak gaya mera. That's all.
The thing is, we have to think about our ways of responding. We've been teaching people, degenerative cyst, no point treating. The fact is not so. Even patients who have scars with fluid, the fluid goes away. But unfortunately, it's not taught to them. It's not taught to the general public or the vitreoretinal surgeons that, look, this can respond to treatment. And the patient's visual clarity improves. That's why I was asking you.
You see, the beauty of Brodicimab is, you see, sometimes with huge PD, huge SRF, normalization of the OCT, absolute normal. You see, if temporary, absolute normal, you can't make out where was the RPD there.
So is now Brodicimab, so Lalit, is that now your first line drug for treatment of?
No, not yet. Enough confidence. You see, I'm still scared of IOIs and vasculitis. And you see, but I hear Ramesh Venkatesh and
16 cases. No.
Yeah, and they have high volume of cases. And you see, Disha has done more than 800 cases. So slowly and gradually, the confidence is building up.
So Ramesh, for you, is that now the first line drug?
Yeah, first line for PCV and type 1 CNVM, sir.
Okay.
Type 1
See, even in my talk, I concluded based on 22 patients which I have done. So maybe Brodicimab is drug of choice where you have RPED, symptomatic RPED, type 1 kind of membranes, and PCV. These are the 3-4 indications where Brodicimab may become drug of first choice.
Yeah, Ramesh, one comment on your last two cases. One was actually when you repeated after the second injection, 3rd month, you found that the ICG, the polyp was still leaking. And that was a source of your recurrence of fluid. That means that polyp is not regressed or inactivated. There is no other reason for that fluid. It's not polyp inactivation or polyp regression. And your last case had an extramacular for PCV. Why didn't you do a focal laser to that? That would have ended the matter. I would not inject Brolucizumab or even Avastin.
The Brolucizumab was for the bridge arch shape of the degenerative fluid which was there. So
yeah, but then you have, when you do an ICG and you see a polypoidal lesion sitting there around, I don't know, how many 1,000 microns away from the,
Dr. George, I had actually done the focal laser at the first instance itself when we gave those 3 injections of ranibizumab to that patient.
I agree, Ramesh, with George that I also would have tried, laser in that patient.
Yes, I agree. I have already done the focal laser to that patient when the injection ranibizumab was given.
Yeah.
If I can make a comment, Lalit, Dinesh mentioned something about, the visual acuity gain not being there. Why do you want to repeat it? But in some of these patients, you find that the definition and clarity is definitely slightly more than what they started off with, when even though the visual gain may not be there. And
That's what Prashant said. That's what Prashant said. You see, we may not objectivize the, on scenario visual acuity that patient has gained, but
Exactly.
patient does feel better symptomatically.
Yes, and even the fibrotic ones, you find that there is some degree of visual impairment even in those cases, where earlier we used to think that these are like, defunct cases, they won't improve anymore, We've
Better
seen.
realized by the only eyed patients.
Yes.
So regarding the duration, Srinivas had no recurrence after single injection in all his 12 cases.
No.
Follow-up is about 2 to 3 months.
I don't think so.
Let me complete.
Srinivas can't claim this.
He selected the best 12 ones.
Never I mentioned
and Dr.
that you can go back.
Venkatesh said his average duration is 8 weeks. So let us discuss what is the average duration, because that is what the longevity
Sir,
of the durability we are
in my
talking
set
about.
of cases, it is minimum 1.5 months to maximum 5 months I have seen.
Okay.
And that which I showed was a surgeon, orthopedic surgeon. And I have been following it up. It is nearly more than 4.5, nearing 5 months. And he's taking up OCT in our peripheral center, and he still is dry. So the maximum duration we have seen is of around 5 months. And the minimum I have seen, see, in one patient, I had seen earlier 3.5. Later on, it became 3 months. Now 2.5. Now she is responding only 2 months. So every 2 months, she is having recurrence.
Okay.
So all set of cases and examples we are seeing.
My question is, like, would you give first injection and the next injection at 2 months and then next one at 3 months, or how do you follow? You go for monthly injections?
Sir, I don't follow monthly, especially in cases of Paginax or brolucizumab. I go in for the PRN because naive cases I have just started doing it. We have crossed around 180 cases now on brolucizumab. And earlier we used to give in all the resistant cases. But gathering, as Dr. Lalit sir said, he needs some courage, and Ramesh also showed his case of 112. I think now it is showing a good safety and efficacious both, sir, because in our 180 cases, it has been doing pretty well. So I think that gives a confidence to start on the naive cases. And since I've been doing it on a naive cases, but still I'm doing on a PRN basis, sir, coming to your question. I'm not following a monthly basis.
Even
So you give the first injection, wait for the recurrence to happen, and then when it happens at 3 months or 4 months or 5 months, then you give your second dose.
Yes, sir. I study both the OCT as well as OCTA, and provided the OCTA, the vascular network increases, I still ask them if there is no activity even on the OCT, and the OCTA network is increased. When I ask them, when they say that symptomatically I'm better, but I keep a threshold of at least 3 months. And more than 3 months, if it is increasing on the vascular network, I try to re-inject in these cases.
Prashant, till now, most of us were giving aflibercept in patients of PCV whenever we had monotherapy option, since PDT is not available. So question to Ramesh, Srinivas and other panelists is, do we shift now to brolucizumab? Ramesh and Srinivas, because you have high volumes.
Ramesh, you can go first.
Yeah. So I give the option of both actually to the patient. Aflibercept and
What is your choice? What is your choice?
My choice would be both. I wouldn't say, because aflibercept, because tried and tested. Okay.
That's a difficult question on this panel.
Yeah, because I'll tell you the reason. Because that's a tried and tested product, aflibercept, well proven. Okay, and brolucizumab acting efficacious, getting the PED flatter, showing regression of the polyps as well, and the PED flattening of the PED. So I say both.
But you just said that your drug of first choice for type 1 CNV is brolucizumab.
Yeah.
PCV is type 1 CNV, no?
Exactly, sir. But that type 1 CN means in comparison to ranibizumab, means I don't give the option of ranibizumab ever to the patient now. Where
No, my question was, Dinesh, between aflibercept and
but that's what I asked. What's the first line drug? So I was told from brolucizumab. I was
so let me candidly admit, you see, my choice has now shifted.
Sir, have Lalit sir, we have other panelists as well. We should take their opinion as well. We have had enough talk with this.
Let's ask
Dr. Dr. Somnath, what do they think about it? Let's have their opinion as well, Doctor.
Yes, Dries.
RP
I
Singh,
don't
sir.
have too much experience with it, so I wouldn't like to comment. But yes, the drying effect of brolucizumab is really fantastic. So I think we'll be inspired by Ramesh and Srinivas today, and I think encouraged to use it more, especially in type 1 CNVMs and these large areas. And the other comment I think is well taken, that this large cystic spaces or degenerative cystic patient definitely feels that the scotoma is gone. So I think
Yes,
it's well
yes.
worth trying it out in these cases also.
Somnath,
We have
Dr.
Colonel
Somnath.
Mishra also with us, who is in a government setup, R&R. I think
We
he
can't
must
see,
be a
we
high
can't
volume
see
surgeon.
Colonel Mishra नहीं है यहाँ पे.
अच्छा,
Somnath is here. Somnath is here.
Good evening, sir. Sir, regarding your question, I actually would like to answer that. There's a unique situation in my setup. I practice in a small town. Actually, I never had patients who could afford aflibercept, these 3 loading doses, and previously it was very expensive. Now they have come with all sorts of schemes, but still it works out quite expensive. The cost effectiveness of going with single dose and then PRN that we can achieve with brolucizumab has made in my setup brolucizumab now the drug of choice for all wet AMD and PCV cases. And like Dr. Venkatesh and Dr. Joshi, I now have experience in 100+ cases. I have one case of IOI, but that was in an off-label use in a vein occlusion case. And the IOI incidentally happened 9 weeks after the injection. That was only one injection, because in my experience also, I'm seeing that not only the effect sustains till around 8 to 10 weeks. So I invariably, in my practice, have now counseled patients that you can expect one injection every 3 months. So that is how it becomes cost effective for my patients. And that is probably one of the reasons why brolucizumab has been steadily increasing. Acceptance of this drug has been increasing even in my peripheral center. I practice in a, like a tier 2.
If they reduce the price, the usage of brolucizumab will increase.
Yes,
But he scored my sentiments exactly for tier 2 cities and tier 3 cities.
Yeah.
Unlike people who are seated in Delhi and all, it becomes an economically viable option, and that's why it's a procedure of choice or a drug of choice, at least for us in economically backward zones.
So Prashant, I think we have jumped the time, and we have jumped the time, and you see people are after life to conclude this. So I think let's thank all the speakers and the panelists for a great discussion, and hopefully prices of brolucizumab, as Prashant was saying, should come down so as we double our usage of brolucizumab.
Thank you.
So I think
Thank you,
sir. Everybody.
So may I just request all of you to just smile, and so that we can just take a picture. All of you can just keep their cameras on for like a minute.
श्वेता, ये आर्टिफिशियल स्माइल कब तक चलेगा?
नहीं सर, बिल्कुल आर्टिफिशियल नहीं है.
Okay, take a picture.
Thank you so much, sir. With this, I would like to conclude for the day.
Thank you, Prashant, Ramesh, Srinivas. Had a nice discussion. Very nice.
Prashant.
Thank you. Bye-bye, ma'am.
Bye-bye.
Thank you so much, sir.
Missed you during the discussion. Bye-bye.